सभी आ लाइए।
I welcome everybody. You all. So I welcome you all to the Global Neuro-ophthalmology Case Festival. This is the day 2. At the outset, I'd like to invite Dr. Satyakarna. Just a minute. Just a minute. Just having a problem with my share. Yeah, just a minute. Yeah, so this is the day 2. We are going to be discussing efferent systems. Yesterday has been a terrific day and excellent speakers with very good discussions and an audience of more than 2,200. And we hope to replicate the same thing today. But to start with, I'd like to introduce Dr. Satyakarna. He's been the main person who's got all of us together and been able to put this terrific feast. He's the Associate Director of Ophthalmology at the JP Hospital, Noida. He's one of the pioneers of neuro-ophthalmology in our country and has done a lot of post-graduation in neuro-ophthalmology training at Shankar Nethralaya, Chennai. He's authored Shankar Nethralaya Atlas of Neuro-ophthalmology, 2 editions, the step-by-step neuro-ophthalmology examination and diagnosis. He's a specialty reviewer to Indian Journal of Ophthalmology and the Joint Secretary of our Indian Neuro-ophthalmology Society, INOS. His special interests are neuro-ophthalmology, cataract, LASIK, glaucoma, and networking. And I just invite him to introduce today's schedule. Dr. Satya, you'll have to unmute yourself.
Yeah, fine. Got it. Here I go. So let me introduce Dr. Jyoti Matalia. She is the head of pediatric ophthalmology, strabismus, and neuro-ophthalmology at Narayan Nethralaya 2, Bangalore, India. Her areas of interest include pediatric cataract, neuro-ophthalmology, and teaching is her passion. Dr. Matalia is a volunteer faculty of Orbis International as well. She underwent fellowship training from LV Prasad Eye Institute, Hyderabad, India, and completed her ICO fellowship at the Wilmer Eye Institute, US. She has more than 45 publications in peer-reviewed journals, and she has presented at conferences in India and abroad and made several award-winning teaching videos in AAO and ESCRS. Over to you, Jyoti.
Thank you, Dr. Satyakarna. So we start with today's session. This is a session 1, and I've called it as O-No of neuro-ophthalmology, the acronym for the various cases that will be presented. I first present to you our panelists, which are all from India, and we'll be trying to talk about each of them, and then they will be introducing the speakers. And this is our list of speakers for today. So first is Dr. Jitendra Jethani. He's a director of Baroda Children's Eye Care and Squint Center. He did his post-graduation from Ahmedabad and was a fellow of National Board at the Arvind Eye Hospital, Madurai. He did his short-term fellowship, that is the ICO fellowship, from the University of Wisconsin, Madison. He's currently the director of Baroda Children's Eye Care and Squint Center, which is one of the largest and a well-equipped pediatric ophthalmology center in the state of Gujarat. He has won many national and international awards, and he has about 52 publications in peer-reviewed index journals and presented more than 120 lectures. Then we have Dr. R. Muralidhar from the Eye Foundation, Coimbatore. He did his graduation from JIPMER and then his ophthalmology training from AIMS. He did his specialty training in strabismus, glaucoma, and neuro-ophthalmology from the same institute, and then worked in Shankar Nethralaya, Chennai and Arvind Eye Hospital as a senior consultant in pediatric ophthalmology and neuro-ophthalmology. He also received the fellowship training in glaucoma and pediatric ophthalmology from Modern Eye Center and New York Eye and Ear Infirmary. He currently heads the Department of Pediatric Ophthalmology and Neuro-ophthalmology at Eye Foundation, Coimbatore. And he has many publications in national and international journals and conducted many instruction courses in various conferences. And finally, we have Dr. Digvijay Singh. He's a director of Noble Eye Care, Gurugram, and also attached to multiple hospitals in Gurugram and New Delhi. He has a special interest in neuro-ophthalmology, strabismus, and pediatric ophthalmology, and also glaucoma. He has about 20 awards, 75 publications, 20 book chapters, 1 book and 60 abstracts to his credit. He has delivered over 100 lectures in various national and international conferences, great interest in technology, and has done multiple innovations as mentioned here, and is presently the president, YOSI, which is the Young Ophthalmology Society of India, and also the treasurer of our INOS Society. So I then welcome all of you and Dr. Jitendra to introduce the first speaker.
You have to stop sharing the screen. Okay. Okay, thank you. Thank you, Jyoti. And I have been given the honor to introduce Associate Professor Dr. Siria Chen. And she is an associate professor and consultant neuro-ophthalmologist and a clinician scientist at Flinders University. She completed her prestigious neuro-ophthalmology fellowship at Wilmer Eye Institute, John Hopkins Hospital. She is currently the president of Neuro-Ophthalmic Society of Australia and has over 90 peer-reviewed papers in leading journals with contributions including committee roles at national and international conferences. With an excellent research record, she is a recipient of both national and international scholarship awards, including American Australian Education Fellowship, South Australian Science Excellence Award, Asia Pacific Academy of Ophthalmology Achievement Award. We are honored that she has joined us. She would be presenting a case. Dr. Murli.
Hello, everyone. Thank you very, very much. And it's my great pleasure to be here. Now, I'm going to, we're moving from afferent to efferent today. So I'm going to start a case with a motility case, and I'll welcome the panel to make comments. I'm going to talk about a case of variable ptosis and ophthalmoparisis. This is a 65-year-old man. He's a lawyer, so alarm bells start ringing. And I also get very worried whenever someone's referred to me for a fourth opinion. So they've actually been around town already and seen many people. And it's because he's been getting droopy eyelid and intermittent double vision for the last 14 years. What happens is that he had a history of ependymoma of the fourth ventricle that was treated with neurosurgery, with a shunt, and then followed by radiotherapy. Past history also include postural hypotension, Bell's palsy, and a hearing loss, which is thought to be due to an unrelated cause that happened only about 2 years ago. He's currently not on any medication, but previously he was on Dilantin soon after the neurosurgery, and also Mastinol, which I'll explain. So the double vision really started about 14 years ago, 2 years after his neurosurgery. He noted double vision when he was reading, so that was problematic to him as a lawyer who has to read a lot. And he described that he could see the images sometimes horizontal, sometimes vertical. And because it only happened when he was reading, when he was tired. So at that time, he was diagnosed as convergence insufficiency. 3 years followed, and it was just that double vision on and off. But then the eyelid started drooping. So at that point, he was then referred to a neurologist. And the neurologist had written a letter back to the general practitioner to say eye movements were normal. The neurologist couldn't find any double vision. It was completely normal eye exam. And this was sort of towards 1999 at that stage. So they did a CT scan. We can see a shunt in situ. But other than that, there were no other findings. It's quite impressive. He come in with the big packet of X-ray. So it's a matter of sort of going through all his various scans throughout the years. Now, the third neurology opinion came on, because at that time, he then started having trouble. Being a big Australian guy, he loves his steak, and he found that he cannot chew a steak anymore. Every time when he eats, he starts getting spasm. So because of that muscle weakness, at that point with the double vision and intermittent droopy eyelid, he was questioned whether he's got Myasthenia gravis. He had a CT of the thymus, acetylcholine receptor antibody, they were all negative. But at that point, the neurologist thought, well, we got nothing to lose, tried mestinon and prednisolone. When he was on prednisolone, he thought he was feeling better. However, there was absolutely no change to his symptom. So after 9 months, the medications were stopped. Okay, and I think the panel probably, and you know, in all the meetings, we've talked about Myasthenia gravis being a masquerader, and it is quite common. A lot of people have a trial of the medication. And so I started looking at all his packet of films, and at that point, the third neurologist did an MRI scan, went through the films, definitely couldn't see anything abnormal. Okay, and by the time I saw him, vision was 6 on 6 in the right, 6 on 7.5 in the left, color vision were fine, pupil were normal. And he did have a left ptosis, so I'll show you a picture of that. And there was an enhancement of ptosis. So you lift up the left eyelid, the right eye droop down. His eye movement, and I'll show you. Cranial nerve, he's actually got decreased sensation in all 3 divisions of the trigeminal nerve on the left side, associated with the left side of facial weakness. And then he's got a right side hearing aid. Slit lamp examination, completely normal. And this is his motility. So we can see that left ptosis, which enhances. The left eye cannot adduct. The left eye has trouble elevating and depressing, but similarly also the right eye. So I'll let everybody sort of pause for a minute here, and I'll now invite the panel to comment. At this point, has anyone got any ideas? Okay, no, all right, I'll keep on going. Now, watch that lead. So I was talking with him and I was examining him in a various position of gaze without touching him, without doing anything. All of a sudden, this happened. What do people think? And I swear I didn't touch him. I didn't do any funny movement or inject anything into him.
Is it a Kogan's lid twitch sign?
No, there was no Kogan's lid twitch sign. Very good, good
Not
point.
an eye test either?
No, I didn't do an eye test.
As I
said, I didn't touch him. At this point, I was still just examining him.
And
you had radiation therapy. Did the radiation
Yes.
therapy, do you know what the field was, if it included the midbrain?
Absolutely, and Neil's right onto it. The radiation therapy is the clue here. And what happens is that this is absolutely spontaneous. And when it is spontaneous, we start thinking, what's that radiation therapy got to do with everything? Because this all happened 2 years after his neurosurgery and radiation therapy. So, and we can all see that whenever we see double vision, we think neurological, neuromuscular, muscular. In this case, it doesn't fit any neurological pattern or maybe neuromuscular. So this is him 1 minute and the next minute. Okay, I'll go back again, 1 minute. And then literally without touching him, without any eyes test, without any periodal stiffening, this happens. Okay. And he was doing that several times as I was talking with him. And the reason that Neil's actually asking about radiation is because there is a condition, and we're going to review that very quickly, which is, and I'll just talk about a couple of the other associated findings. So very interestingly, while his eyelid were lifting, we also start seeing facial grimacing. Also what happens is that there was a facial contracture at the time. And remember, he at one stage was having jaw spasm. He was having a very pseudo-bulbar, very sort of high-pitched monotonous speech. And when he poked out his tongue, I mean, I'm an ophthalmology trained neuro-ophthalmologist. I don't usually do this, but I examined all his cranial nerves, and we definitely do notice that he's got an atrophic tongue. And the neurology colleague then helped me added that he's also got gait ataxia and limb dysmetria. And I see that we got Dr. Ampati here with us, who's a neurologist. So this is one time I got my neurology colleague to help me with a procedure. Does anyone want to hesitate to guess what it is?
EMG?
Very good, perfect. So the neurologist helped me to do an EMG of the orbicularis, but I personally was a bit shocked that I also could do an EMG of the tongue. And because he's got this very pseudo-bulbar speech, and it showed a neuromyotonic discharge with a short complex motor unit. So what happens to this gentleman is that he's actually got neuromyotonia. And as Neil was asking about the radiotherapy, it is rare, but it is quite well described. And in anyone with a history of with radiotherapy, always sort of have that at the back of our mind. What happens is that it causes a transient involuntary tonic contraction and then a delayed relaxation. And it can affect a single or multiple cranial nerve neuropathy. And it is when it's affecting the third cranial nerve, in this case, that's what's causing the ptosis and also the diplopia. And in his case, his second cranial nerve is normal, his third, fourth, and sixth were involved. Remember how he's got a very frozen orbit, almost this ophthalmoparisis pattern of both eyes. His fifth was involved. Remember how there was an involvement of sensation on all of the left side. He's also got the seventh nerve involvement and also the 10th and the 12th involvement causing that atrophic tongue. So definitely, I think that radiation was a whole brain radiation to get the fourth ventricle, and that's actually definitely causing quite a few damages, or should I say consequences. In this gentleman, it was trialed with carbamazepine, but if we look at the literature, unfortunately, various things are tried and they all have quite limited success. In his situation, he tried the carbamazepine, didn't work, and he thought, look, I've had this for 14 years, and he actually continued going on like this. And these are just some additional references on cranial neuromyotonia that I'll share with you, and I will now welcome any question. Thank you.
Yes, very interesting case.
I think it's interesting that the pupil wasn't involved in that case, as near as I could tell. I've seen some cases of third nerve involvement where there was actually a change in the size of the pupil at the same time that the lid came up and then came back down, the pupil would change.
Yes. And I wonder whether the bilateral involvement, because even though it was more on one side, whether that was what also skewed the pupil finding. But you're absolutely on the money, Neil. You told me everything I know. So, yeah.
Dr. Digvijay, anything you would want to ask?
Yeah, I was thinking whether, presence of orbicularis myokymia or kind of a twitch or something would have helped you in clinching the diagnosis further. I mean, if that's an earlier sign for something like this, or did you get that?
Yeah, I mean, I definitely didn't see any myokymia or muscle twitch. And as I say, what was alarming was that as I was testing his motility, then the eyelid just spontaneously shifts without. And as we say, we do see the contraction, the slow relaxation, but it's not a myokymia pattern. I think in this situation, definitely it's that variable ptosis that was quite interesting, almost like a seesaw pattern.
It's been, yes, Dr. Carmen. Yeah.
Celia, thanks for the interesting case. I think it was very interesting that it's bilateral because in Hong Kong, because of nasopharyngeal carcinoma, we have a few cases of ocular neuromyotonia, but it's usually unilateral. Most common is sixth nerve palsy, and second most common is third nerve. But I haven't actually seen I haven't actually seen a bilateral one before. So for those with sixth nerve palsy, it's easier because what some of them benefit from carbamazepine, but those who don't want to take it, I find that you can actually ask them to avoid doing the precipitating eye movement, because it's usually precipitated by, for example, right-sided sixth nerve palsy. It can be precipitated by looking in that direction. So by asking the patients to use a head posture to compensate for that, usually they can avoid precipitating the symptoms.
So they start looking very cool, looking to one side.
They're looking to one side or turning their head. So instead of like using the eyes to adopt an eccentric gaze.
Oh, thank you. Yeah.
I mean, indeed, rare case from that point of view, because we've been working a lot with the oncology departments at our multi-specialty hospitals, and there's a lot of radiation, and of course a lot of it is now focused radiation. It's not usually the whole brain for many cases, and so we don't see these very often. I've probably seen one where we're getting some myokimic symptoms early on, so maybe the patient would have progressed, but that time we kind of ignored that as the initial symptoms.
Yes, and I fully take what you say on board, because now they all do stereotactic fractionated. And again, whether or not this was because it was, back in about 1999 when they did it, and also because of the fourth ventricle location, I wonder whether because of the proximity, that's why there's that collateral damage with the multiple cranial nerve palsy.
There's one more question, Dr. Celia, I wanted to ask you. That is, could it have been Lambert-Eaton, the patient trying to, attempting to lift his ptotic lid up and then it goes up? I mean, Lambert-Eaton actually typically becomes better with attempted this thing. Of course, your EMG clinched the diagnosis, but would Lambert-Eaton be a differential? What would you say?
I must admit, I haven't thought about that. So that's a great question. Has anyone else in the panel or in the audience had the experience to help with the earlier diagnosis?
Can I say something?
Hi, Gordon. Yes.
Yeah. In Lambert-Eaton syndrome, ocular involvement is extremely unusual. It's recorded, but it's extremely unusual. And the only case I ever came across was presented in Ireland some years ago, about 40 years ago, and the case was lost to follow-up. So Lambert-Eaton syndrome tends to start, in fact, in the lower limbs. It has a lot of autonomic features as well. But if anyone has seen ocular involvement in Lambert-Eaton syndrome, then please speak up. I can just say that it's very rare.
Gordon, Lambert's first case actually had a little bit of ptosis, but you're absolutely right. The there's no usually any ophthalmoparasis. Maybe the saccades are a little slow on occasion, but I agree with you. And I think the really interesting thing is, I don't know what it's like in other countries, but we're in the United States, everything moves so quickly that this is one of those conditions like periodic alternating nystagmus, where if you don't watch the patient for a while, or you're spending all your time looking at the computer instead of the patient, you miss the diagnosis. And I was going to ask you, in your patient, what was the cycle time? Because these things vary significantly. It can be 2 or 3 minutes or 5 minutes between cycles. But I've seen some of them where they cycled about every, minute and a half or so, 2 minutes, and it drove the patients crazy, because the 1 second they would have diplopia and the next they had nothing, or they go from parisis to overaction. So they always have double vision. It's just a question of of the type. So sometimes they're esotropic, like with the 6. Sometimes they're esotropic, but sometimes they're exotropic.
While he was having the contraction, literally it happened while I was testing motility, and it was happening just about every 2 minutes. And I thought I was imagining it, and literally I had to take out the camera and literally snapping away. So you're absolutely right, and it's actually quite dramatic to watch how the eye movement can move so quickly. But only during that contraction and relaxation time, and then other times it's okay. So, really, that's why it's intermittent. And literally, it was kind of lucky to capture it.
I quite agree that we're seeing a lot less neuromyotonia because of more modern techniques in radiotherapy. I saw a patient recently who had pituitary irradiation done 30 years ago, which was a single shot. And she lives in Bristol, where they have a one of the best dental school in the country in Bristol. And she'd been attending their department for 15 years with difficulty chewing. Of course, she was sent to me because of undiagnosed ocular neuromyotonia. But she had on her MRI scan, she had one massive masseter muscle. And you just asked her to clench her teeth for a few minutes, then she couldn't open her mouth. So she had neuromyotonia of the masseter.
One question I wanted to ask the panelist. Apparently, it said that probably is the radiotherapy that can affect the myelin sheath, and vitamin B12 is having a good role. So do you think in the initial, like post radiotherapy, there's any role of giving vitamin B12 to probably prevent?
I think this is a channelopathy.
Okay.
I mean, myelin may have some part to play in it, but I think this is a channelopathy. And what happens in neuromyotonia is that you get a buildup of extracellular potassium, which is not being cleared. And that leads, after a certain amount of time, that leads to depolarization. And then you get this, repeated firing. That's why carbamazepine helps, because it treats the channelopathy of it.
Gordon, do you think that cyclic oculomotor parisis and spasm is another form of channelopathy? I mean, that would be the differential diagnosis in this type of thing. And I've never really, the only difference is that you go in ocular neuromyotonia, you generally go from spasm to normal. But in cyclic oculomotor parisis and spasm, you go from parisis to spasm. And I've always thought of them as as somewhat similar in terms of being a channelopathy, but I honestly don't know.
No, I think it could be. Of course, in the limbs, neuromyotonia and myokymia are very important neurophysiological markers of radiation damage to the brachial plexus. And neuromyotonia was originally distinguished from myotonia in patients with limb muscle involvement, where they showed that it was abolished by curare. So really, unfortunately, what they did was just add neuro to myotonia, which is very confusing for everyone. They just should have called it neurotonia and dropped the myotonia altogether. But, that's the way these things get named, isn't it? People just add something to the name that's already there. But it's a really important, well, again, we don't see it so much, but a brachial plexopathy in a patient with recurrent breast cancer, is it radiation damage or recurrence? Used to be a big thing, but now we don't see it so much. And of course, the imaging is so much better. But I think that these ocular cases often have a long wait to get a diagnosis because it's intermittent and people just don't think of it.
Is there any predilection for any muscle, ocular muscle involvement?
I don't think so. We wrote up a case of a fourth nerve. I think it depends where the radiation goes. The third nerve, of course, is the most dramatic. But I don't know. Neil, do you think it's any particular nerve? I mean, it's been reported in pretty well every nerve in the body.
I would say that I've seen more thirds than sixths, and way more thirds and sixths than fourths. But I really don't know. As was said, I think the third is the most dramatic. So that's the thing that's always talked about. The other issue is that not everybody with this condition has had radiation therapy. There have been a couple of cases after in the setting of thyroid disease. And so there are these strange cases that there was one, I think, that Bob Yee reported years ago after radioiodine for thyroid disease. So there are some strange ones where you can't, there's no history of radiation as there is in most cases.
No, there are. We reported in our series, there was one case, a third nerve case, that had a compressive lesion. It was an aneurysm, but that seems to be very rare. And one of the other cases, it was a fourth, was provoked by drinking alcohol.
I think we can move on to the next case. Sorry, we're already a little late.
Dr. Yee's case.
Okay.
Sorry, can you hear me okay? Yeah, Bob Yee's case wasn't radioactive iodine. It was a like matrizamide, some sort of iodine type.
That's Yep.
Imaging was for imaging the spinal thing, and it went up into the head, and they found it there. Thorotrast, I think, was the name of it, and it was found, by scanning 30 years later. They could see
that was in the days when we had CT, but we didn't have the contrast. So you'd put matrizamide in the CSF and scan.
Move them around
Thanks,
to get it to flow up. Sure.
Okay, so we can move on. Dr. Digvijay, you can introduce the next speaker. Digvijay, you'll have to unmute yourself.
Yeah, am I audible?
Yes, you can. You can speak. You can go ahead.
It's a great pleasure to introduce Dr. Clement Tan. I'm very eager to hear Sir's case. And I've had a pleasure of interacting with him in the past. And he is an associate professor and a consultant ophthalmologist at the National University Hospital in Singapore. He has a keen interest in neuro-ophthalmology and cataract surgery. And he has been he's been the cluster director for the National University Health Services there, as well as the head of the Department of Ophthalmology at the National University Hospital. He's been the director of the residency training in Singapore, and a lot of the students and a lot of our colleagues have been in touch with him for that in the past. And he's been a medical examiner for ophthalmology as well. And over to you, sir, your case. Thank you for being part of this session.
Thank you very much, Digvijay, for the very kind introduction. And once again, I think we need to acknowledge what a fantastic conference Satya and team have put together. I'd like to share with you a case that is still troubling me because the management of this patient is by no means over. This is a 59-year-old man with poorly controlled diabetes as evidenced by nephropathy, diabetic retinopathy, and he's had amputations to his toes, his feet. And he presented with a few-day history of left eye pain and blurring of vision. His visual acuity in that left eye when he pitched up at emergency department was counting fingers. He was in a very bad mood because he had pain. He yelled at the resident on duty. He had, from the pictures you can see, limited ocular motility in the left eye that seemed to be a combination of both a third as well as a sixth nerve palsy, but the pupil was smaller, and at that time it was thought it was a Horner's pupil. There was an afferent pupillary defect detected by looking at the fellow pupil, and there was a bit of proptosis of the left eye. Bloods done at emergency showed that he had a raised total white, and his blood sugars, his random blood sugars were really high. He, of course, went imaging, and at emergency, the quickest thing that you can get is a CT scan. And so these are his CT scans, and they show what looks like a what looks like a sinusitis that fills up the maxillary sinus somewhat, and also has involved the inferior orbit, and it looks like it's gone into the masseter space as well, right? So quite an extensive lesion, including the orbital, as you can see from here, the orbital apex down the inferior orbital fissure. I don't know if Dr. Veena wants to comment on this before I move on.
Dr. Veena?
Yeah. So basically, there is sinusitis on the left side, maxillary. There is wall erosion, and there is involvement of the orbit. So looking at this picture, the differential diagnosis, first considering that the patient is a diabetic, would be fungal. The second, we get patients like vaginous granulomatosis and an IgG4 disease.
Yes, thank you, Dr. Veena. So those were our initial considerations, and of course, what we did was we get the ENT surgeons go in, and this one quite quickly they had fungus inside the microscopy, and the cultures later showed this to be aspergillus. There was also some staphylococcal bacteria that were cultured from this. It's thought that it might have been a contaminant, but nonetheless, there were no vasculitic changes in the histology eventually. There was a non-necrotizing granuloma. There were CD20 and CD3 positive cells, but these just thought to be part of the inflammation. We thought also to check him for HIV. He was negative. The CSF showed raised protein, but not too many, but hardly any white blood cells. No fungus, bacteria, lymphoma was detected to it. So he was started on antifungals and antibiotics. He remained pretty unwell for a while. A second round of nasal toilet found candida. Coincidentally, we also did think of IgG4, and we sent that off. However, in the meantime, his vision declined, even though he was on treatment, to no perception of light. Ptosis went down, it became almost complete. The limitation of movements became worse, and at this time, the left pupil started getting larger as well. These were the MRI scans done, I think, just after the FES. And again, showing, much the same. The sinusitis is still somewhat there, and the orbit is also still involved. I don't know if Dr. Veena has any further comment on the MRI scans here.
Well, it's almost the same finding, except that the sinusitis, I think, has worsened. The orbit involvement also has increased a bit. Apart from that, I think there is nothing more to this.
Thank you, Dr. Veena.
I would look at I would like to look at the T2 weighted images also.
Okay. Sorry, I did not think to put all of them up. I shall remember that next time. Yeah. Okay. Thank you.
Clement, can I just ask you a question? Was
Sure.
it felt that this was too extensive to do radical surgery on? One of the things that always comes up in this setting, especially with aspergillus and mucor, is whether a major radical removal, exenteration, etc., by a team ENT and ophthalmology and plastics would cure this patient, save this patient's life.
Yeah, I think those were considered systemically. He wasn't doing too badly, although he was ill and he was vomiting and a bit nauseous a lot of the time. But you know, after a while, he started to pull through this a little bit, and so the infectious disease people thought, okay, we'll just keep plugging
I mean,
ahead.
he's got disease
with the infectious disease neurologist. Yes.
I mean, he's got disease along the temporal tip on the left, it looks like. And so I know it's spread, but I mean, I know that in our institution, there would be a big discussion about whether a major procedure would be curative.
Yes, I think especially if it's mucor, especially, I think there's usually a discussion about radical surgery. But for aspergillus, so I haven't really encountered big discussions on whether to whether anybody is eager to jump. Not yet, at least where I am. But well, he did start to get better, and he gradually improved. He completed about 2 months of voriconazole. He had 2 weeks of vancomycin, 2 months of voriconazole. His vision didn't come back, but his ptosis and his movements started to improve. However, and I'll show you on the next slide, the radiological imaging, he got worse. And we wanted to repeat the biopsy at that stage because there was a debate over whether this was IgG4, whether this was a tumor of some other sort, because you can see, as you can see in the next slide with the MRIs, there was maybe a bit more soft tissue density there. It was uncertain what he had at that point, but he was not quite fit for surgery at that point because of his blood sugars. And this is the repeat MRI at 5 months after treatment, after he had been off voriconazole for about 3 months. And you know, we all thought it looked to us that he was getting worse. And this is exactly where we are now, at this point, where he is looking like he is clinically better, but radiologically worse. And I think this is the point where I would like to pose to the panel for discussion. What would everybody do at this point in time? I'd like to take some guidance from everyone. What's the end point of treatment with the antifungals? Do we treat till it's neurologically, radiologically resolved? What do we do while we're waiting for him to be fit enough for a biopsy? Should we restart the antifungals? And if we have to biopsy this again, what's the best bet for a site for the biopsy? I put up the images for the panel to have a look at. I'm happy to take comment on this case.
Dr. Clement, was the diagnosis of a fungal invasion made on swab samples? Because just getting fungus on the swab doesn't necessarily prove it is fungal.
It was on the biopsy as well. It was on the biopsy as well. If you're right, it was on not just on the swab but also on the biopsy.
I think the best bet for a biopsy site would be the nasal sinus mucosa. The maxillary sinus mucosa can be. That's what I feel. And possibly, as Dr. Neil Miller has suggested, a radical surgery could have been planned. Of course, he's improving on voriconazole. There are case reports of this fungal sinusitis, invasive fungal sinusitis, improving on antifungal alone. Yes. I feel radiologically he's better, isn't he, Dr. Veena?
Yeah, that's what I was going to say. Considering the 5 months duration of the disease process, if it was mucor or something, I think it would have been far more worse. If you look at the sinus, I think they have cleared quite a bit, especially the maxillary and part of the ethmoid. The posterior ethmoid is still showing some kind of a residual sinusitis, but the orbit also does not show that much of a worsening. In fact, I would say that it's more or less stable. I don't think that there is much worsening on the scan.
Okay, well, that's comforting to know. We were all concerned because especially in the orbit towards the apex, it looked like it was more involvement further back where we can't really get to it?
In such cases, it's always better to keep the the scans in the serial order side by side. Then you can really appreciate the the change of the lesion over time.
Right.
One point I wanted to make here is when I discussed this case with our oculoplasty and orbit colleagues, they actually did mention like what Dr. Miller said, that that particular situation they would have gone in radically, and sugars is not their concern. They say that it's the last thing they worry about. It's easily to get them under control, but to probably salvage, save the patient's life is more important. But luckily what we have noticed, within 5 months, there has been a significant radiological and clinical improvement. But sugars is not something that does concern. They are able to manage it well. If it's the matter of the life of the patient, they'll just go in and able to manage them on insulin. So that's not their concern.
One of the real problems with aspergillus, unlike mucor, which it almost always is just rapidly progressive, aspergillus can be just, it can also be like that. It can absolutely mimic mucor, but often it's like this. It's just a slowly invasive process that keeps on going. And I'm not sure at this point that radical surgery would cure the patient, but I think that it's the only option you have, other than you could try local delivery of antifungals, but I'm not sure you're going to get all the way there. Right now, it doesn't look, as near as I can tell, from the axials, that the cavernous sinus is involved, but it will be soon at some point. So I think it may be too late. It may be the horse is out of the barn, but I don't know of anything else to do. The other point, as we made, Dr. Veena made yesterday, and we talked about, is that just because the MRI doesn't show much involvement of sinuses doesn't mean there isn't fungus in there.
Yep.
And a CT would be possibly helpful in terms of just what's going on. I noticed at the beginning, he had disease, maybe just polyps in his right maxillary sinus as well. So I don't know if that has anything to do with it.
Yes.
That is just a retention cyst.
Yeah, that's what I figured that was all it was.
Considering the improvement, can we just continue him on medical management? Considering that he has clinical improvement, some radiological stabilization, would at this point of time, any of the panel or Dr. Neil, would you recommend radical surgery at this point, considering his improvement, or would you just consider voriconazole?
Well, I think this is one of these things where you have to have a team approach. We presented at a conference and try to decide, because if you're going to do radical surgery, this is ENT, neurosurgery,
yes,
oculoplastics.
Yeah.
I mean, this is going to be a big procedure, and I'm not sure at the end how much you would achieve, especially in this guy with his other medical problems. So I think at this point, I just don't know. It may be too late, and I don't know what the patient. This is another one where the patient has to weigh in on whether this type of surgery would be something he'd be willing to tolerate.
There's a question from the audience, not audience, our panelist, Dr. Etzeling. He would like to know whether antifungals can be delivered via orbital catheter.
I've not heard of that, but that sounds so interesting.
Oh, they absolutely can be, Edsel, but the problem is you've got such diffuse disease that I'm not sure if it were just limited to the orbit, it might be possible. And we've done that. We've also done it with patients who had pure sinus disease, but I think this may be just too extensive to get.
Is there any role for hyperbaric oxygen?
We haven't tried it. We don't have a hyperbaric chamber at Hopkins, There's one at the University of Maryland in downtown Baltimore, but to my knowledge, we haven't used it, although there are reports that it helps.
Okay. Well, thank you, everyone. That's very helpful. Something to take back and discuss with the whole team and with the patient himself, and try harder with the antifungals.
Jyoti?
Yeah, we can go to the next case.
I just, if you don't mind, I would just take a short moment to, for those of you who remember Barry Cullen, he passed away on Tuesday evening. I just wanted to say a few words for him. Barry was a great teacher, a mentor, and a friend to many of us, and we're all going to miss him very much. He was often present at many of these meetings in Singapore, at least. I mean, we all owe him a great debt for setting up neuro-ophthalmology in Singapore. So rest in peace, Barry. We all miss you.
So we can ask Dr. Murli to introduce our final speaker.
Sorry, am I audible?
Yes.
It's my pride and pleasure to introduce Professor Dr. Umapati and Thirugyanam, Senior Consultant Neurologist at the Department of Neurology, National Neuroscience Institute, Singapore. It's a great pleasure to have you, sir. His subspecialty interests include neuromuscular disorders, electrophysiology, autonomic nervous system, eye movements, and neuroimmunology. Over to you, Dr. Umapati.
Okay, thank you very much. I'm going to just start sharing my screen. Okay, so thank you very much for the organizers for having me. Dr. Satya gave me a very simple task. He just asked me to confess. And since I'm a frequent sinner, confession is quite easy. And today is Sunday, which is in many traditions, it's a religious day. So let's start with some confessions. Please forgive me if my confessions are not appropriate. Okay, so I'm going to start off with a story. So this story started on a typical Wednesday afternoon, a hot, humid Singapore Saturday afternoon. Saturday afternoons are very special for my team because we have this unenviable task of going down to emergency department and clearing the backlog of hundreds of patients, not hundreds, but dozens of patients who are waiting to get into the hospital, but they don't have a bed yet. So I was there at about 4 p.m. with my resident. As we were approaching that whole row of patients that we had to see, my heart started sinking, seeing the number of patients we had to see. But the first patient was a young girl who was complaining of headaches. And she wasn't the best patient to see because she was a little bit belligerent, a little bit hesitant to talk to us or engage with us. And this was basically the chief complaint that was given to us. And so because she wasn't so keen to talk to us, I decided to peek into the emergency notes. And as you can see, these were some of the phrases that I plucked out of the emergency notes. So words like probably migraine, let's give her some analgesics, let's observe this pain that she's coming into the hospital for. And then subsequently, when the pain recurred again, they decided, let's get a CT head. And the CT head was normal. And then when the CT head was normal, they said, okay, let's admit neurology, because they couldn't figure out why the person was having headaches. So with that kind of story, I decided to, because as I said, there were lots of patients to be seen. So I just got on with the examination and found that she was actually quite normal examination. She was very well looking. She was afebrile, neck was supple, and a full neurological exam was normal. So I turned to my resident and said, you know, this is probably migraine. Come, let's go on to the next case. Let's start some treatment and go on to the next case. So at this point, my resident said, doctor, I think you want to hear this. Then I said, no, let's move on, man. There's another dozen cases to see. Let's not get stuck with this straightforward case. He says, no, doctor, you must listen to this. I was just going through the electronic records of a past medical history, and I managed to quickly get this out within the last few seconds while you were examining the patient. And so the story was that she had lupus since the age of 12, and this was complicated by severe nephritis, and the pediatricians, unable to cope with her teenage angst, have decided to transfer her over to the adult rheumatologist. So she was just starting to see the adult rheumatologist in the last 1 or 2 years. And recently she's been also referred to the renal physicians because the BP is very, very difficult to control. Kidney disease was getting worse. And just a few weeks ago, she was seen in the clinics where her steroids and immunosuppressants were ramped up. So when the resident told me this, this is what I often refer to in clinical moments. I would call this the still point of the turning world moment, when everything seems to stop in spite of the crowd around you. Everything seems to stop, and then you take a deep breath and your heart starts beating a little bit faster. So this kind of reminds me of a very important metacognition error that we always fall into, which is a framing bias. So the same story depends on how you frame it, comes to different sort of diagnosis, doesn't it? You saw it for yourself. So the same story could be very benign, or at the same time, if it's framed in a different way, it could be very sinister. You could say that just because she has lupus doesn't mean that every time she comes in with a trivial complaint, her trivial complaint will be magnified 1,000 times. On the other hand, the fact that she's got so many comorbidities means that you have to pay respect to them. So that's the reason why framing the question properly is very important. This is particularly important for headaches. Why? Because nowhere in medicine are you dealing with a disorder which is very unique in being a symptom. At the same time, it can be a disease. Now, you don't really face this in any other areas. If you have back pain, it's either back pain due to osteomyelitis of the spine, or prolapse intervertebral disc, or osteoarthritis of the spine, or something of that sort. There's no idiopathic recurrent back pain, but we have idiopathic recurrent headache, migraine. We have recurrent trigeminal pain, which is called trigeminal neuralgia. And there's nothing wrong with the patient, correct? So what is normally considered an alarm, pain is an alarm, that's supposed to ring only when there is pathology. But imagine you have a fire alarm in the house, and it rings occasionally when there's fire, but it also incessantly rings when there's no fire. So you, as the owner of the house, have to figure out when to pay attention to the fire, wake up and go look for the fire, or when to ignore it and turn it off. Because if you do it at the wrong time, you will be burned, literally, right? So this is exactly what is the problem that we have to deal with headache. But most of the time when we see patients with headache, we tend to use intuition and gut feeling, or something called clinical reasoning, which a lot of us tend to throw around, right? Without really understanding what it means. So very early in my career, I decided that headaches are going to give me lots of angst, lots of pain in my head. So I had to figure this out. So rather than having instinctive gut feeling, why can't we think of an underlying formula that allows you to get it right by design rather than by chance? So this is the basic formula that I use. I have 3 buckets of questions that I ask. What is the headache profile? Are there red flags? And what is the patient profile? Then I throw it into the black box, and then I see, do I need to treat it as a primary headache, or is it a symptom? Now, without talking too much theory, I'm going to apply this on our patient, because that's exactly what we did. When the still moment kind of became flurry again, my resident and I decided, okay, let's approach this patient again, but let's now use the formula. I was very thankful to my resident for stopping me. So I thanked him, and then after that, I went on to apply the formula. So let's apply the formula on this lady, okay? So first question, what is the headache profile? Well, she does have, in the last 2 years, headaches that could be consistent with migraine. So she does satisfy criteria for migraine in the past. Okay, now what about the current headache? Is there anything in that current headache that suggests that this is not migraine, but it's a symptom of underlying intra or extracranial pathology? Is there anything? Well, for that, I have a checklist. Like all checklists, you must have a fixed number of questions you must ask so that you don't forget. So I've got 5 questions that I asked. So let me go through that. So we asked this patient whether she has symptoms or signs of focal neurological deficit. She had none. Then we were asking, did you faint or did you become drowsy or anything of that sort? At that point, the patient just say, no. But At this point, the long-suffering mother who was standing by the side came up to us and said, Doctor, now that you mentioned this, actually what happened was yesterday, my husband and I heard a sound in the room, a loud thud. And then we walked into the room and we found her lying on the floor. And she was just awakening from being drowsy. So I think your question may be relevant because it looks like she may have fainted. So that was very important. And it only came out because we had a checklist. When we were going through that, the patient's mother heard that and came. If you don't have a checklist and we just ask history blindly, sometimes patients may not remember the same and some things, just like this case. She didn't mention to the emergency doctors that she fainted. Then we went on to ask for symptoms and signs of raised pressure. She didn't have any. And then we asked for constitutional symptoms. Again, the patient denied it. But the mother said, after she fainted, because of her previous illness, the mother is very careful with her. So she felt that the patient wasn't just right, So she decided to test the temperature and realized that she had borderline temperature, like 37.9, but nothing to write home about, just mild borderline temperature only. But in the emergency department, she was afebrile. She was 36.7. Then what about the character of headaches? Is it similar to her previous headaches? No, actually there was a change in character. Previously, it was one-sided throbbing headache. Now she had a generalized headache that was much more severe, and she listed it as 8 out of 10. Then the third bucket of questions that we normally ask is the patient profile. Here I already kind of alluded to it. It's important because what the patient, the background of the patient, the comorbidity of the patients either increases or reduces the possibility of this patient having a secondary cause for headache. So that's the reason why we need to contextualize the first two questions in the context of the patient's profile. So in this context, we realize that she's got quite a number of complications that could result in headache. So with that, we decided to throw it into the box. What is that box? It's that black box right in the middle. The black box, you throw the 3 sets of questions and you ask yourself, do I want to treat it as a primary headache or do I evaluate further for a secondary headache? But there's not one particular cause for secondary headache. So there's a common misconception that you do a CT head and everything is done. But actually, a CT head will be normal in meningitis, correct? So therefore, you need to decide what is the possible causes. And then the next question is, what is the probability? And depending on the probability, you choose the most sensitive or more specific test. So in this case, we decided that because of uncontrolled hypertension and lupus, a hypertensive emergency like posterior reversible encephalopathy syndrome is very important to consider, even though she didn't have papilledema. Because she was nephrotic, she had loss of very high proteinuria, she was procoagulant. And plus the dysimmune features make her more likely to have coagulopathy. So we were considering cerebrovenous thrombosis. So we thought breast and cerebrovenous thrombosis are very important to consider. And we labeled and we graded or ranked the probability as high to moderate. A pre-test probability of her having a CVT or breast, we thought was fairly high. Because it's fairly high, we felt that the CT scan wasn't good enough, correct? So we needed something much more specific. So we ordered the MRI, an MRI flare, which will show up the changes of breath, and MRV. Now, then what about that low-grade temperature? My resident was saying, no, doctor, but she's got no neck stiffness. She looks so well. She doesn't look like she's meningitis. But remember, she's on immunosuppressants. So because she's on immunosuppressants, I was telling my resident, we have to be thankful that she had a low-grade fever. We have to be grateful that she at least manifested a low-grade fever. So we cannot dismiss meningitis, but we agree that the index of suspicion for meningitis is not super high for me to do a spinal tap in emergency department. And I don't think it was high enough for me to start antibiotics, but we cannot dismiss it. So what do? When something is of low or moderate probability, we screen with a simple test. What's a simple test? ESR, CRP, and procalcitonin. We decided to do that. And if that was high, we would pursue it further. Now, in terms of subarachnoid hemorrhage, with the CT scan being normal, we thought it was less likely, but it was 2 days into the symptoms. So we still thought it's possible, less likely, possible, but we knew that our MRI sequence will have an MRI GRE sequence, which will show up the blood anyway. And nevertheless, we thought about doing a spinal tap and xanthochromia if all other causes were ruled out. So what do? We ordered the ESR, CRP, procal. We ordered the MRI with all these special sequences and went on to see the other patients. A few hours later, maybe 1 hour later, I got a call from the nurse saying that the patient's CRP, procal, and ESR was very high. So with that, we immediately started on meningitic doses of antibiotics. And we were planning to do a spinal tap once she gets into our ward. In the next few hours, she went down to the radiology department and got a scan. And guess what the scan showed? Actually, it was quite surprising. It was not one of the diagnoses that I considered, but I should have considered. This scan actually shows multiple DWI changes consistent with infarctions. But more importantly, remember she's only 21 years old. The vascular abnormalities in the MRAs, there were multiple corrugated appearance, multiple areas of stenosis suggestive of vasculitis. So she didn't have cerebrovenous thrombosis, she didn't have press, but luckily the scan was good enough to pick up one of the diagnoses I didn't consider, I should have considered because of a lupus and a progressive renal disease, but she has CNS vasculitis. So we immediately brought her into the ward, started on pulse methylprednisolone, and called the rheumatologist, and the next morning she was started on cyclophosphamide. And so what were the errors in this patient? First and foremost, gut feeling. You know, using your gut feeling, the patient looks well. Yes, good that the patient is well. We want to see the patient well. We don't want the patient to be sick before we see them. So we should have some sort of a framework to understand and approach these patients rather than just using gut feelings. And then we talked about the bias called framing bias, which is basically the conclusions are drawn based on how the information is given to you. The other metacognition errors that we thought we committed this time was, or rather that was committed by all of us as a team, was that thinking that the CT scan being normal helps us rule out most things. But actually, as you know, CT scan is only relevant if it is specifically done to rule out specific pathologies. And then, of course, the fallacy of therapeutic trial in undiagnosed headaches. Now, the patients with migraine may not get better with medications, but patients with very sinister conditions may get better with analgesics. And finally, not using a systematic formula, but using gut feeling to make a diagnosis. Now, quickly, I'm going to go to the next case, which is basically another case that I heard in, a 65-year-old man who I've been seeing for a number of years for various complaints. And the conclusion was none of them were sinister. In fact, most of them were psychosomatic functional disorders. But I couldn't discharge him. You know why I couldn't discharge him? Because I didn't know what to write in the discharge note to the family doctor, because every visit he will come up with a different symptom which is functional in nature. So it was much easier for me to give him an appointment every 3 months and see him in my clinic rather than angst over the discharge diagnosis. So basically that's the patient that I had. And then one day I get a call from my resident saying that this patient of mine is admitted for headaches, which he never complained before. And he told me that the rest of the examination was normal. A CT scan was done in the emergency department. What do you want me to do for him? And then, of course, I immediately, when I heard his name, my heart sank, because I knew this man I've been seeing for years. He must be functional, right? Because he's functional all the time. So what did I do? I already decided that he was functional, correct? So even though he didn't have a primary headache syndrome, I thought he must have a functional disorder like tension type headache. And I thought most likely he has tension headache. Why don't we just treat him for tension headache? And then I went to talk to him, but instead of going through a checklist of red flags, what did I do? I asked him more questions to confirm my already predetermined diagnosis of functional disorder. So I got more history that he's more stressed. Recently he was going through a divorce, and he was so upset with his divorce lawyer because his divorce lawyer was giving all his money away to his ex-wife. So all these things further confirmed that he must have tension headache. So I turned to my resident and said, resident, please carry on. Discharge him with some medications. But luckily, this patient was admitted to a ward. There was another attending who was taking care of the patient. So the next day when she came to see the patient was still in the hospital. She decided to apply the formula that I've been talking about, but I didn't apply. And she agreed that there was no significant primary headache. But she went through the checklist. She went through the checklist religiously or rigorously, unlike me, who just dismissed it. So what did the checklist showed you? Well, first and foremost, when she asked for focal symptoms, which he actually says that he's been having transient obscuration of vision, which he kind of like didn't really volunteer to tell anyone until somebody asked it. Now, in terms of obtundation of sensorium, he had none. He had no symptoms of raised pressure, and he had no constitutional symptoms. But his headaches were persistent and not responding to analgesia. So he had two small red flags there. One, a focal neurological symptom, which was unexplained. And then, of course, the fact that his headache was different, or rather he never had headaches before, and this was a new persistent headache. So then she went on to check the third bucket of questions, which is patient profile. while I only focused on his psychosomatic complaints, she decided to look at all his recent medical history and realized that since I saw him last in the clinic, he was admitted to another district hospital for a history of TIA. You know, it wasn't clear what kind of TIA he had, but the workup showed he's a 65-year-old man, non-smoker, no diabetes, no hypertension, but he had bilateral severe carotid disease. Now, this wasn't explained at that time. So they thought this man had bilateral carotid disease, attributed his TIA to that, got him an outpatient appointment at neurovascular surgeons, gave him some aspirin and discharged him. This was a few weeks before he got admitted for headache. So with that now, she decided to look at the whole picture and called me and said, Dr. Uma, you know that patient of yours that you thought, yeah, you know, he was recently admitted for TIA, and I'm just wondering that he doesn't have prominent temporal arteries or painful temporal arteries, his temporal pulsation is normal, he's got no jaw claudication, anything. I think there is a possibility that this could be GCA, but I'm not quite sure. But I think I will go ahead and do a ESR, and I will do an ultrasound of his, because, you know, it's unusual that he's got bilateral carotid disease. And then, of course, I had nothing else to say except yes. And a few hours later, she called me and said the ESR was more than 100, and the ultrasound of the temporal arteries was very suggestive of temporal arteritis. And then subsequently, the rheumatologist came in and collected more information and confirmed that diagnosis of giant cell arteritis. So in this case, what was the metacognition error? Well, first and foremost, anchoring bias, which is another bias. Just now I talked about framing bias. I'm talking about anchoring bias. Anchoring bias is the tendency to rely too heavily on certain information very early in the diagnostic process, and therefore to limit consideration of alternative explanation that is overly influenced by the first impressions. Exactly what I did, anchoring bias. What else did I do? I fell into the trap of confirmation bias. Basically, I decided that this patient is psychosomatic. So what I did, I only collected information to confirm it. So confirmation bias is the tendency to focus only on information that supports our preconceptions rather than refutes them. What is the third error here? Remember, we said checklists are very important, especially when you have high thoroughfare. When you have lots and lots of patients you see, the checklist ensures safety. Now, no matter how senior you are as a pilot, the pilots will tell you that they cannot take off the plane. They may be they have 50 years of flying experience. They may know everybody in the airport. They may know all the mechanics, but they still can't take off the plane until they fill in a checklist, a safety checklist. Why? Because they have to be right, not 99% of the time, but 100% of the time. So likewise, as clinicians, I feel that if we want to be right, because we're dealing with people's lives, limbs, and eyes, we have to be right most of the time rather than some of the time. So checklist ensures safety. So if I had applied this checklist on this patient, in spite of my anchoring bias and confirmation bias, the checklist would have saved me, because I would have picked up, hey, he's got focal neurological deficits. He's got transient obscuration of symptoms, which he never had, and he had change of headache nature, which he never had before. So the checklist would have saved me, okay? So in summary, I have gone through with two of my sins, by illustrating two of my sins and confessing on two of my sins, the three most common areas of bias. And this is particularly important for headache, because headache is a challenge. As neuro-ophthalmologists, you guys also see patients with headaches. And because you see too many of them, rather than believing in gut feeling and intuition, I would propose that using a formula of 3 buckets of question, deciding on what is the possibility, and then ranking the probabilities, and based on your ranking of probability, choosing the right test. If you're suspicious of something, do the test which has got higher sensitivity and specificity. If you don't suspect something, perhaps you can do a simple test, a screening test. Okay, and that will allow us to be rational in our approach to headache. With that, I would like to thank you and take questions.
Thank you, Dr. Umapati. A very nice talk, really highlighting the bias that can be there in our diagnosis. Putting forth as practitioners, as we grow more and more into our field, we tend to believe our gut feeling more than actually looking at these red flags, and you put it very rightly. Any questions from the other panelists?
Can I make a couple of comments?
Yeah, yes. Sure.
Yeah, with the first case, very interesting case, really very a great teaching case. I don't personally believe that in SLE you see vasculitis. Vasculitis is inflammation in the vessel wall. What you see, which you see with PAN and GCA, of course, but what you see in lupus is vascular occlusion due to antibody deposition, or if it's larger vessels, then very often they have the antiphospholipid syndrome. And I wasn't sure whether there was a plan to anticoagulate your patient or look for evidence of the antiphospholipid syndrome. The other importance of antiphospholipid syndrome, it's the only prothrombotic disorder that causes arterial as well as venous thrombosis. All of the other conditions we look for, factor V Leiden and protein C, etc., that only cause venous thrombosis. So I just have that question about the first case.
Sure. Thanks very much for the comment. Yeah, I can't remember the top of the head whether antiphospholipid antibody was positive, because subsequently the next morning we actually did transfer her to rheumatology, and but they did immediately start the patient on cyclophosphamide because they did feel that the patient had enough features to suggest CNS vasculitis, because they were already suspicious about systemic vasculitis from the point of view of the kidneys and other organs prior to seeing us. So, but your point is quite right about the antiphospholipid syndrome, but I'm sorry, I don't have the information right
on the second case, I think that transient obscurations of vision in GCA are very interesting. When we talk about transient obscurations, it's just by convention, we mean transient loss of vision that lasts for seconds only. And of course, we see that with papilledema. We're not quite sure of the mechanism with papilledema, but it's usually provoked. So it's provoked by standing quickly or bending forward and standing up and so on. But the other situation where you see transient obscurations is where there's poor perfusion of the eye. And it's a really important symptom in GCA, which is because the patient will come saying that they have transient loss of vision in one eye, but it will usually be provoked by standing because the problem is that the whole eye is poorly perfused. So when they stand, they get loss of vision that lasts for a few seconds. And the mistake is to not to differentiate that from embolic transient monocular visual loss. So it's actually a really important question and symptom in GCA. It's worth highlighting that.
Thank you very much, sir.
I'd just point out that these are perfect examples of why AI has come to the fore, because it's very tough to get rid of confirmation bias and anchoring bias, whereas the computer, if you program deep learning correctly, it'll eliminate that and improve the diagnostic capabilities.
But can it ever come up with anything completely new that no one's ever recognized before? That's what we do. Come on.
So Fiona has a statement here that this is in case 2, it's called Stockholm syndrome. Fiona, could you comment on that?
Well, like Uma, I'm a neurologist, and you can get into a signal to noise problem with patients that you follow for a long period of time. I'm completely empathetic, Uma. And if you catch yourself on a bad day and they're on a bad day, it can be very, very difficult to see an old patient in a new light. And I refer that as mutual Stockholm syndrome. The patient's stuck with us and we're stuck with them. But your patient escaped, Uma.
Thank you. That's funny. I always thought that Stockholm syndrome had some dark connotations with hostages and loving your hostage takers, isn't it? So in this case, the hostage taker is the doctor. Yeah, good point. Yeah.
Well, what I mean is we're all held hostage to our cognitive biases. So sometimes when I follow patients for a long period of time, I actually I ask the resident specifically to challenge my hypothesis, and I want the resident to go see them. And I say, I really want you to disagree with me. I need a young mind and fresh eyes, because when you've been following a patient for 10 years in the very way that you describe, where you're engaged on a Q3 monthly basis, it can trick us all. And we've all had that experience. I'm sure everybody would.
Edsel, do you have any comment on the GCA? Edsel?
No, I still get fooled by the GCA all the time, so I shouldn't talk. But it's just always something to keep in mind. I think I overdiagnose GCA more and maybe subject patients to temporary biopsy too much. But it is an excellent case. I have nothing to add. I'm learning a lot here today. Thanks.
Actually, yesterday Andy was talking about how in Asian patients he's seeing this overlap between Takayasu's and so yeah, I mirror that comments exactly, because I've seen quite a number of patients who don't seem to fit nicely into either Takayasu's or temporal arteritis, and they seem to have and their age groups are around 50s rather than, not this patient, but we do see patients who seem to be more temporal, more Takayasu-like, but they come to neuro-ophthalmologists or neurologists with headaches and symptoms suggestive of temporal arteritis too. So I think there is something in between the two that we may, I'm not sure whether there's a biomarker to sort this out. Over.
Dr. Umapati, one question. What proportion of headaches do you see as primary and how many secondary? And in primary headaches, do you always do imaging?
Yeah, so I think that is the point of the whole exercise, in the sense that there is this feeling that if you image somebody, you would get away with everything, you know, and if you choose the most sophisticated image, you get away with it. So even if an MRI for that second patient would have been normal, but what helped us was a good history, and then of course a targeted test, ESR in this case, right? So I think the challenge here is to decide. Because it's going to be difficult, because you see so many patients with headaches, right? And many of them have primary headaches, and primary headaches are so common. So just because you have a primary headache, I always joke with my residents, just because you have a migraine doesn't mean you cannot get meningitis in your life. It doesn't mean that you cannot get intracerebral bleed. On the other hand, just because you've got HIV doesn't mean that every time you come for a headache, it may be benign migraine, and then you end up with a spinal tap and everything just because you've got HIV. So how do we decide when to investigate, not to investigate? So actually and that's why I think a formulaic approach, rather than just relying on gut feeling, that decide, is it a primary headache syndrome based on the 3 sets of questions? And then the more important thing is decide on the possibilities and then rank the probability. If the probability is high, because yesterday again there was some discussion about testing, right? So I think Edsel was talking about ESR negative temporal arteritis. Now, but many of us, when we see a patient, we're not just going to do an ESR, right? We decide on the patient's pre-test probability. So if the person comes with one eye blind and then the other eye with complete ocular ischemia, with temporal pain, with polymyalgia rheumatica, with thrombocytosis, if the ESR is normal, I would still treat it as GCA, right? So in that context, the ESR doesn't help me at all, right? Because the pre-test probability is so high. So I think that's one of the things that we must understand as clinicians. We never use any instrument of diagnosis in isolation. We use it in the context of the patient in whole, and we actually use a mathematical formula, which the statisticians call pre-test probability, to decide whether the patient has. If the pre-test probability is high, then we have to choose the most specific and sensitive test. If the pre-test probability is low, we can get away with a simple screening test. That's how I simplify it for my residents, over and out.
Yeah, thank you. So I will quickly show you one case which has been sent to us by Dr. Cynthia Nusanti from Indonesia. She had some questions related to it, so I will just share it with you. So this is sent by Dr. Cynthia on cavernous sinus thrombosis in a diabetic patient. It was a 57-year-old female patient with 20 years of history of diabetes, came to the emergency room with blurred vision of both eyes. 2 weeks ago, she had a gingival abscess in the right upper maxillary gum, fever, general weakness and headache. 10 days before, patient got fever, nausea and headache. 1 week before admission, the right eye started to become blurry, developed ptosis and was protruding. Later on, the left eye started to become blurry and unable to move. This was the examination. The patient was somnolent, harlequin face. There was no bruit, no light perception in both eyes. There was ptosis, proptosis with no ocular movement, as you can see here. The right eye showed chemosis, corkscrew vessels, corneal ulcer. Left eye did not show any light reflex, and you can see dilated pupil. There was a cherry red spot consistent with the central retinal artery occlusion in the left eye. The MRA showed total occlusion of the right ophthalmic internal carotid artery 5 days before admission. This was a lab test. The corneal specimen showed fungal hyphae and spores. The urine showed candida albicans. Sinus showed mucorales. And this was a lab testing with marked leukocytosis, high procalcitonin, high fibrinogen, high D-dimer, and the blood sugar was also high. This was a CT scan result. The contrast-enhanced CT scan dilated right ophthalmic vein, suggestive of CCF. I'd like Dr. Veena to make her comment on this. This was a CT scan which apparently was done at the ER. Dr. Veena, would you like to comment?
It's difficult on these images to comment on CCF because the cavernous sinus images are not, I mean, they're very small images for me to comment. Of course, the SOV is dilated,
Okay.
but I cannot comment anything more than that.
Yeah, sure. I mean, this is the only images said. This was the MRI 7 days after the admission, which showed thrombosis in the cavernous sinus and large area of infarct.
Okay, that's fine. The SOV is not showing any enhancement. There is a filling defect, so that confirms the thrombosis. There is a lack of enhancement in the right cavernous sinus, so it looks like a cavernous sinus thrombosis. And probably we'll have to look at the MRA pictures for the occlusion of the internal.
And this was the MRA result, showing the occlusion of the carotid interna and the medial cerebral artery. So what Dr. Cynthia wanted to know is, in the very short time this has developed into this stage today, is there some red flags that could be picked up to prevent the patient from losing both the eyes? So that was a question to the panelists.
Yeah, basically, she wanted to know that patient came with a dental gingival abscess, and sooner or later she developed the ptosis. So would it have been possible to, determine that she was going into this kind of a situation in the next few days?
As Dr. Shikha has mentioned. Yeah, sorry.
I mean, is it during the COVID period?
No, she has not specified that. This is the only PDF that she sent to us.
Because
as Dr. Shikha is mentioning.
It's a typical case of mucormycosis. It tends to invade the vessels, occlude the vessels, and then lead to infarcts. And it's going just the way. It's eventually fatal. This is how fungal infection mucormycosis. It invades the blood vessels, occludes, and then leads to infarcts in the brain, and it progresses very fast.
But at the time of the abscess, is there something that could have been done to prevent this? That was in a matter of few weeks.
But sinus and orbital involved.
I don't. Yeah, probably the sinuses got invaded
Yes.
during the procedure. She's a diabetic, right?
Yes, right.
She's a
uncontrolled.
Diabetic, yeah.
So that classically fits. But is there something in the initial stage itself of the abscess formation? Because it happened in a matter of about 1 or 2 weeks. Is there some red flags that we can look at to prevent this from, progressing to a fatal condition?
The initial images could have picked up an initial MRI. She's done CT initially, right?
Yeah, but that was all in ER. So unfortunately, the patient directly came after a week, so did not show anywhere before it. So that was the problem. Any question? Any suggestion, Dr. Miller?
Well, I think, you have to be cognizant in patients who are basically immunosuppressed that when you do any type of procedure, you have to be aggressive in terms of protection. So I suppose I didn't hear whether there was prior to the dental procedure, whether the patient was placed on antibiotics or whether there was any sort of attempted protection. I can't recall whether what the patient's hemoglobin A1C was at the time of the procedure, but I think you just have to be hyper aware in any patient who's immunosuppressed by disease or age or drugs that they can develop this. And then my experience is that in many cases, particularly of fungal disease, people are slower to react than they should be. There's always, you're really hesitant to accept. It's sort of a variation on what Uma was saying. People are hesitant to accept what's right in front of them in terms of all, if you look at your checklist, you don't pay attention to it because you don't want it to be what you fear. And so you take a different course and that delays everything. I don't know if that makes sense.
It does, and there's a point I would like to add there. We all know it, but before any procedure on a patient who is a diabetic, I think the blood sugar control and all other parameters which need to be cleared, even if it's a dental procedure, I think it needs to have a clearance from the physician or the anesthetist before a patient undergoes. And therefore we can prevent this kind of a scenario in the next few days.
Yeah, it's a great point, Satya, because there have been numerous reports, certainly from the neurosurgical literature, that no matter what the procedure, the patients who are diabetic, and particularly those not well controlled, have much worse outcomes overall.
I'd like to make a point about that distended superior ophthalmic vein.
Yeah, sure.
Because it clearly, probably the commonest situation in which we see that is a dural fistula. But of course, it will always be present with cavernous sinus thrombosis. I mean, I find at MRCP level, the students diagnose a cavernous sinus thrombosis in more or less everything that you show them, and then they discover it's very, very rare. But the SOV will always be dilated, of course, with the cavernous sinus thrombosis. And this one is actually thrombosed. Now that you do see with dural fistula, there are two causes of thrombosis of the superior ophthalmic vein, which is an unusual thing to happen. One is fistula, and that's because of the high flow. Venous thrombosis is associated with all types of arteriovenous communication because of damage to the endothelium of the vein. But the other one is infection, either in the orbit itself or in the cavernous sinus. And so often with cavernous sinus thrombosis, there's a mixture, there's two things going on. There's a thrombosis, but there's also the aggressive underlying infection, be it bacterial or aggressive fungal.
Okay, thank you. So now we can move to the next session. Dr. Satya, you can introduce the moderator.
Yes, thank you. So the next session is being moderated by Dr. Jaspreet Singh. He is a consultant pediatric ophthalmology and neuro-ophthalmology at the Postgraduate Institute of Medical Education and Research in Chandigarh, India. He was trained with Dr. Gordon Plant before starting neuro-ophthalm services in ophthalmology, and he is also the president of the Chandigarh Ophthalmological Society. He has more than 100 publications in peer-reviewed index journals and several chapters in books. He's the associate editor at Acta Ophthalmologica. He's also received the Orbis International Gold Medal at ECRS and also the Best Video at ESCRS. He got the Om Prakash Award in Pediatric Ophthalm in the AIOS in 2020 and several other awards too. He was invited as a speaker at various international and national conferences. and he is also a reviewer for many international and national journals. Over to you, Jaspreet.
Thank you, Dr. Satya Khanna, for those kind words of appreciation. What better session can it be? I have my mentor here, Dr. Gordon Plant, and I'm happy to be introducing the panelists for this session, and who would be further introducing the wonderful speakers we have. So we have Dr. Samira Irfan. She's a consultant, works in a neighboring country, Pakistan, and she does oculoplasty and neuro-ophthalmology as well. She's done quite a bit of a training in UK and has won honors in pediatric ophthalmology and the SARC Excellence Award in Ophthalmology, then a gold medal for excellence in ophthalmology by the Society in India, and of course she has again a keen interest for teaching. I mean, you can see from the award she's won for educating ophthalmologists in Pakistan. She is no doubt actively involved in clinical research and has authored 4 books in ophthalmology. She has 60 scientific papers, and also she's the editor of the SAO Chronicle. She started this online official journal of the SARC Association of Pediatric Ophthalmology and Strabismus. So that is our first panelist. Our second panelist is Dr. Varshini Shankar. She has done her post-graduation and fellowship training in pediatric ophthalmology and adult strabismus from Shankar Nethralaya, Chennai. Presently, she's a consultant in pediatric ophthalmology and manages the squint and neuro-ophthalmology division at Shroff Eye Center, New Delhi. Special interests are managing eye disorders in children with developmental delay, complex strabismus, disorders of convergence, accommodation, and unexplained loss of vision. Our third panelist is a neuroradiologist, and we are fortunate to have her here with all her expertise. She's a Dr. Veena. She's a consultant radiologist, VRR Scan Chennai. She's done a post-graduation in radio diagnosis from Mumbai and specialized in orbit and neuroimaging. She's been an invited speaker at various state and national level conferences, ophthalmology and radiology conferences. And she's co-authored a book on the Atlas of Imaging by JP Publication. Thank you to all the panelists. And I would now request our first panelist, Dr. Samira Irfan, to introduce our first speaker. You need to unmute, Dr. Samira. You need to unmute.
Good evening, everyone. Thank you so much, Dr. Jaspreet, for your kind words, and very grateful to Dr. Satya for inviting me to this wonderful webinar. So I'll introduce my first speaker, and she is Dr. Zoe Williams. She's where is my screen?
You can open this presentation, yeah.
I'm opening it. Why can't I share?
You can stop share and do it
Stop
again.
share and do it again?
Yeah, and this time choose the PowerPoint. Choose the PowerPoint this time.
Isn't it? Share.
Yeah.
It doesn't share.
Oh, it's sharing. You just have to double click on
Presentation, yeah.
presentation.
Open with.
I am.
Yeah.
Is it sharing now?
Yes, it's there.
Okay. So Dr. Zoe Williams, sorry about that. She received her fellowship in neuro-ophthalmology at Wilmer Eye Institute, Johns Hopkins University. She has served on basic and clinical science course in neuro-ophthalmology committees since 2015. She is on the American Academy of Ophthalmology's Self-Assessment Committee since 2016. She has authored several book chapters and 20 peer-reviewed publications. She has been awarded the Richard Green Research Grant Award and a 5 Forsyth North American Neuro-ophthalmology Society Postdoctoral Fellowship Award. She has also received the American Academy of Ophthalmology Achievement Award. So welcome, Dr. Zoe Williams, and it's a pleasure to have you here. Would you like to discuss your case, Dr. Zoe? She's not here.
No, I think Zoe's muted.
Okay,
Yes,
am I
now.
back on now?
Yes.
Okay,
Hi.
sorry about that. So thank you so much for the opportunity to participate in this festival today. This has been absolutely great for me. I've already learned a ton. And today I'm going to present a case that hopefully I can get some input from the panelists on, as it's not completely known at this point. So our case is a 56-year-old female with hyperlipidemia and borderline diabetes who was referred for suspected right 6th nerve palsy. Her husband had actually noticed that she had restricted abduction of the right eye, and then on questioning, the patient endorsed that yes, she does get some blurred vision or binocular diplopia on right gaze starting 2 weeks prior to her initial evaluation with me. She had not noticed any progression since onset. She denied any preceding head or eye trauma, said no pain with eye movement. She had not noticed any change in the prominence of her eyes. And on questioning, she did report paresthesias in the right first trigeminal distribution. And she said that there was no change in her visual acuity, color vision, or peripheral vision. Her past medical history was significant for no history of skin cancer. She never had strabismus surgery. She was a former smoker, but she only had smoked for 3 years, 1 pack per week, and she had quit over 30 years ago. Her family history was non-contributory, and on review of systems, it was negative for giant cell arteritis, including no unexplained weight loss or fevers. So her afferent exam looked great. She did have a trace 1+ left afferent pupillary defect, but function was good. On visual field testing, there was a glaucomatous field defect in the left eye, a nasal step. On her motility exam, she had a very mild esotropia in primary gaze, and she did have significant abduction deficit of the right eye, but she also had a supraduction, infraduction, and mild adduction deficit as well. So this caused her esotropia to increase significantly on right gaze. And then on down gaze, she developed a right hypertropia, and on up gaze, a right hypotropia. Her motility of the left eye was near normal. She had a mild limitation of abduction. And there was no appreciable slow abducting saccade of the right eye. On external exam, she had bilateral exophthalmos with a fullness of her superolateral lids. Her TEL showed that it was 28 millimeters on the right, 26 on the left. This is a Caucasian patient. Her facial sensation was intact, and cranial nerve 7 was also intact. Anterior segment was unremarkable, and dilated exam was only remarkable for the glaucomatous cupping in her left eye. So on neuroimaging, so all of these sequences are T1 flare with fat suppression and contrast. And this was read as showing multiple enhancing mass lesions within the orbits involving multiple bilateral extraocular muscles. So in the right orbit, it was the right lateral rectus, in addition to the superior rectus and superior oblique. And then in the left, it was the medial rectus, as well as the left superior oblique, as well as bilateral lacrimal gland enlargement and enhancement, and a mass lesion tracking along the left superior and lateral orbital rim abutting the globes. There was moderate mucosal thickening, especially in the maxillary sinus, and no intracranial findings. So at this point, I'll ask the panel for their differential diagnosis.
How about thyroid?
IgG4.
But there was no pain and no signs of inflammation.
Correct. No pain in the front of the eye, looked quiet.
Metastasis.
A lymphoma.
Great. Okay. So I think we covered all the broad categories: inflammatory, infectious, and neoplastic. So this was the initial differential. So on preliminary lab screening, her CBC showed no sign of infection. Serum IgG4 was normal. Laboratory screening for sarcoidosis was negative, and her ANA and ANCA screen were negative. So she underwent a biopsy of her left lacrimal gland, periorbital tissue, and bone biopsy, and this showed features of atypical histiocytosis, most concerning for a histiocytic neoplasm. So gram stain, fungal, AFP stain, and cultures were negative, and the path was officially read as non-necrotizing granulomatous inflammation with scattered atypical foamy histiocytes and multinucleated giant cells, including rare Teuton type giant cells. She actually had immunohistochemical staining that was positive in rare cells for CD1A, which we typically see with Langerhans histiocytosis, and also for Langerin. And then in addition, she had a positive S100, and she was CD68, CD163, and factor 8A positive. So CD68 and CD163 are nonspecific. They can be positive in Erdheim-Chester disease, as well as Langerhans histiocytosis and Rosai-Dorfman, but the factor 8A is more specific for Erdheim-Chester. And then her immunostain was also positive for BRAF V600E, which can be seen both with Erdheim-Chester and Langerhans cell histiocytosis. So at this point, I called her with her pathology results and asked a little bit more history. She did endorse that she'd had 1 week of night sweats, but it was transient. It was about 2 months prior to when I saw her. The lasting symptom that she had was increased fatigue. She said she'd been taking an hour nap 3 of the 5 weekdays for the past 5 months. She denied any bone pain. She said she does drink a lot of water since her gastric sleeve surgery, but she denied any excessive thirst, increased urination, or clear urine. And she'd had no headaches, shortness of breath, fevers, weakness, or weight loss. So at this point, I ordered a skeletal survey, and I was really relieved when the radiologist read this and commented that there were no radiographic signs suggesting Erdheim-Chester disease until I opened up the images and saw that it only extended to the pelvis. So at that point, I wasn't so sure that we had ruled out skeletal involvement. She got a CT of the chest that showed mediastinal right and right hilar lymphadenopathy consistent with sarcoidosis. A mutation panel was sent from her biopsy tissue and again showed a 5% BRAF positivity. So at this point, I referred her to hematology oncology, and I also referred her to pulmonology. I saw her back at 1 month after my initial evaluation. At this point, she'd been untreated and her exam was stable. Her pathology from our institute had gone for external expert review and was felt to be likely non-neoplastic, most consistent with sarcoidosis, but the BRAF positivity wasn't mentioned in the report. And when our pathologist called the expert pathologist, they weren't quite sure what to make of it and said that if there was additional tissue obtained, they'd be happy to review it. So at this point, I decided to try an empiric trial of prednisone, 1 milligram per kilogram for the patient, and see her 2 weeks later. At that point, she said really nothing had changed. She had resolved her right-sided paresthesias, but there was no change in the diplopia on right gaze. The exam did show a minimal improvement of her proptosis, but her ocular motility and misalignment were stable. So I thought this was pretty unimpressive, and I advised her to taper her prednisone to 40 milligrams over the next 4 weeks. She subsequently saw pulmonology, and they were pretty convinced that she had sarcoidosis. They did a ultrasound-guided mediastinal lymph node biopsy, which did show rare small granulomas with no histiocytic proliferation, but pathology noted that the tissue was very scant and no sequencing could be performed. She was seen by hematology oncology, who recommended additional workup for possible Erdheim-Chester disease. She underwent abdominal and pelvic CT looking for evidence of retroperitoneal disease, or in particular renal involvement, and this was unrevealing. And at this time, she is pending echocardiogram, full body PET CT, and evaluation by an Erdheim-Chester disease expert. So obviously this case is not solved at this point, but I realized as we were working up this case that this is actually, once you've got pathology that's somewhat suggestive, it's very hard to actually exclude this diagnosis. So Erdheim-Chester disease is a rare non-Langerhans cell histiocytosis. It's been shown recently to be a clonal neoplastic disorder with a high rate of BRAF V600E mutation. And this implicates the mitogen activated protein kinase signaling pathway. Most cases are present, or most cases present between age 40 and 70. This is a somatic mutation, and there is a male predominance. So the diagnostic criteria were actually written in 2014, and for histopathology, our patient doesn't meet this part of the criteria, but this is not the only criteria to make the diagnosis. So you should see infiltration of foamy or lipid-laden histiocytes with admix surrounding fibrosis and Teuton giant cells. As I mentioned before, the immunohistochemical stains can be helpful. They're positive for CD68, CD163, and factor VIIA, plus or minus S100 in Erdheim-Chester disease, and should be negative for CD1A and Langerhans. However, it was shown in the about 800 cases of Erdheim-Chester disease that have been reported that there are about 12% that have some overlap on immunohistochemistry with Langerhans cell histiocytosis. The histopathologic findings are part of the diagnosis. As I mentioned, the other part is the appropriate clinical and radiologic context. And interestingly, BRAF V600E is often present at a low allele fraction, less than 5%. So initially when we had that back, we weren't sure how significant it was, but actually typically when it's positive, it's not a high fraction. So in terms of radiologic and clinical findings, so the most common finding is symmetric diaphyseal and metaphyseal osteosclerosis in the legs, so particularly the femur. And that's seen in 96% of patients with Erdheim-Chester disease. But it's often missed on plain films. So I think even if the skeletal survey had been full body, as I thought it was, we still couldn't have really said that we had adequately evaluated for this. It takes either a bone scan with a radionucleotide or a full body PET CT to look for this. A very common finding, which was looked for by hematology oncology with the abdominal pelvic CT, is dense infiltration of the perinephric fat, which is the hairy kidney. That's almost 70% of cases have that. And then for orbital involvement, it's actually most commonly intraconal masses, but there are some of the cases that have been reported have been extraconal and a very high rate of exophthalmos. There can be CNS findings. Our patient did not have any, but patients can have meningeal lesions, which will often mimic meningiomas. There can be pachymeningeal thickening that's quite expansive. Infundibular stalk lesions or enhancement is also not uncommon finding. And then some patients will have pontine or cerebellar masses, and there's a particular characteristic of high signal in the dentate nucleus. Additional findings, so other systems involved, cardiovascular, there can be periaortic infiltration, you can have pericardial effusion. Pulmonary findings are more commonly parenchymal rather than the hilar adenopathy that we found. And then about 25% of patients will have endocrine involvement with diabetes insipidus, and that has considerable overlap with Langerhans cell histiocytosis as well. So the baseline evaluation for Erdheim-Chester disease is actually quite extensive. So our patients had the CT chest, abdomen, pelvis, and MRI of the brain with gadolinium. We're pending insurance approval for her full body PET scan, and cardiac MRI is likely to be planned depending on results of her echo. She has no evidence of renal insufficiency, and she has not yet been assessed for endocrinopathy. So yesterday it was brought up in the case of adult onset optic nerve glioma, how important it is to test for BRAF 600 mutation, as we now do have approved therapies which are BRAF inhibitors. Basically, there were clinical trials specifically for Erdheim-Chester disease as well with the BRAF inhibitors that showed a great response. And I'm not sure if I'm going to pronounce this correctly, but vemurafenib received FDA approval in the United States in 2017. So that's actually now first-line therapy for patients who have cardiac or neurologic disease or end organ dysfunction. Traditional first-line therapy was previously the PEG interferon alpha, and corticosteroids have been reported in Erdheim-Chester to reduce acute edema, specifically exophthalmos, but this is not sufficient as a standalone therapy. So again, I'm sorry to present a case that is not yet concluded, but I thought it would be interesting to get the panelists' point of view on if her full body PET does not show skeletal involvement, it basically takes the chances of this being Erdheim-Chester disease down to less than 10%, but it's still not excluded. So I was hoping to discuss whether people at this point would go ahead and do a trial of steroid-sparing immunosuppression for possible neurosarcoid, if that full body PET comes back negative, or whether what they would do next, because I'm sure that to get approval, we have to have a pretty sound diagnosis for to proceed with a BRAF inhibitor therapy given toxicities associated.
Actually, Zoe, the BRAF inhibitors really don't have that much toxicity. We, as you well know, we use them all the time in kids with gliomas that are BRAF positive. So we had a recent case of Erdheim-Chester where we used dabrafenib, and it was like magic. So I think if you can get approval, that's always the issue. Either dabrafenib. We haven't used vemurafenib very often, but it's said to be really good. Most of the time it's dabrafenib or trametinib. But I think that's a great idea to use if you can get approval.
So you would go to that first if we can get approval? If the
I would, given the extensive involvement that she already has.
Okay, thank you.
Can I make a comment, Zoe? That was quite an interesting case. Can you please stop sharing your screen?
Sure.
Yeah,
thank you.
Thank you. So I would like to make a few comments that you said it's about painless, bilateral, asymmetrical protrusion of eyeballs. So you said exophthalmos. Exophthalmos, we only reserve the term if it's due to an endocrine cause, like thyroid eye disease. So it's actually a bilateral, painless, asymmetrical proptosis, isn't it? And then there is ophthalmoplegia, so in her left eye, right?
So I'm not sure actually if that's just, so I grade that based on the scleral show that's left. I'm not sure if that's just from the proptosis.
No,
Yeah.
no pictures, photographs of her showing her eyes or ocular motility.
I did not take a video, unfortunately. I'm sorry. So just my subjective measures.
So according to you, it's not total ophthalmoplegia?
It's not, no. So she had 20% abduction of the right eye past midline, and then about 90% superduction, infraduction, 95% adduction. On the left side, it was just a 10% limitation of abduction, but that easily could be the proptosis, just making it look like the sclera doesn't vary.
Okay, and I mean, you think your diagnosis is Erdheim-Chester disease, but I mean, your biopsy on the lacrimal gland and mediastinal lymph nodes, I mean, they prove to be sarcoidosis. So why isn't the diagnosis sarcoidosis, and why focus on just on the blood test BRAF 16?
So that was actually also the immunohistochemical stain in the biopsy tissue came back positive for BRAF as well, and also showed these other stains which are consistent with signs of histiocytosis. So that was really the issue. I think clinically this does look like sarcoidosis, but it's kind of hard to ignore the BRAF positivity and those stains. And then also the fact that we sent also the next generation sequencing mutation panel was also positive for BRAF. I just felt like we can't really ignore that. I mean, I did try steroids for her. I know sarcoid can be steroid refractory, but she really didn't have any change in her motility or her ocular alignment measurements. So I think it needs more workup to make sure this is not Erdheim-Chester.
False negative BRAF test.
So it's actually not, so this was hard to find. So I was trying to look at this, and it's more, I'm going to tell you this, the specificity from melanoma studies, it's actually pretty high. So it's supposed to be a sensitivity and specificity of 95%, plus the other findings on the path. So there were these foamy lipid-laden histiocytes, 2-ton giant cells. So there were findings that, you know, I think they're hard to ignore. So, but it's not concluded yet.
Right. So, and one more thing, if the third, fourth, and sixth nerve, they are all affected, and the frontal division of maxillary, I mean, they all come together in the lateral wall of the cavernous sinus. So was that looked into? Because
so her initial study was an MRI of the orbit and brain, and I really just showed the orbital images because the brain had no findings. It was completely normal, the cavernous sinus on the right side and left side.
Right. Okay. And since that lacrimal gland was so much affected, but you didn't mention any, and the tear meniscus, you mentioned it's reduced, but I think she should be given treatment for her dry eyes. It could be very severe in that case.
We did do that. I just left it out in the interest of time.
Okay.
Mr. Plant, your comments?
From the motility point of view, you need to distinguish how much of that is restrictive and how much is paretic.
Yeah, I actually think that it's all restrictive, although I couldn't really explain her down gaze limitation unless it's just related somehow to her proptosis. Because once you see that scan, it, you know, and I didn't see a slow abducting saccada, though it can be hard to tell when there's only 20% movement past midline, but I didn't do forced ductions in the exam with her.
It looked to me as though it's likely to be mostly restrictive rather than paretic. Another warning, do beware of your whole body PET scan. The whole body PET scans that we have don't include the tibia.
Okay. Maybe we'll get the femur.
Which is the one bit of the body you're really interested in. So maybe you've got bigger machines in America than we have, but we've been caught out on that.
Okay, thank you.
Thanks very much. Could we, Dr. Jaspreet, move on to the next case?
Yeah, I just want to ask one question from Dr. Miller. Was your case different, the one you managed, different from the presentation, was different as compared to this case?
We did not have the confusion regarding sarcoid versus Erdheim-Chester. I think but I think our feeling was that even if it was sarcoid, if it didn't respond to steroids, and the patient had had steroids before, but if there wasn't a major response, we had very little to lose by going after the V600E mutation. So it wasn't nearly as complex as Zoe's case. And there was bone involvement, which I think is a crucial part of most cases of Erdheim-Chester, as Gordon said and Zoe said.
So in such a case, when should we suspect such a diagnosis, rare diagnosis?
I mean, I think it really came up. I'm sorry.
No, go ahead.
I think it really came up with the pathology showing these immunohistochemical stains in the foamy histiocytes, and then the BRAF was sent because of those findings as well.
Yeah, I do think it's in the differential diagnosis anytime you have muscle involvement or intracranial pachymeningitis. Years and years ago, we operated on a patient who had this thickened material, extradural material, or dural material, as well as bilateral orbital disease. And the stuff, it was a yellow, it was like a carpet across the brain underneath the skull, and it turned out to be Erdheim-Chester. It's an amazing disorder.
But there's no myositis in these cases, or is there?
Not as far as I know. I think it's it's not a myocytic, but it's an infiltration with histiocytes, but it's confusing because of the granulomatous nature of some of these things.
Neil, how often have you seen sarcoid causing enlarged extraocular muscles?
I think that's really unusual, Gordon.
Yeah.
I mean, I saw the big lacrimal glands on both sides, I think right more than left, but I was really surprised that could be sarcoid.
I've only seen it twice. Once was in an 80-year-old woman, and we biopsied her muscles. And the other was a paroxysmal case, and we published a photograph of her bus pass because she happened to go for her bus pass photograph when she was having an attack. But otherwise, there's a few cases reported in patients with systemic sarcoid, obvious, gross sarcoid everywhere, who with minor muscle involvement. But it seems to be pretty unusual.
I think I remember one that we had where the sinuses, paranasal sinuses, were involved, and I think there was spread through the bone into some of the extraocular muscles, because that's another issue where sarcoid can fool you, because it can be present as a paranasal sinus process.
Yeah, absolutely. But most of the at-home chesters we see have diabetes insipidus, because that's how they get to us. They go to endocrinology, they have a brain scan and get to us.
Well, and that's why you think in terms of Langerhans cell in these cases, because they really look like that. And I actually thought, as Zoe was talking, that this was going to be on the Langerhans cell side until they did all of the other tests.
And the most important part of the body to look at is the tibia. And we have the only part we haven't seen yet.
That was an interesting case and a good discussion.
Dr. Jasprit, can I make one comment? I'm Ambika.
Yes.
Actually, we had a case like this, which started with a right side mastoiditis. He presented with the ear pain and a sudden vision loss. And subsequently, he started developing a lesion around the cavernous sinus. And he was a 70-plus-year-old person who developed a sudden vision loss and a complete ophthalmoplegia, having this extraocular motility restrictions. And on biopsy, we were able to pick up, and he was also graft negative. And that is the time when we investigated him extensively, and we found a lot of pulmonary fibrosis for him. And that's when the patient was given a choice. And by the time we were geared up, he was treated with steroids, and there was we were not able to get the long bone signals, what we are expecting in him. But by the time we were shifting him, he developed a respiratory arrest and he succumbed to that. He was 75 plus, and he also, but at that time they were giving an option of interferon therapy. So I just wanted to know from the panel, is there any role of interferons in such a condition?
So that was the standard first-line therapy before, if the patient is either non-BRAF positive or before the BRAF inhibitors became available.
Thank you. That was interesting. Now we'll move on to the next case, and I'll request Dr. Veena to introduce the next speaker. So you need to unmute.
Yeah. Am I audible?
Yeah, but there's no screen sharing. Yeah, now we can see the screen.
Okay. So I'm happy to introduce our next speaker, Dr. Fiona Costello. She is the professor at Departments of Clinical Neuroscience and Surgery at the University of Calgary and a clinical scientist at the Hotchkiss Brain Institute. She completed her neurology residency training at the Memorial University of Newfoundland and followed by her clinical fellowship in neuro-ophthalmology at the University of Iowa. She has received the Outstanding Contribution in Leadership Award from the University of Calgary in 2017 and Senior Achievement Award with the American Academy of Ophthalmology in 2017. She was also the president of the Canadian Neurological Society in the year 2017. She has published nearly 120 peer-reviewed papers, 21 book chapters, has been invited over 200 national and international presentations. Over to Dr. Fiona.
Okay, I think I can screen share here. Yeah. So, can everybody hear me okay?
Yes, you're audible, but you need to share your screen.
Okay, hold on. So screen share. Hold on. So,
Is the green
yeah,
one?
I thought
Can you see the green share screen? And
yeah, you know, I'm gonna, I think I need to go back into Zoom. And I can see you, and I've kind of lost, oh, holy, yeah, there we go. Share screen. There we go. Let's see if it comes up. And yeah, I think it's back here. Sorry, guys. Still not coming up?
No, we can't see your screen.
Okay. Share screen.
Are you highlighting the presentation before you share the
screen?
screen?
I think I got it. I think I got it now. Can you see it there now?
Yeah. Yes.
Can you see? Okay, perfect. Sorry about that, guys. And now, let's see if this works. All right. Does everybody see the screen?
Yes.
I'm good. I must be under-caffeinated, and I'm very grateful to be here. I can think of nothing I would love more than to be up at 4:30 in the morning with some of my favorite people around the world. I will warn you, you will see violence, grisly images. There will be some profanity. And I really just mean grisly images in terms of fundus photos. And these cases have been modified given the open nature of this educational forum. And I will warn you as well that I have kind of tried to jam a watermelon into a banana peel. So I'm very happy to cut my talk short, but I welcome interaction and open discussion. So without further ado, let's start with the first case. So a 50-year-old librarian, previously well, comes to us all with recurrent headaches, progressive diplopia, and this is all evolved over a period of months. And to Uma's point earlier with the headache talk, she for a number of months was actually described as having migraines, although these were progressive headaches, somewhat relentless to therapy. But the plot thickened when she developed nausea and vomiting that brought her to the emergency room. Now, her general examination is not terribly exciting. She's normotensive, she's afebrile, and she has a normal body mass index. And similarly, her afferent examination is fairly benign. She's 20/20 in both eyes with respect to acuity. Her pupils are equal and reactive to light with no RAPD, and she has normal color vision. Now, try as you may, I wasn't too excited about these visual fields for the first time field taker that she was. She was reliable, she had good foveal sensitivity, she had a few scattered areas of loss, I think when she got tuckered out by the left eye. But I was really heartened by how normal her color vision was and actually how good her acuity was. And she endorsed no afferent visual pathway complaints either. And I'm looking hard, as you'll come to understand. And again, you know, the longer you stare at fundus photos, and I'm quoting Bob Surgott's description of the macula, the more abnormal they appear, but her fundus examination was absolutely unremarkable. Now, in the spirit of creativity, I tried to recreate her efferent exam. So on inspection, what's interesting is she has some mild left upper eyelid ptosis, and she also has diminished pinprick over the left V1 distribution. And with her versions inductions, all I can pick up is that she has an abduction deficit in leftward gaze. So she has an esotropia that naturally increases in leftward gaze and is pretty much non-existent in right gaze. She also has a left hyperphoria that's greatest in down gaze to the right with 5 degrees of excyclotorsion. And I think to the general ophthalmologist, if you don't have double Maddox rod testing, I just look for the, preservation or lack thereof of encyclotorsion in the right eye when I'm trying to localize a fourth in the context of multiple cranial nerve palsies. And this is my very childish rendering of this depiction. And then in her alternate cover test, she has findings that explain the fact that she has binocular horizontal and vertical diplopia with an esotropia and left hyperphoria in primary position. So my question at this point is, where is the lesion most likely to be? And maybe in the spirit of, well, I can put this to the panel if anybody wants to chime in. I think it's always good to start with localization. All zebras first start with just a good, rendering a zebra diagnosis starts with a good history and a good exam.
The orbital apex.
Okay.
I would think
Why would you
superior
say that?
orbital fissure.
Okay. Anybody else?
Yeah. A.
A.
Why would you say that?
So I would say superior orbital fissure because your fourth nerve seems involved, sixth nerve seems involved, and the first branch of fifth nerve seems involved, but the optic nerve functions are relatively normal.
Mm-hmm.
Also mild ptosis,
So
maybe superior branch of third nerve.
Okay.
Yeah, no RAPD.
Could this be a cavernous sinus? Could it be a cavernous sinus lesion?
I don't know how you separate superior orbital fissure and cavernous sinus. We usually call it, I call it a spheno-cavernous syndrome because it's really, I mean, you're talking about millimeters of difference. The only thing that helps you is the lack of the optic nerve dysfunction, but I don't think it helps you at all between A and C.
Okay. I totally agree, Neil, and I actually understand, I think, all of the thinking behind each of these, you know, kind of anatomical regions. And I think it's important for the ophthalmologist to understand why we machinate about localization, because it has everything to do with directing the right imaging study to the right anatomical region of interest. So she didn't have any history of fracture. I looked a little bit more at historical involvement of the superior orbital fissure. She had no proptosis. She has no afferent abnormalities, and she has, you know, some very focused sort of cranial findings that I felt best localized to the cavernous sinus. But you'll see that I was biased a little bit by information that will become known as we go through the case. Because here we see a very interesting picture in our patient. So she has an anemia and a thrombocytopenia. She's a little bit hyponatremic, and remember, she's coming in with nausea and vomiting. She has elevated acute phase reactants, and she is 50. She's rheumatoid factor negative, anti-double-stranded DNA negative. She's got a positive ANCA though. Her IgG serum subsets are normal. And she has some evidence here of pituitary dysfunction with low prolactin and low IGF-1, but she also has a low cortisol and low ACTH test. So, who's intrigued? So maybe I could ask some of the experts to weigh in, and I apologize for the paucity of images, but I think the relevant findings are evident. Maybe I could have people smarter than myself comment on these imaging studies.
How about Veena?
Yeah, so basically these are all contrast enhanced T1 images. This is the, can you see the arrow or should I need to? Okay, so
I put the arrows in. I think Helen Keller can see the arrows because I wanted to make it as easy as possible for anybody.
So the first image is a SAG, which shows you the involvement of the infundibulum. The pituitary stalk is thickened and enhancing. The second image shows you the thickened dura at the lateral wall of the cavernous sinus, as well as at the tentorial edge. The coronal image, of course, shows a little heterogeneous enhancement of the pituitary and a thickened infundibulum. So
thank you so much.
Yeah,
I'm fascinated by the fact that the prolactin is so low. You know, in all my years, I don't know that I've ever seen a prolactin that was really low. Usually, if there's compression or infiltration or something like that of the stalk, you've got a hyperprolactin, and it. I think that's absolutely fascinating.
So radiologically,
I don't know what it means.
Radiologically, Dr. Veena, what would it like?
So I would put some kind of a granulomatous inflammation. So it's like a pachymeningitis with involvement like a hypophysitis.
And you can you please explain for the benefit, I think, of the listeners, what are the features of the pachymeningitis, and then what are the features of the hypophysitis? I put the arrows in there, but I think it bears mentioning.
Yeah, so basically pachymeningitis, you see the thickened, the dura, the meninges here, and the hypophysitis, you'll see the pituitary gland is not at all enhancing. In the coronal, it looks a little heterogeneous, and the involvement of the infundibulum.
No, thank you so much. That's incredibly helpful. Okay. So how hard could this be, this case? Let's think about it together as we kind of go through things. So we have a patient who has radiological and serological features of hypophysitis. And, although this is described as affecting, 1 in approximately 7 million people, I've seen about 3 cases of hypophysitis throughout the pandemic. And so our patient did present with some cardinal clinical findings. So she has hypopituitarism. And there isn't with hypophysitis the same kind of hierarchical respect that we sometimes see with pituitary adenomas. So she actually has knocked off cortisol function. She could have hyperprolactinemia, but as Neil has pointed out, our patient's prolactin is actually quite low. She had evidence of diabetes insipidus, so that was actually accounting for her vomiting. And again, really heralding, I think, some of the very important points that Uma made, that, it wasn't just pain and part of a migraine syndrome that was contributing to this particular part of her clinical presentation. She has headache that, for all intents and purposes, mimicked a primary headache disorder. And she could have easily had vision loss and more of an orbital apex-like syndrome, but she presents with ophthalmoplegia. What's glaringly absent here is proof of whether she has meningitis or not. And that is in part because we did not, we were not able to convince this patient to undergo a CSF analysis. So she's presenting quite interestingly, I think, with this hypophysitis picture, but it's a little bit more than that based on the radiology. And I think another important pearl to consider is that with hypophysitis, say unlike a pituitary macroadenoma, the radiological findings of stalk, thickening and enhancement can be quite underwhelming compared to the extent of pituitary dysfunction. Okay.
So I have a question.
So what do you guys think? Go ahead.
Yeah. So how do we explain the ophthalmoplegia?
Okay. So the ophthalmoplegia is interesting. And I think that's an important question because I had convinced myself, and let's just have a look back here. I'd convinced myself clinically that this patient had to have evidence of cavernous sinus involvement. And the radiological kind of feedback I received from multiple scans is that it's not there. But I'm going to sort of rest on my clinical laurels and just say, I'm a believer. She has a partial third with evidence of ptosis. She has a 4th nerve palsy and a 6th nerve palsy and the 1st division of V1 involved. So that is easily localizable to the cavernous sinus, but I can only answer this by saying the extent of cavernous sinus involvement may not be evident radiologically, but it is there clinically and certainly at the tissue level. But I'm welcome to other points of view. Anybody want to answer that differently?
There is cavernous sinus involvement, especially the posterior, the posterior and the lateral wall of the cavernous sinus is definitely involved.
Yeah, I think,
Good, I'm glad.
I think the problem is that your coronal is more anterior, but your axial, you can see it beginning in the posterior aspect of the cavernous sinus and extending backwards.
No, I think in this case, Neil, neuro-ophthalmology could be redefined as the reinterpretation of abnormal imaging that's even more abnormal than it's described to be. But I think you really also highlight an important point. We're the clinicians here, like we're the soldiers in the field seeing the patient. And there is clinical radiological dissociation at times. I'm glad you agree there's cavernous sinus involvement. My own radiologist did not. But we have such privilege in being able to look at the patient and more proximity than the radiologist. So we have to stick to our guns. I felt there was evidence certainly of pachymeningitis, but also cavernous sinus. So she may, and there's a hint to the question, have more than one mechanism accounting for her clinical presentation. So let's come back to our question now. Go ahead.
can I make a comment about hypophysitis?
Please do.
Well, I think this is a term that we started to use a lot when we began to recognize lymphocytic hypophysitis, which is this classic syndrome that occurs in the postpartum period, and there's failure of lactation, total pituitary wipeout. It can be adenohypophysitis or posterior neurohypophysitis. But actually, that's an organ-specific autoimmune condition of the pituitary gland. What we saw for years before we ever started recognizing those cases was infiltration of the pituitary gland, and that doesn't have to be inflammatory. It can be a metastasis. It can be other conditions, non-inflammatory conditions, and the characteristic of lymphocytic hypophysitis is that the pituitary gland lights up like a beacon with contrast, and this one actually doesn't. It looks to me as though it's enhancing less than the normal pituitary gland. So you do have to. I prefer to think of this as an infiltration of the pituitary gland with clearly extra pituitary dural disease as well, which might be inflammatory, but it might not be.
Oh, that's helpful, Gordon. I think if we had an imaging study of the tibia, it would be even clearer. Do you? I'm making fun of you. Okay. But Gordon,
the other thing that's confusing is that some cases of hypophysitis are said to be non-granulomatous and others are said to be granulomatous, and then you get the whole issue of sarcoid and some of these other disorders, and I don't know where you draw the line.
Well, it's easy if you've got disease outside the pituitary gland.
Absolutely, absolutely.
Because then it can be granuloma. And I mean, I've seen TB or granuloma of the disease of the pituitary gland that was tuberculosis. Yeah. So I think that and I've seen IgG4 there as well. I think the hypophysitis is an interesting concept. It's much clearer when we have a straightforward lymphocytic picture.
Can I make a comment? I agree with Dr. Gordon Plant that the enhancement of the pituitary is definitely much less than the infundibulum, and probably there is some amount of necrosis that is going on in the pituitary gland, and that is why it is not enhancing, is what I feel.
Yeah, see, to me that's not hypophysitis.
But Gordon, hypophysitis is, as you say, it's a global term that encompasses various mechanisms. So it can be caused by immunotherapy agents. It can be caused by ruptured craniopharyngiomas. It can be caused by secondary infiltration and metastases. It can be caused by systemic inflammatory disorders and infections. I think it's a region of inflammation.
I wonder if that's the reason, as Dr. Vina said, maybe what's happened is that there's prolactin inhibiting factor that normally would cause a hyperprolactinemia that's coming down, but the pituitary adenoma is damaged, pituitary gland is damaged, and it can't do anything about it. So maybe that's the issue, is you have both the problem of the stalk, but you also have a bigger problem of the gland itself.
Oh, absolutely. That's what we see with metastases. Metastases to the pituitary gland is a complete wipeout of pituitary function.
Our excellent radiologist has commented on the feature of pachymeningitis. Do you agree with that, and that there's actually potentially more than one mechanism at play, including direct cavernous sinus infiltration and perhaps multiple cranial nerve involvement from a pachymeningitis?
Yes, there's dural involvement of this condition, and that's why she's got the ophthalmoplegia. She wouldn't have it if it was just a pituitary disease.
Yeah, it's well posterior to the cavernous sinus.
So where would you hang your hats then? Is this IgG4 hypophysitis, a pituitary adenoma gone bad, granulomatosis with polyangiitis causing hypophysitis and pachymeningitis, or something else?
the patient is ANCA positive. So
correct.
ANCA could be positive in TB and sarcoidosis and giant cell and Crohn's. So I mean, it could be positive in so many conditions.
Okay. Well, you know, my working hunch, if people don't mind if I go on, was that if we looked at the ANCA positivity, the hypophysitis, clinically and radiologically, taking into account Gordon's comment about what exactly is hypophysitis, and then the pachymeningitis, we look at where are these most likely to overlap in this patient. So this is a slightly abbreviated list for both, but IgG4 disease is on both lists. GPA is on both lists. Sarcoid is on both lists. But I thought with working with what we have, the most likely kind of contender would be GPA, notwithstanding all the excellent comments that have been made. And we thought the answer might be found on a chest CT scan. You know, tissue is the issue because she did have a spiculated lesion in the right upper lung lobe. But unfortunately, as is often the case, frustration abounds, and there was just fibrosis with lymphoplasmacytic inflammatory infiltrate. But some pertinent negatives did emerge in that she had no signs of IgG4 involvement and no signs of malignancy without granulomas. So at this point, does that clarify or muddy the waters?
Well, for PGA, you do need tissue diagnosis because all we have is ANCA positive test, nothing else.
What about the strength of, do you think the strength of the clinical syndrome biases you in any direction with everything you know? I mean, I know the IgG4 is the Kardashian of inflammatory, hypophysitic syndromes right now, but not everything is IgG4. And sarcoidosis could do this as well.
Exactly.
But I think what we thought, and people can disagree, the good thing is the treatment would be somewhat similar and for many of these entities is that the patient likely had hypophysitis and pachymeningitis, presumed secondary to GPA, with possible, multiple cranial nerves involved because of the pachymeningitis and then the cavernous sinus findings, without orbital apex involvement. And she was treated with high-dose Go ahead.
Was there so much fibrosis that they couldn't assess the vascular? Because my understanding is that with GPA, one of the key features is the vascular the vessel involvement. So was it just I mean, if it was plasmacytic or lymphoplasmacytic, I would have expected that there would be enough vessels to look for the specific histologic features of GPA.
No, it's an excellent point, Neil. And I always go, look at the report and I speak directly often to pathology, just like I do with radiology. And my own sense is sometimes we follow the prudence is the better part of valor approach in terms of us trying to obtain tissue, which is prudent and good. But then we run the risk of simply getting a scant biopsy specimen. And I think that was the problem here.
It's a multi-system disease. So couldn't a biopsy be easy from the nose?
I think that there was no evidence of sinus involvement. And there was a little bit of, I think, attrition in terms of the patient's willingness to be poked and prodded, because all of this happened in a fairly concentrated period of time. And also during a time where we weren't, go ahead.
I was just going to say, no kidney disease in this patient.
No, and in the tincture of time, I think all will be revealed. But currently, and I think that's important. Currently, we think this patient has hypophysitis and pachymeningitis secondary to GPA. She's responding beautifully to high-dose corticosteroids and rituximab, but admittedly, many things will. But my own personal approach is to really, hunker down for a marathon and not a sprint. And really just look over the period of time. If new information or new tissue becomes available to biopsy, or any fork in the road changes my sort of working diagnostic hypothesis in this case. But I think the weight of the evidence probably most firmly rests on this diagnosis, although some may disagree.
Thank you, Dr. Fiona. That was quite an eye-opener. You have another case, isn't it?
Yeah, like,
Yeah.
is everyone still with me? Are we taking too long?
Please go on.
Okay. So this is expect the unexpected when you're at a crossroad. And what I think is really important to point out, again, reiterating what other good people have said and highlighting again to Uma's point, we can get very much framed and anchored in the kinds of things we see. So I see a lot of systemic inflammatory disorders causing neuro-ophthalmic findings and primary central nervous system demyelinating syndromes. I think that we all see a lot of those things. I think my practice is somewhat more skewed than others, and I'm a neurology trained neuro-ophthalmologist. So I have to be really careful of my diagnostic scotomas in terms of not labeling everything inflammatory, even though every fiber of my being wants to sometimes. And you'll see the challenge that this case posed. So this is a 24-year-old tennis player, and he presented with a painless progressive vision loss. He says it's been ongoing for several months, and he's not exactly sure when it began. He has no other personal relevant history, and his family history is negative. He's using no medications, very healthy. Okay, so his visual acuity is count fingers in the right eye and 20/40 in the left eye, which is concerning. His intraocular pressures are normal. He has a right relative afferent pupillary defect. That's no surprise. He's quite severely impaired in the right eye. His color vision is non-recordable, however, even in the 20/40 eye. So this is concerning to me as a more optic nerve involvement than this acuity would reveal. His ocular motility testing was normal. Otherwise, I would have drawn more videos for you. So these are his baseline visual fields, which are obviously concerning. So he has, a dense central scotoma in the right eye, but as we all know, it's not the bad eye that really is most informative to us. Sometimes the localization with fields, it's, the so-called good eye. So here he had on the grayscale is somewhat, so you could call it a superior arcuate pattern of distribution, but he's got a diminished foveal threshold. We know he's down to 33. We know he's got some central depression of the vision because he's 20/40 in that eye. And these are alarming. These fundus photos reveal that he's got quite significant optic atrophy already with pallor in both eyes. The remaining findings of the fundus examination were completely normal. And the OCT shows there's not much room to go here. I'm not going to be really able to rely on this test because he's almost at the floor with respect to his peripapillary RNFL measurements, which are in the ballpark of about 60. And, he's in the 50s with respect to his ganglion layer measurements. So a lot of damage has preceded our initial appointment. So he wasn't kidding when he said, I've had slow, progressive, painless vision loss. And in fact, is somewhat of an understated fellow. So I will ask the experts to weigh in, our panel, on these imaging studies and what you would call this at baseline.
Okay, so basically these are all T1 contrast and non-contrast images. There is involvement of the right intracranial optic nerve. There is a bulky chiasm, and there is some patchy enhancement. That's all I can comment on these images.
Dina, that's excellent. And that is exactly what the radiologist said to me, word for word. You must have talked together before this symposium. Now, can you tell me, if you're the reporting neuroradiologist, what your differential is going to be in the order it's going to be? When you direct people like me, because I need help, what are you going to say? Consider the following.
Well, some kind of either it could be some kind of a neuritis, like a demyelination. Was it a vision loss acute or gradual?
He says it's very gradual, which bothered me, and it was painless.
Okay.
But I agree. I think that patchy sort of inflammation would make that a contender on the diagnostic differential, absolutely.
Yeah, so if it is a gradual drop and if the history is really correct, then we would think of other differentials Of course, in our country, we always put granulomatous as a differential in any pattern. So I think that's it.
That's
I
fantastic.
think it has
Thank
to
you.
be it has to be some sort of intrinsic infiltrative process. So a low-grade glioma, even in an adult, can occur. An inflammatory process, but there's no pain. But obviously, you have to consider sarcoid. Some lymphomas are very, very slow in terms of progression.
Do you
So
think?
Neil, what do you think? Yeah, can I ask? I'll just ask Neil this. I think it's excellent with that thickening. You know, the other interesting thing is this radiological pattern has been even described in Leber's. What do you think, Neil, with the extent of the vision loss, with this being a low-grade glioma in this gentleman who's an adult with no history of neurofibromatosis type 1, and in fact has no stigmata of that condition?
Well, the thing that has always bothered me, or one of the many things, is that the histology of gliomas there's often a disconnect between what we see with imaging, what we see with histology, and what we see clinically. So it's unusual, but it occurs. We see that, that's our usual mantra as neuro-ophthalmologists. We see that. So it doesn't bother me that much. I'd prefer something more like sarcoid or TB, but it's just so slow that bothers me.
Okay. And what about Leber's? What do you think of the likelihood of that diagnosis?
There's no central scotoma in the seeing eye, so probably Leber's usually begins with a central scotoma. So I would not.
And that I've never seen a Leber's, or never recognized a Leber's that was that slow. I mean, usually the nadir is 3 to 6 months. And although Alfredo Sadun has said there's a continued slow decline, I've never been sure whether that was simply age related in a nerve, or in nerves that already had lost a lot of axons. So Leber's would not have been on my differential.
Can I make a comment about the tumors, Fiona?
Go ahead, please.
Please do, Gordon.
Well, the tumors we see mostly are the most benign form, the
Histiocytic.
Yeah, pilocytic astrocytoma is associated, and also the malignant gliomas, which are very aggressive and occur in older people and are usually occurring elsewhere in the brain. But I've seen a few cases which are astrocytomas in between the two. I mean, you'd call a grade 2 or something like that, a grade 2 astrocytoma. We've even seen them invading the retina, coming visible in the eye, the anterior optic nerve, and these go at about this pace. It's very different from the two that we see most commonly. And I was going to point out that I think the radiologist agrees that the right optic nerve prechiasmatic is thickened, isn't it?
Yes. I would also look at the T2 weighted images, especially to look at the surrounding brain. Sometimes there may be edema in the surrounding area, which would give you a clue, if it is some kind of a neoplastic versus inflammatory etiology. The enhancement in the chiasm is not that much. It's very patchy, at least in the actual images. The coronal is a non-contrast T1. So it's difficult to comment on the pattern of enhancement at the chiasmal level.
Those are all really helpful comments.
I agree with Gordon that sometimes you see a more aggressive astrocytoma, or even something like a ganglioglioma or something of that nature, an oligo or something of that nature. So it doesn't have to be a pure pilocytic.
Well, I'm reluctant to agree with Gordon, but I find myself committed to doing so because, I think 3 subsets of gliomas of the optic nerve have been described. These grade 1 pilocytic astrocytomas that are quite indolent and often accompanied by good vision. Then on the other end of the spectrum, we have our unfortunate, glioblastoma multiforme types. But there is this low-grade aggressive glioma subset that is emerging in the literature, bearing in mind that this is quite a rare diagnosis, but a consideration and a broad differential at this point. Okay, those are really helpful comments. So do you guys agree with this approach? It was a bit of a grind, because to the really excellent points about this being potentially inflammatory, and I admit my own bias, I see a lot of patients with neuromyelitis optica spectrum disorder, MOG antibody associated disease. I see patients with GPA. I looked at things like syphilis, of course, HIV testing. The spinal MRI was really done to look for disseminated white matter lesions that were otherwise not apparent in the cranial imaging. A CSF analysis was done to look for signs of lymphoma, signs of, oligoclonal band positivity, bearing in mind the really, really important points made in cases before this one that's somewhat non-specific. A CT chest, abdomen, pelvis was done and then repeated. And this took me down the rabbit hole a little bit, because this patient did in fact have hilar lymphadenopathy. And I thought, okay, great, this is it. Like, I figured it out, this is sarcoid. And all the while the patient's being treated with steroids, and he's endorsing some improvement, but I'm not convinced that there is much. But he did hold kind of steady for the first 6 months of this course. But I actually had him bronched, and this was just reactive lymphadenopathy, no proof of sarcoid. And then, kind of near the year mark, he describes over the phone very classic cluster type headaches on the right side, which intrigued me. And I brought him in and had to haggle pretty hard during trying times to repeat this imaging study. But I was very concerned about another thing he told me, which is that his vision now is deteriorating a little bit. And I'm mindful that this patient is a very stoic person who tends to, if anything, underreport. And again, you'll see what I mean. So now he's no light perception in the right eye and 20/60 in the left eye. And he has iopidine proven right corner syndrome in the setting of this new cluster headache with a right relative afferent pupillary defect and a sensory exotropy on the right eye with, again, non-recordable vision. And this is his visual field. Anybody want to comment on these? And I couldn't obtain any visual field owing to the fact that he's no light perception for the right eye.
So he developed a temporal field defect.
He's gone chiasmal.
Okay.
Yeah. Yes, now it's chiasmal.
Yeah.
Okay, and he's still pale. So what could we be missing here?
The tumor is growing backwards and involving the chiasm.
All right. So what do you think of this imaging here?
So it's obviously progressing both forwards and backwards. The optic nerve is thickened and the chiasm is thickened, much more thickened than it was earlier.
Okay.
And very far anterior too. Look how far anterior it is in the orbit.
Yes.
It's grown both anterior as well as posterior.
It's turning malignant.
Okay. So here we have, thickening of the chiasm with enhancement that's extended into the right orbit you see here. What do people think this is?
Do you think that the amount of enhancement is actually less than, if you look at the difference between the cavernous sinus pituitary area and the sinus mucosa and the enhancement, it's not nearly as enhancing as I would have thought if it were say, sarcoid or an inflammatory process. I would have thought that it would have been a lot more enhancement. So my money's still on an infiltrative tumor. And I wonder if it's one of these things, as Gordon was saying, we get used to thinking that it's either a benign pilocytic or it's a malignant, rapidly progressive, as we heard yesterday from Val, tumor. To me, this looks like it's somewhere in the middle.
I think lymphoma also should be considered in the differentials.
So what was it?
So, you know, it's pending. I think these are all good points, and I'll just take the crew through these diagnostic differentials. So here we have a patient who has evidence of neuromyelitis optica, starting off with this chiasmal enhancement. Here's a Lieber's case. These are all reported in the literature. This is a case of zoster infection causing both this posterior scleritis and chiasmal enhancement. This is a case of lymphoma. Now remember, our patient's been very thoroughly evaluated systemically with no signs of lymphoma. Here's a case of a toxic metabolic chiasmal thickening enhancement, and this is what a glioma might look like. And so the pathology is pending at this point for this gentleman. But I think for the benefit of listeners, what we should keep in mind is most of these intrinsic chiasmal lesions in the top row, including congenital causes, genetic causes, radiation necrosis, toxic metabolic causes, and trauma, can be ruled out by history. These other benign lesions, including cavernomas, causes of systemic inflammation, CNS demyelinating disorders, and idiopathic chiasmitis, these are ruled out by investigations and as well by course, which leaves us really with infiltrating neoplastic conditions and primary neoplastic conditions. So this is a case that will ultimately be revealed again in the tincture of time as the pathology is pending, but I certainly appreciate the thoughts that have been helpful in weighing in thus far.
When you say it's pending, has the patient been operated or is
Absolutely.
the surgery pending?
Yeah. No, the patient's had the operation.
So what did they find? They must have done a frozen. What did the frozen show?
You know, the preliminary thoughts are this is actually a case of a germinoma potentially, with no neuroendocrine abnormalities, no diabetes insipidus, and no other radiological findings, Neil.
We had a similar case of germinoma, a young girl who presented with such a bulky chiasm involving also the intracranial optic nerves. So, but it was bilateral nerves and the chiasmal involvement. Ambika?
Yeah, exactly. Because that's the reason why we were able to, say, because the child came with a monocular vision loss and it was only a thickened optic nerve. And the child was referred to me as a NMO spectrum disorder because the thickening of the optic nerve and the enhancement was up to the chiasm. And we kept the child on, the patient was already treated on steroids and all the immunosuppressants by the time I saw. And myself and Beena, we were following that child for a while, and then the child again started developing an increase in the chiasm thickening. So we gave an option or a biopsy to the mass, and when we did the biopsy, it was a germinoma.
Thank you.
Ambika, was it involving the orbital portion of the optic nerve as well as in this case?
It was to a certain extent orbital, intracanalicular, and intracranial, Dr. Miller.
Wow.
Thank you. I think we have another session after
That's
this.
very helpful. Thank you.
We are running short of time. I think I'll ask our next panelist, Dr. Vashni, to introduce our next speaker, and we can have the discussion after the two cases. Dr. Vashni, yeah.
So it's my privilege to introduce Dr. Gordon Plant. He has done his graduation from Cambridge University, and he's double specialized in neurology and ophthalmology. He's also spent time in vision science, supported by the Wellcome Trust, and as a Medical Research Council traveling fellow at Smith Kettlewell Institute in San Francisco. In San Francisco, he attended clinics with the late Dr. Bill Hoyt. Subsequently, he was a consultant in the National Health System. While at NHS, he has published more than 300 articles and has a keen interest in teaching. He has trained a large number of fellows from both neurology and ophthalmology backgrounds. Dr. Plant has recently retired from clinical practice in 2020, but fortunately for us, he remains very active in research and teaching. It's my privilege to invite Dr. Gordon Plant now to share his cases with us.
How am I doing?
Yeah, all good. It's good.
I'm going to show two cases very quickly, and then it's over to the panel. What was that noise? The first case is a 40-year-old Scottish white female who has no significant past or ocular history and has a 4-year history of difficulty reading. She has a particular problem that when she's viewing people's faces at a particular viewing distance, there's a distortion of the appearance of the face. As people come closer or are further away, she doesn't see this. When I saw her, she'd had these symptoms for 4 years, as I say, and she'd had multiple ophthalmology opinions. And this was in the pre-OCT era. She'd had 4 fluorescein angiograms as people were looking for a maculopathy, but everything had been normal. That was Humphrey 10-2 field. So that's the first case for discussion. Then the second case. Is everyone getting a background noise?
No. We can hear you well.
I can hear a whooshing noise in the background. You don't hear that?
No.
No.
Oh, good. I'll ignore it. I'll ignore it then. So this is a 36-year-old civil servant, British but South Asian origin. And he has a complaint of an increasing frequency of migraine with aura. Other than the diagnosis of migraine, he's had no significant past history. And here you can read his description of the aura. So it starts with a star-shaped pinpoint of light in the right lower visual field. This expands into a circle, then a horseshoe shape, and it's a zigzag pattern. And over many minutes, it expands to occupy the entire right visual hemifield. Total duration up to 60 minutes from the beginning and end of the attack. Usually, but not always, followed by left occipital headache, and this will be relieved by analgesics and sleep, particularly. During these attacks, he would, or following the attack, he would be photophobic, but he never had nausea or vomiting. And he found that drinking concentrated orange juice could reliably precipitate an attack. So here you can see his visual fields, 30-2, normal. Actually, it's 24, isn't it? Things changed a little bit after the age of 30. So he'd had these attacks for 10 years, and he would find occasionally that he'd have an episode of a small star-shaped flashing light lasting much briefer than the other attacks. And this would, as I say, last for 10 seconds and then disappear, but also always in the right lower quadrant. And here's his drawing. So this is this is his, we drew the 4 quadrants here. This is his fixation. And then early on, it starts like this bright star, and then it'll get this big. And then by the end of the attack, it's like this. And he's just given an impression here of these zigzag lines he has around that. So those are the 2 cases. How would people investigate the first lady?
I have a small comment. Both the cases had normal visual fields. So
yeah, I showed you. Yeah, sorry, you're stating. Yes, I've shown you.
So I think the problem in both the cases lies retrochiasmal, and it's not in the eyes, definitely.
It's not in the eyes. Agreed. But how will we find out where it is and what's going on?
You do an MRI.
Yeah, but I'm not going to show you an MRI. I want you to tell me what this lady's symptoms could be due to.
Easily be in the occipital lobe, and both the cases could be localized there. Either of them, triggered by occipital lesions.
I agree entirely. We're dealing with conditions that are affecting both eyes, aren't we? Either a positive symptom, although of course, if patients have positive symptoms affecting one eye, they can sometimes find it difficult to say that it is monocular or binocular. And one of the
was it to one side or another, or did it involve the entire field? Or could the patient tell?
What, this first case?
Well, either of them. Was it a suggestion of a hemianopic occurrence, or was it the entire field of both eyes was involved?
No, it had a hemianopic flavor to it, definitely. So this distortion, if we go on, I think I can, for the first case, this was the distortion. So the person that she was viewing would have to be about 2 meters away. If the person came closer, then there wouldn't be this effect. If the person was further away, there wouldn't be this effect. And what she described is the other person's left cheek, to her right, obviously, to the patient's right, appeared to be sunken in, as if, she said it was like molten, as if it was molten wax. So
I was trying to decide if this was the temporal crescent that was being affected, or if it was far enough peripherally.
Well, no, Neil, this face is 2 meters away. She's viewing the nose here. Oh, that's what we're talking about. We're talking about 5 centimeters, 2.5 meters distant.
So it's inferior quadrant.
Well, that's how I've drawn it.
Yeah. So of the face, it's inferior to the lower quadrant.
Yes. So Neil, this would have to be a paracentral homonymous effect because of the dimensions of what she's looking at here.
Well, you could do a multifocal VEP, I suppose, but you already know pretty much where this is.
Yes, but
yeah,
I wanted to show that. Yes, Carmen.
Are the symptoms intermittent or constant?
Oh, absolutely constant.
Constant, and you're able to reproduce
whenever
it.
she's in this situation, it's always like this and has been like this for 4 years. Remember her other problem, though, which I want you to explain, is difficulty reading.
Right. because just the whether it's intermittent or constant probably determines what the, well, we know that there should be something on the MRI, right? So if it's constant, it's probably less likely to be epilepsy, because obviously it can't be constant all the time. So anyway, I'll wait for the answer.
Well, for this first case, just to finish with this first case then, has anyone come across anything like this that a patient's described, or in the literature, where there's this homonymous distortion?
I presented a case similar to this at the Walsh conference a couple of years ago with a heavy metamorphopsia of a face that was occurring intermittently, and the patient ended up having intravascular lymphoma. And we also had one case of Creutzfeldt-Jakob disease that had a similar kind of phenomenology.
Yes, that's very true. So presumably there was no visual field defect.
There were non-specific visual field effects in the first case. I don't remember on the second case, because that was several years ago.
Because Avi Safran described what he called the thin man syndrome.
Right. Yeah.
The difference there was that was a very large scotoma. So the whole person standing in front of him appeared to be very thin, because the relevant side of the person's body did this kind of thing. So this is a special case of metamorphopsia. This wonderful series of paintings was done by an artist who had an occipital meningioma, and he didn't have these symptoms pre-op. This was all post-op, while they're all doctors and nurses here, and clearly he had a left occipital lesion. But this is the more typical metamorphopsia that you see with occipital lesions, and I think probably this would have related to your Jakob Creutzfeldt patient, but definitely. But what tends to be there is that the distortion is bizarre and often grotesque and frightening, whereas our patient's distortion was just really a combination of filling in. So she's not aware of the scotoma, so the scotoma is filled in. But when there isn't enough information to do a good job of filling in, then you start to get this distortion. And what Avi suggested was, we agree with some work we've done on this, is that there's some remapping in the cortex around the scotoma. So we actually have some anomalous wiring, spatial wiring, and that gives you a different type of metamorphopsia, which can be explained on a Cartesian basis of rewiring. So in that sense, it's more like the metamorphopsia that you see with retinal disease, which is where the cones the cone layout is distorted, but of course the brain doesn't know that, so it interprets. You get macropsia and micropsia due to that. But what the thing is, what I did was a tangent perimetry. And the reason I use tangent perimetry, I've heard people discuss at meetings the resolution of perimetry and how to find very small scotomas. Well, the only limit to the resolution of tangent perimetry is the curvature of the Earth. The further away you get from the patient, the higher the resolution. And I just thought, just in case there's any flat earthers watching, you have to get up to 30,000 meters to be able to see. All of the pictures you'll see of the curvature of Earth are due to distortions in the camera lens, but this is really it. Anyhow, so I did my little calculations as to what I thought as to what I thought the, oh, damn, as to what I thought this scotoma would be like. And I did a tangent, I carried out this tangent field at 456 centimeters, just thinking of this 4 centimeter face at 2 meters, with a target size of 2 centimeters, which at that distance is 1/4 of a degree, binocular viewing. And then, so at that distance, this is 1 degree of visual angle, there's the fixation. And I was able to plot the scotoma. It just needed a bit of space. It only took about 2 minutes to do it. And so I think that tangent perimetry still has a place. And in fact, you can plot angioscotomas on tangents, but you can plot scotomas due to the retinal blood vessels. It has that degree of resolution. So, so this was Avi's paper. Our patient, no one had ever found an abnormality on the MRI, but she did have, as you would expect, a lesion a little bit smaller than this. It was a while ago, and I don't have the original images anymore. So this is a case of a small homonymous scotoma. And then, so why did she have difficulty reading particularly with such a tiny scotoma? If you all shout at once, it gets confusing. You're allowed. Well, the thing is, when we read, we're actually also always looking ahead. For left to right readers, we're always looking ahead into the right visual field, because as we make saccades across a line of text, these are not random or regular. They are carefully calculated according to what's coming up. So when we're reading English, we don't make a saccade to the or but, and we tend to make saccades to the beginning of long words, because the end of long words tends to be tion and ing and so on. So for efficient reading, we're always looking ahead. So patients who have these homonymous scotomas, which are to the right of fixation, if they read from left to right, they will just make a series of small saccades across the line, which are not which are a bit random. And the corollary of that, which when I was looking at this with Alex Left some years ago, is that if you have macular sparing with a right homonymous hemianopia, it doesn't impair reading very much at all. It has to be macular splitting. So you only need that 4 or 5 degrees to be able to read efficiently. So well done.
Gordon, I was actually asked to write an editorial on that paper of Avi's, and I thought one of the interesting aspects, and you showed that in your drawing, was that he only found the thin man phenomenon in the inferior, with the inferior homonymous scotomas, not superior ones. And I thought that was suggestive.
Yes, it's very interesting, isn't it? Yeah. There's just to point out, this was quite a nice demonstration that these small homonymous scotomas can be difficult to detect, and it can be difficult to see the lesions causing them. But the ganglion cell layer analysis has made it much easier. Neil will remember some years ago, I put forward the idea that there's transsynaptic degeneration in the retina with occipital lobe lesions. And we had to jump through hoops looking at the retinal nerve fiber layer. And of course, I got there was a lot of skeptical comments about that, because a lot of people didn't believe it. But actually, you can show that all of this much more easily in the ganglion cell layer. And of course, it corresponds exactly to the visual field defect. And basically what we found looking at the nerve fiber layer has been confirmed by everyone who's looked at it this way.
Gordon,
I guess another point that ought to be made is you pointed out metamorphopsia occurring in non-retinal lesions. There have been a couple of reports of metamorphopsia in chiasmal lesions. So it's not just a retinal phenomenon by any means.
No, and I think that what we see in the retina is quite different from this kind of thing. Yes, Val.
One comment just about the Jakob Creutzfeldt. We presented a case at Walsh some years ago and then published it. Jakob Creutzfeldt with homonymous hemianopia and much distortion, but and bizarre distortions of where things were in space. A car looked like it was 4 feet above the ground, and the cow looked like it was on the roof of the barn. But the distortions weren't particularly in the homonymous field defect, which I suppose speaks to the multicentric or more diffuse nature, multicentric really, of that disease. But I'm stuck on your first case. I'm still stuck at the very first slide. So the issue of the distance from the patient, viewing distance, determining whether this face was distorted or not. So I guess the point is that viewing distance changes where the scotoma fall, where the image that has the scotoma in it falls on the retina. And
Yes,
I'm still puzzled by why, when we look at faces, there's strategies that have been well worked out for how we explore a face. So there's an eye movement with that. We don't do it like you do a visual field. You don't look at the center, at the nose, and notice the eyes and mouth. You like look around it, and you look here and there, and do all. So it would be constantly moving. So it would be an odd viewing method that she'd be using, which she must have been a very observant person to like, well, what if I don't look around at the face? What if I just stare at the face and look for, maybe she also had CPEO and she couldn't move her eyes around rapidly. But it's just I'm still on the very first slide. I was listening to you and watching with great interest, but I'm still stuck on trying to figure out how she figured that out, and because I think I mean, I would have explored the symptom, but I would still be stuck on how could that be? What is the nature of that observation?
Well, I think the viewing distance is very important because, of course, in order to get the thin man effect, you have to have the border of the subject within the scotoma. Otherwise, you'll get complete filling in.
Right.
So the fact that just at that particular viewing distance, the patient's cheek was within or at the border of the scotoma. And yes, indeed, but she's had 4 years with this symptom. She's had a lot of time to work things out, and she knows that she has to look at the person. She would have noticed it one day just in a casual glance, and then it happened again, and then she starts looking at faces. They have to be a certain distance away. She's had 4 years to work this out.
That's true. Maybe an engineer could have done it in a couple of months, but most of us would take 4 years to get it. Okay, got it. Thank you.
Yeah. So yes, she has to look steadily at the patient's nose to get the effect. The subject's nose to get the effect. The subject has to be exactly the same distance apart, so she doesn't get a distance from her, so that she doesn't get a complete filling in.
Right.
Anyhow,
and also on your second case, just some very interesting features of it, but the combination of very classic migrainous scotoma with the slow spread being the real deal, right? That's the real thing that tells you it's migraine, except that every once in a while it's stimulated by an actual structural lesion. So we had a patient like that with an occipital, so Neil mentioned the temporal crescent, a young 19-year-old boy with a very tiny little AVM just at the outskirts of the occipital lobe, causing these sparkles throughout the day, too often to be migraine, just in the periphery. And on his field testing, all he had was the temporal crescent, but he also occasionally had a full-fledged regular migraine, 20-minute.
Yes, so this, what was interesting about this chap was that he'd had what would you would accept as a pretty typical migraine aura in terms of its duration and all the rest of it. But it always started in the same place in the visual field. And we're talking about hundreds of attacks, always starting in the same place in the visual field. Because migraine is not a localized disorder. It's some kind of channelopathy affecting the brain, isn't it? So most patients with migraine will say it shifts from one side to the other and left and right and so on. So this always starting in the same place. Then the other, but this is not like occipital epilepsy. And as you can see here, what he actually had was a cavernoma, an occipital cavernoma, which wasn't causing a visual field defect. But then he also had these other attacks which lasted for only 10 seconds with just these brief flashes. So he was tried on various treatments. So this is just a 6-month period, and this shows episodes of aura, the blue dots with duration here on the vertical axis. See most of them half an hour. And the red arrows are when he got headache. And he was tried on a beta blocker and on pizotifen, but sodium valproate completely abolished these attacks. And he's been taking it now for several years and has never had one single attack. And last year I saw another patient with exactly the same phenomenon, an occipital cavernoma causing a migrainous aura, and he's done exactly the same thing. He's responded to sodium valproate better than any epilepsy I've ever seen, and better than any migraine I've ever seen. Which
what is the relation to orange juice?
It's a known migraine thing that the whole question of looking for precipitants in food of migraine goes back many years, and it's generally not very important. I mean, there was a period when I was just first started at Queen Square as a senior house officer. There was a clinic there where they were putting people on pears and lamb. I remember they weren't allowed to eat anything but pears and lamb. Of course, yeah, vegetarians, hard luck, but pears and lamb. And then you gradually introduced one more food over many months. And when you had the food that was going to cause the migraine, you knew what it was. But I didn't. But there's still many patients who complain of specific foods, and orange juice is one of them.
Back to that. I have a question about the side switching. So I agree that when a patient knows that sometimes it's on the left, this is for migraine, sometimes it's on the right, totally reassuring. I get that. But that issue, I guess the question is how alarming, how much of a red flag is it when the patient says, no, it's always on the right side? Because what I learned was a term called side-locked migraine. I think this was from Donaldson's book. And I think the number I learned was like 20%. Or maybe even a bit bigger, but I think 20% were what's called side-locked migraine, which means—
Does that apply to the aura?
The migrainous aura, just, it's always up, right, not which side the headache is on, but just the visual aura always on the same side. And so the question is, what works as a red, like would you scan anybody? If you scan everybody that says, oh no, it's always on the same side, you'd be scanning a lot of people for nothing.
I agree. I know side locked in terms of headache, but yes, no, some patients it's much more the other way around, that as soon as they've said it, it switches sides. It's very unlikely to be a structural lesion, but you've got to go on all the other evidence to decide whether to have a scan or not. So this is so rare. I mean, I put together all the cases I'd ever seen with migraine or aura that fitted the migraine phenotype, visual aura, that I'd seen in whatever it was 30 years. And I've seen thousands of patients with migraine. And I can't remember, I think, how many there are in the series. I think there's about 12, something like that. It's very, very, very rare. But often there were other clues as well. The most important clue is a visual field defect. That's really, really important. If the patient has a visual field defect, that should not happen in migraine. So that's
what I was going to ask you, Gordon, because we had a case, a lady with known breast cancer who started to have had a history of migraine, but began to have them always on the same side, associated with field defect. we did imaging and initially couldn't find anything, and the field defect grew over months, grew and grew and grew, and eventually imaging showed the metastasis.
Well, isn't that fascinating? Yeah. So yes, if there's a visual field defect, but they can be very, very small scotomas, you see, and you have the same problem. You need to get your tangent perimetry kit out to find them sometimes.
Gordon, do you have any more slides?
No, I don't think so. Oh yes, I was just going to show. This is the classic migraine aura, which is called, the term teichopsia was coined by Hubert Airy, and it's from the Greek walls. Teichos is a wall in Greek, so it's wall vision, and that's because this resembles a bastion type of fortification. So it's also known as fortification spectrum. And this is more typical of occipital epilepsy. So this was my colleague from St. Thomas's, who's an epileptologist, asked his patients with occipital epilepsy to make drawings of their symptoms, and some of them are overlapping, like in our patient getting zigzags, but they're more likely to describe colored circles. This actually is not the patient's drawing. This patient said, "Oh, I can't draw, but this is what it looks like." This is actually Christmas wrapping paper, and these are Christmas baubles in soft focus on a Christmas tree, giving the same effect. And I think that you can explain this if you can show that epileptic activity in cortex will activate the orientation columns in striate cortex, and migrainous spreading depression in striate cortex will activate the orientation columns, giving the zigzag, whereas epileptic activity will activate the color cells, giving colored shapes without the lines. So that's Plant's theory of occipital epilepsy and migraine. Thank you all.
That was wonderful, Dr. Plant. Thank you. We'll move on to the last case, and I'll request Dr. Samira to share her screen, please.
Okay. Right, it's visible?
Yes, please, you go ahead.
Okay. So it's better to have a painful than a painless orbital lesion. So my patient is a 50-year-old lady. She presented to a general ophthalmologist with sudden puffiness of the left upper lid. It was painless, non-itchy, with slight congestion under the upper lid medially, and the ophthalmologist could feel a small, soft, non-tender swelling in the upper part. So he diagnosed as eclasion, gave her some steroid antibiotic, eye drops, and cream, and sent her home. Within 1 week, the swelling increased. Her eye became protuberant. She was unable to close the lids, and she went back to the ophthalmologist again. And this time he was alarmed and he referred her to the oculoplastic surgeon. So her presentation on the 10th day was a painless lid swelling with a prominent eyeball, inability to close both the upper and lower lids, along with horizontal diplopia. Her health was perfectly fine. Otherwise, she has no weight loss, fever, headache, fatigue, normal appetite, no bone pains. She was non-diabetic, non-hypertensive, and she never had any problems in the past. So perfectly good health, and she develops this. On examination, her vision was 6/6 in both eyes. Ptosis was axial. It was both the eyelids were full and markedly non-tender swelling. With ptosis, upper lid, and she of course couldn't close her eyes. On retropulsion, the lids felt very tight, and extreme resistance felt to press the eyeball backwards, so as if something was pushing it out. She had ophthalmoplegia in that eye. The movements of the right eye were absolutely fine. She had chemosed conjunctival congestion and cornea due to exposure keratopathy. She was developing SPKs. anterior segment was quiet, the discs were healthy, there were no choroidal folds, and color vision was normal at that time. So what do you think I should do in this case?
And immediate imaging.
Yeah.
Immediate imaging. See, because she has an acute proptosis, and depending if it was a painful proptosis, then it points to an inflammatory or an infective condition, but it was painless and acute and rapidly progressive. So in that case, it was most likely, and because of axial nature, most likely malignant. And in this case, axial proptosis, there is in the intracorneal region, there is fat, lymphoid tissue, vessels, nerves. So it could be a primary tumor, a secondary infiltration from the adjacent organs, like nasal sinuses, nasopharynx, lacrimal gland, lacrimal sac. But they would all lead to a non-axial and eccentric proptosis. So secondary infiltration was mostly ruled out. So it could be either a primary or a metastasis. So metastasis from breast, from kidney, lungs, and they are frequent in the choroid, but her fundus examination was normal, or in the intracorneal fat, or in the recti muscles. So an urgent MRI was arranged and a hemogram. Hemogram is a very simple test. So in order to exclude any inflammatory or otherwise condition, you get the result in an hour. So it's important to have that. And an urgent MRI brain with contrast. At the same time, because she was developing exposure keratopathy, she was given lubricant eye drops and ointment along with a beta blocker, because her pressure was also about 22, and steroid eye drops 4 times. Her hemogram, the next day she came and the swelling had increased, her condition has increased, but the vision was still 6.6. But it was markedly swollen, still non-tender, absolutely non-tender. And the hemogram showed a marked anemia, low platelet, low red cell count, white cell count, absolutely within normal limits. And she had a very high ESR. The MRI orbit with contrast showed 3 lesions, 3 tumors, space-occupying lesions in the left eye and another one in the right. So she had a large tumor in the intracorneal space, pressing on the medial rectus laterally. At the same time, another one at the next to the sphenoid sinus, and another third one in the lateral temporal, anterior temporal region. And then on the right side also, there was a small tumor which was present in the extracorneal space. So a perfectly healthy lady, and she develops all these suddenly, which are rapidly progressive. So it was quite alarming, and along with all these counts, they are absolutely low with a very high ESR. So thinking that in mind, that it must be a lymphoproliferative or a myeloproliferative disorder that has suppressed all these counts, and at the same time increased her plasma viscosity so much. So she was urgently, the same afternoon, she was sent to the hematologist and oncologist. And he arranged, because the eyeball was threatened, the optic nerve was being threatened. So she was started immediately on IV methylpred to reduce the ocular swelling and inflammation. And he arranged the bone marrow aspiration and fine biopsy from the pelvis. And it was diffusely hypercellular and infiltrated with sheets of malignant plasma cells. Erythropoiesis, myelopoiesis, and megakaryopoiesis was diffusely depressed. Then he arranged her serum electropoiesis and electrophoresis and immunotyping, and IgG kappa band was positive, and monoclonal gamma protein band as well. Our other parameters, uric acid was high, but otherwise electrolyte, serum calcium was a bit low, and renal function test was normal. So the diagnosis was made of a plasma cell tumor, and most likely an extramedullary plasmacytoma, because it was all present in the bone marrow as well. So it was with multiple myeloma, because if it was only localized to the orbit, it wouldn't have caused the suppression of leukopoiesis and erythropoiesis in the pelvis. She had no problem there. So it was actually a multiple myeloma, which had presented primarily as an extramedullary plasmacytoma, which is a very, very rare presentation. So she was given a targeted therapy with carfilzomib and high-dose dexamethasone along with bone-modifying drugs. She responded very well to therapy, and within 10 days, from day 1 to day 10, her movements came to normal, congestion, everything was normalized after the second dose of this carfilzomib. Every week she was getting the injection, and it responded very well. So she was, I looked at the literature, and these extramedullary orbital plasmacytomas as an initial presenting feature in multiple myeloma is extremely rare. And I think only 3 or 5 cases are reported. Mostly it's a sign of recurrence of multiple myeloma in remission, because these plasma cells, they tend to hide in spaces where they are not being killed by the killer T cells, and then they start proliferating as soon as the immune status of that person is lowered. And usually they come up in a patient in remission, but she was perfectly fine otherwise. So primary plasmacytomas can occur, and they can occur as solitary, isolated in bone or soft tissues. And mostly if they are there in the orbit, they are extracornal. And they can progress to multiple myeloma in 50% of the cases pretty soon. So pain, if it occurs in such a case, it's usually due to orbital bony erosion. But luckily in her, she was still localized to soft tissue and responded very well to treatment. So complications that can occur in such a patient is that it can really compress the optic nerve, which it was happening. If the diagnosis was delayed a little bit, of course, she would have lost that eye. Then exfoliate keratopathy, then crystal or copper deposition in the cornea, and it can affect the choroid along with exudative macular detachment. Bony lesions anywhere can lead to stress fractures. So, and hyperviscosity, her ESR was so high, but then still I believe she's very lucky that she didn't develop the central retinal vein occlusion, and diagnosis was made early. Anemia is a main problem, along with hypercalcemia, low white cell count, albumin, immunoglobulins. They can cause recurrent infections in such a patient. So it's very important to keep her general health well maintained. She needs to be advised how to maintain her health, her anemia, and diet, and therapy. It is important to restore quality of life to such patients, because if proper therapy is done, proper advice, then the life expectancy can be increased from as much as from 1 year to 10 to 15 years. So it all depends how you manage these cases.
So what happened to your case?
Well, she's done very well, and I keep her on regular follow-up, and she's maintaining her vision and eye status. Her profile, all these blood tests, they are getting back to normal. She's due for her protein electrophoresis again to see if the gamma protein, it has come down again. And that is how such cases are assessed. And if the kappa and the lambda chain, they are come down to normal, then the therapy, the targeted therapy is truly tapered, and she'll be given on maintenance therapy. but she has to be kept warned that they can recur anytime.
Thank you. That was a wonderful case. Any one or two expert comments before we close the session? I think you made everything clear.
Okay, so just a few lessons that a painless, rapid, progressive lesion, most likely to be malignant until proven otherwise. And pain is mostly a diagnostic feature of an infective or an inflammatory lesion. An absence of pain is really should be scary. And a proactive clinical approach and a simple blood test, it can save lives and patients' eyes. So any patient who is in remission of a malignant disease, and if any new symptom or growth occurs, it should be considered as a recurrence until proven otherwise. So, thank you.
So there are no comments. I think everything she's explained it all very lucidly. Thank you all for being part, the speakers, the panelists, and Dr. Satya Karna for giving us the opportunity for this session. Apologies, it has got delayed a bit, but we had a good discussion. And once again, thank you so much.
Okay, thanks very much.
Thank you, Jaspreet. So I'll start with the introduction of the moderator for the next session, and that will be Dr. Virendra Sachdeva, who's a consultant pediatric ophthalmology, strabismus, and neuro-ophthalmology at LV Prasad Eye Institute, Visakhapatnam, India. He's done his pediatric ophthalmology fellowship from LVPI, Hyderabad, and he's done his clinical research fellowship in neuro-ophthalmology from Emory University in Atlanta, USA. His areas of interest are complex strabismus reoperations in strabismus, imaging in strabismus, and amblyopia neuro-ophthalmology. He has 60 publications in peer-reviewed international journals. He has written 19 book chapters, including textbook chapters in neuro-ophthalmology, and he's a reviewer for several peer-reviewed journals. Over to you, Virendra.
Thanks, Dr. Satya. Thanks for organizing a wonderful feast. It's been interesting 5 sessions already, and we are looking forward to the last session. And we have a feast of very distinguished faculty taking us through this interesting session. So may I request all the faculty to please turn on their videos and join for the live session. I welcome you all, Dr. Heather Moss, Dr. Prem Subramanian, and then we have Dr. Vivek Patel, Dr. Bhatt, as well as we'll have Dr. Padmaja Sudhakar. Dr. Mark Cooper-Smith will also be joining us for this interesting session. A little late, he has some personal commitment, but he'll be joining us soon. I would like to begin by also welcoming our panelists for taking us through the cases. And I hope you can see the slides. It's a privilege for me to introduce my co-panelists. We'll begin by introducing Dr. Sumit. Dr. Sumit Monga is a senior consultant in pediatric ophthalmology, strabismus, and neuro-ophthalmology at Delhi, India. And he has over 17 experience of working experience in the field. His areas of interest are neuro-ophthalmology and pediatric eye disorders. He did his residency from Delhi, Maulana Azad Medical College, and then he did a fellowship at LV Prasad Eye Institute. Further, he is recipient of many distinguished national and state level awards. He has also conducted an all India survey to analyze the spectacle prescription patterns in children, and he has contributed to various peer-reviewed publications and book chapters in pediatric and neuro-ophthalmology. Our next panelist is Dr. Swati Fuljale. She is an Associate Professor of Ophthalmology at Rajendra Prasad Center for Ophthalmic Sciences at AIIMS, New Delhi, India. She did her post-graduation in ophthalmology from AIIMS itself. Her areas of interest are neuro-ophthalmology and strabismus. She has been awarded the AIOS Singapore National Eye Center Fellowship in Neuro-ophthalmology. She is the section editor for Neuro-ophthalmology for Indian Journal of Ophthalmology, and she is the managing editor for INOS E-Times, which is the e-publication from Indian Neuro-ophthalmology Society. She has over 80 publications, including book chapters, 15 peer-reviewed publications, 40 peer-reviewed publications, and 15 non-peer-reviewed publications. Next, we have Dr. Preeti Patil. She is currently an associate professor of ophthalmology at University of Pittsburgh, and she is also a faculty in pediatric neuro-ophthalmology at the same place. She did a residency and fellowship from Shankar Nethralaya, Chennai, and then she went on to do an additional fellowship from University of San Diego, California. She was a colleague and a dear colleague at L.V. Prasad Institute. She served there for 7 years in the field of pediatric ophthalmology and neuro-ophthalmology. Her special focus has been complex strabismus, pediatric neuro-ophthalmology, and CVI. She is a reviewer for many peer-reviewed journals. And last, I have Dr. Vivek Warkad, who is a dear colleague at our Bhubaneswar campus of L.V. Prasad Eye Institute. He did his medical degree, MBBS, and post-graduation from India. He also did fellowship from L.V. Prasad Eye Institute. He is also currently doing the visiting research scholar fellowship at Boston Children's Hospital at Harvard Medical School. His special focus has been complex strabismus, pediatric neuro-ophthalmology, and pediatric cataract. He has over 10 peer-reviewed publications. With this introduction for the panelists, we will start with the cases, and we will be introducing our distinguished faculty as we go ahead with each case. I would request Dr. Vivek to please go ahead and introduce Dr. Heather Moss, who will be leading the first session today.
Yeah, thank you, Dr. Sachdeva, for the introduction, and I welcome you all for this wonderful, the global neuro-ophthalmology case festival session. So, can you please project the slide for Dr. Heather Moss? Yeah, so I would like to take this opportunity to introduce Dr. Heather Moss. So she is currently an associate professor and the director of clinical research, Department of Ophthalmology, the Byers Eye Institute, Stanford University. She did her medicine at Harvard Medical School, followed by residency as well as the fellowship in neuro-ophthalmology at University of Pennsylvania. And then she actually contributed as a head of neuro-ophthalmology, and in fact started neuro-ophthalmology fellowship at University of Illinois in Chicago. There are more than 80 peer-reviewed publications and many book chapters on her credit. And she also, interestingly, she is a biomedical engineer from Harvard and MIT. And probably that is the reason, her area of interest is innovative diagnostics in neurological and neuro-ophthalmological conditions. So I would like to invite and over to Dr. Moss.
All right. Thank you so much for inviting me to join you all today. It's so wonderful that around the world we can connect virtually to share these wonderful cases. And I want to go back to basics a little bit for the neuro-ophthalmologists on the panel. And so even though some of these things may seem obvious to us, for the benefit of the more general practitioners or practitioners in training on the live stream, let's think about some of the key teaching points that would be helpful as we approach these cases. These are my disclosures. None of them are relevant to the current presentation. So this is a 35-year-old woman who has right eye problems. A month ago, she developed a mildly painful right eye and associated with right-sided headaches. These were diagnosed as migraine. She was seen by an ophthalmologist about 10 days after it started, and her IOP was noted to be 30 millimeters in the right eye, with otherwise normal exam, and IOP was normal in the left eye, and so she was started on drops for her ocular hypertension. And then a month after onset, she was involved in a minor car accident, and when the emergency medical services arrived at the scene, They noticed that she looked like this, and so they brought her to the hospital. And I wonder if anyone on the panel has comments on her eye appearance.
So Heather, certainly the right eye looks somewhat prominent compared to the left. There's certainly a degree of injection. I don't know if those are somewhat dilated vessels. There doesn't appear to be any periocular swelling though.
Also, it looks like ptosis.
Yes. And then what was particularly alarming when she got to the emergency room and they looked at her eye movements, this got her a very rapid ophthalmology consult. So she's looking to the left, now trying to look to the right.
Yeah. Can I shut my eyes to focus? Yep, shut your eyes. Okay. And then when you're ready, open them up. Okay. Now you see one again. Yes. Look all the way to your right. Good. Okay, shut your eyes and refocus. Good. Open. Now look up all the way. Good. Okay. Look straight ahead now. Good. Now look down all the way. Okay. And straight ahead. Okay. Look all the way.
All right, so that's just a little bit of a teaser. So this is the remainder of her history, which was pretty much unremarkable. And this was her ocular examination. She had normal visual acuity. She did not have a relative afferent pupillary defect or any pupillary abnormalities. Her IOP on drops remained elevated in the right eye at 24. As noted, she did have some proptosis, about 4.5 millimeters on her tel. She reported some red and light desat in the right eye, had full color plates and full confrontation visual fields. All right, so here's her picture again, which we talked about, her anterior exam. And I'll tell you that the slit lamp exam was normal. And then here's her dilated fundus exam, which suggested maybe a slightly asymmetric cup to disc, mild vascular tortuosity in the retina of the right eye, and otherwise unrevealing. And then here are her deductions. So I'll have, I'll play it, and maybe as it plays, if anyone on the panel would like to comment.
And to the right.
This is the normal eye.
And down and left, down right, up and right, yep, up and left, Good. Now switch, cover up the other eye. Okay, now what I want you to do is look all the way to the left. Is it feeling like it's sagging a little bit? Mm-hmm. Okay. Now blink a few times. Look all the way to the right. And it's sagging out again, okay. And look down all the way, hold it. Down, down, down. Okay, up, up, up. Okay, and to the left. And to the right. All the way to the right as much as you can. Down and right. Down and left. Straight down. Straight up. Okay.
All right. Any comments on her motility exam?
I think it looks like, on versions, there is no abduction. On ductions, there is no abduction limitation. So we would less likely consider, the possibility of the sixth nerve palsy, rather the restrictive pathology here.
Right, and I'll go play this video that I initially showed you. So I think what really sort of concerns the initial physicians that evaluated her was that there did seem to be sort of this changing of her alignment. And she refers to it as a spasm, that things get a little bit stuck. And so the conclusion that was drawn was that she did have a mix of pathology, that she had some restrictive strabismus, and that she also had a paralytic sixth nerve palsy. You can see she has trouble maintaining gaze in certain directions.
Okay. Down all the way. Okay. And straight ahead.
All right, and then forced suctions confirm that as well. All right, so what would you do next?
Look for bruit.
Look for a bruit. She did not have a bruit. Any other clinical exam findings?
I wonder if when the intraocular pressure was checked, were the Myers pulsatile?
No one made that observation.
About gonioscopy, any blood in Schlemm's canal?
No.
Does she was febrile? I mean, does she had episodes of fever?
No, she said no episodes of fever.
Retinal venous congestion?
She did have some tortuosity of the retinal veins. All right. So excellent question, sort of getting at this idea of maybe is there a vascular cause going on? So what, in terms of ancillary testing, any requests? Unlike Dr. Plant, I won't withhold it from you. So she went for imaging. So first was a CT of the orbits showing proptosis of the right globe, induration of the intraconal and extraconal retrovulvar fat, and then enlargement of the superior medial lateral rectus muscles with involvement of some of the tendinous insertions. And this is all in the right eye. The left eye and globe are completely normal. What are differential diagnoses based on this result in the exam so far?
So it could be an orbital inflammatory syndrome, looking at the tendinous involvement of extraocular muscles.
Yes. All right, and then this is her MRI. So this is a post-contrast scan with fat saturation. And highlights many of the same findings seen on the CT scan. So you can see that there is some enlargement of the extraocular muscles. There is some changes in the orbital fat, and there is some proptosis of the globe. Interestingly enough, there was also some question of whether there was some hyperintensity of an enhancement of the optic nerve on that side.
Yeah, and sinus is also very classically spared. So usually they don't have the sinus involvement if we think about orbital inflammatory syndromes.
All right. And then there was a very important finding on the coronal MRI scans. So there's enlargement of the superior ophthalmic vein there, along with the other findings of extraocular muscle involvement and some fat stranding of the orbital fat. And how would this change thinking at all?
So in the chat, there was a comment that this could be a carotid cavernous fistula, dural arteriovenous fistula, and I think that's certainly a consideration whenever we see an enlarged SOV. But the flip side of that is that the enlarged SOV is a bit nonspecific, and anything that causes orbital congestion can also produce that finding. But I don't know if the trauma you mentioned was a red herring or not, but that certainly raises my concern for a new or worsened fistula.
Great.
Dr. Moss,
yes.
was she started on any antibiotic? Oral
She had not.
IV?
No, so the only thing she'd been treated with was were the eye pressure lowering drops.
Okay,
and,
otherwise I could think about one of the differential, like the cellulitis as a comprehensive attending physician in first go if we see.
Right, exactly. I think in neuro-ophthalmology case conferences, we like to jump straight to the exciting things that we see rarely. But you know, common things being common, an orbital cellulitis or an orbital inflammatory syndrome are probably higher on the list for this kind of presentation, and along with the tumor that was presented at the end of the last session to keep in mind. So one really important physical exam finding that wasn't requested but was duly done by the ophthalmology resident was a cranial nerve exam, which showed that she had some sensory decrease in the cheek and the V2 distribution. And so that helps point us back to the cavernous sinus being very important, along with this enlargement of the superior ophthalmic vein, although as Dr. Subramanian pointed out, that can be a non-specific sign as well. So
I must say, Heather, I must say that given the size of the superior ophthalmic vein and the changes, I don't think I've seen that much involvement of the orbital fat in a dural fistula or even a direct fistula. That's really a bit unusual. I think if you're thinking of a fistula.
And this is Mark, and I would concur. And actually, I'm sort of unimpressed with the changes. They're very minor changes in the orbital fat. I wanted to point out, Heather, you didn't show us the head scan through the cavernous sinus at all.
I have not, because I haven't chosen those slices, but I will tell you that it was normal, including both contrast enhanced sequences with MRA timing and with MRV timing.
I would be surprised that if you looked at the T2 axials carefully through the cavernous sinus, that they would be normal, which is usually the key to these cases.
And unfortunately, I don't have the slices here for you today, other than to say that we carefully reviewed them and we have, they appeared to be normal, but there may well be things that others could detect on them. So the next question is, what would you do next? So we've got some votes for some of the findings, maybe being some concern for CC fistula, but maybe some other things also still being high on the differential for this patient.
I would get this MRI re-reported, get a second opinion on the scan, look at the T2 weighted images.
Yeah, so it was the MRA. Yeah, so it was, so MRA, which I didn't show you the images, MRA, MRV, MRI, were all re-reviewed with neuroradiology and the neurosurgery team as well. So heading towards this. So she underwent conventional angiography. So for comparison, on the top, I've shown you her right internal carotid artery injection, and on the bottom is the left internal carotid artery injection, which is normal. You can see that as the carotid artery fills up here, that there's some early filling here in the cavernous region going into the venous plexus, and that this extends out getting into the extracranial venous circulation here, as opposed to the left side, which I have flipped for easy comparison. You can see that all of this area is not involved. And so this is diagnostic of cavernous carotid fistula in this patient.
So Heather, I would say you showed us a common carotid artery injection. So it doesn't tell you where it originated from. You see this? This is about both external as well as internal carotid artery filling. So so this is a dural shunt from where? From the carotid or from the external? You know,
I apologize. It's from the carotid.
Oh, okay. Okay. All right. And by the way, you notice a drain to the face.
Yes. So just to remind everyone of the anatomy, so the internal carotid artery goes through the cavernous sinus, and you can have direct and indirect fistulas that form between the arterial and the venous circulations. And that one of the things that this can cause are symptoms from the fistula itself, which were mentioned. So, someone asked about a bruit, someone asked about pulsatility of exophthalmos and of the rings of the Goldmann applanation tonometry, as well as a cavernous sinus syndrome, which could possibly be the cause of some of her motility deficits. And then other symptoms are related to the venous hypertension. So arterialized vessels, which are not super prominent on her conjunctiva, but some could argue that they are. The venous congestion seen in her retina. Someone asked about blood in Schlemm's canal. She had elevated IOP, and then she had muscle congestion and ptosis, along with a restrictive strabismus. So many of these findings. So she was treated with embolization, and in just a couple of days, you can see the outcome here. She did really nicely, and you can see that her motility is dramatically improved, both in absolute extent of her motility and in terms of the speed of her eye movements. All right. So thank you very much. I'll defer to the moderators whether there's any more time for discussion. One sort of interesting question is the role of trauma in this case. Was it just incidental that she had this brewing all along? Or could she have a fistula that might have been brewing and then the trauma tripped it over the edge, so to say?
Wasn't the trauma after the glaucoma diagnosis?
Correct. So she had the high IOP a month before and the eye pain even preceding that. On interview, she said that the eye redness had actually started prior as well. And the car accident was actually very minor. It was just that the appearance of her eye was so alarming that that's what got her brought into the hospital.
I must say I'm aware of a patient somewhat similar who had had some symptoms and then was at a movie theater or something like that and tripped and fell. It wasn't a major injury, but shortly thereafter had much more worsening. And I'm sure this patient, as in your patient, had the dural fistula all along. That's why she had elevated intraocular pressure in the one side. And then the mild trauma may very well have tipped it over.
Right. We also maybe wondered if some of the eye movement limitations and diplopia, which when we really pushed her, she might have had before, might have contributed to the car accident. All right. Thank you very much.
Thank you very much, Dr. Moss. That was very interesting. So just for the benefit of the audience, I think what we all are looking at is a patient where possibly the elevated IOP was possibly due to a much more milder manifestation of the CCF, and then it got accentuated by the trauma. So I would like to ask, for benefit of audience, how frequently you see such kind of presentations, and I think it must be quite common.
I would say in the perhaps confusing thing or less common thing about this case is the age of the patient. We tend to see this more commonly in older patients who develop a low flow spontaneous dural arteriovenous fistula that may be recognized only as IOP asymmetry, or as Bart was suggesting, this pulsatility of the Myers on Goldmann applanation tonometry. So that may have been something that led to this being a little more challenging to diagnose, but I agree with you that it's not that uncommon. And you have to be cognizant of it and think about it, or you will possibly miss it.
Thank you very much, Dr. Subramanian. I think in interest of time, we will move ahead with the next presentation. And I would request Dr. Swati to moderate and begin with a kind introduction for Dr. Prem. I'll share the slide.
Pleasure to introduce Dr. Subramaniam, who is a very well-known figure in the field of neuro-ophthalmology. He is currently serving as Professor of Ophthalmology, Neurology and Neurosurgery and also Vice Chair for Academic Affairs at University of Colorado. He received his MD with high honors and PhD in molecular and human genetics at Baylor College of Medicine in Houston, Texas. His previous position includes being a faculty on the in the Wilmer Eye Institute, Johns Hopkins University School. He's also a founder member of medical staff of Marcus Institute of Brain Health, where he serves to improve the functioning of patients with traumatic brain injury. He also is an active orbitocranial surgeon with a specific interest in tumors of skull base and small incisional approaches. His current research is focused on progressive thyroid ophthalmopathy, increased intracranial pressure, and traumatic brain injury. He also serves on the board of directors of NANOS and has published over 220 research articles, including book chapters and web educational materials. He is also serving as a dedicated educator in several countries around the world. It's a pleasure to introduce Dr. Subramaniam. Over to you, Dr. Subramaniam. You may please share your screen.
Okay, thank you very much. And I will use my time to start with a case which I think is not especially challenging in and of itself, but does give us a diagnostic dilemma that I'll ask the panel to talk a little bit about their approach to a patient like this. And then I've been asked to speak about some evolving technological advancements in terms of diagnosis of these particular conditions where patients have a swollen optic nerve. And so I have no relevant financial disclosures. This is at face value a relatively straightforward case. A 61-year-old male presented to his optometrist with a headache that started about 3 days prior to presentation, and this was associated with the sudden onset of blurred and dimmed vision in the right eye. The headache persisted, it didn't remit, and this was somewhat uncommon or unusual for this individual. He did have a number of systemic vascular conditions, including borderline diabetes, hyperlipidemia, hypertension, as well as vitamin D deficiency, which we all have. He was taking metformin, ezetimibe, rosuvastatin, amlodipine, tadalafil. So a number of medications that we might associate with a predisposition to a swollen optic nerve, as I will show you, and sudden vision loss. And he had chronic headache, but was a little different than the headache he was experiencing now, which seemed to be more centered around this right eye. His visual acuity had dropped mildly to 6/7.5. The left eye was normal. His color vision was not checked, and unfortunately, his pupil exam was poorly documented at that time. He was reported to have some pain when looking up. And inferior field loss was noted by confrontation, and indeed a screening frequency doubling test, threshold test was done. And it was interpreted as showing an infranasal defect in the right eye, although you can see it's a bit more generally depressed than that. Not too impressive in terms of a pattern, and importantly, the left eye was normal. So it was noted as well that his right optic disc was swollen, and unfortunately this is an optos photo that I have cropped down, so a wide field photo with false color imaging, and so the hemorrhage is not as well visible as I would like it to be. This was not an image that we took, but it was documented, and on subsequent fundus exam by us, there clearly was about 270 degrees of infraretinal hemorrhage, peripapillary hemorrhage, not elsewhere in the retina, surrounding a moderately swollen right optic nerve. So for trainees out there, I want you to recognize that wide field photography, as done with an optos or similar instrument, is probably not the best for getting good detailed views of the optic nerve. But in any case, this is what we had, and this is what we have to work with. So the patient was then sent on for a neuro-ophthalmic examination with us, and this was approximately 1 week later. And at this time now, the visual acuity in the right eye has dropped significantly, although the left eye remains normal. There was an RAPD in the right eye now, although color vision, despite the 4/60 vision in the right eye, was relatively intact at 8.5 out of 10 Hardy-Rand-Rittler plates, and he saw 10 of 10 in his left eye. There was optic disc swelling on the right, and I don't have fundus photos from the time that he visited with us, but I do have some OCT imaging of his macula as well as his retinal nerve fiber layer. And so with the retinal nerve fiber layer, with that false color image that is present here that the instrument gives to us, we can appreciate the optic disc swelling. Clearly, the retinal nerve fiber layer analysis shows marked thickening. And in the left eye, it's hard to appreciate here, but this is a somewhat small optic disc with a minimal cup. And aside from what I think is perhaps artifact inferiorly, it was relatively normal. The macular ganglion cell complex at this time, despite his marked decreased vision, was normal. And so I'm going to ask if anyone on the panel or other speakers want to comment on the differential diagnosis, if there is one, in the 61-year-old man with sudden vision loss.
I think ischemic optic neuropathy would be my first differential, particularly non-arthritic, since the visual loss, since the pain was not so significant.
Yes, certainly that was the top thing on our differential. Anything else? So does the pain that accompanied this, does that trouble anyone, or can you see that with ischemia?
I would think about optic neuritis as well, or compressive optic neuropathy.
Sure. The pace was a little unusual for compression, but optic neuritis, although he's a 61-year-old man with multiple vascular risk factors using tadalafil, that optic neuritis was a consideration as well. Absolutely. Anyone think this is papilledema from elevated intracranial pressure? There was that little bit of abnormality in the left eye. No, I don't think so either, because the asymmetry, the degree of vision loss, with the relatively moderate to mild disc swelling really wouldn't go along with this being papilledema, swelling from increased intracranial pressure. And again, just to clarify for those out there who are listening who are not neuro-ophthalmologists, when we see a patient like this with significant visual acuity loss, visual field loss, and not disc swelling, which is not extremely impressive, we're going to be less likely to be concerned about that. Does the color vision help us at all? Are there other factors here that help us to discriminate between ischemic optic neuropathy and optic neuritis, which really are the two major considerations here? So I mentioned that the pain was one reason that we were thinking that this might not be NAION, or made us at least a little bit more concerned than when the average person comes in with non-arteritic anterior ischemic optic neuropathy findings. And I don't think this is likely to be arteritic AION. That was certainly on our differential because of the severity of the vision loss. But pain and headache don't necessarily help us. Ed Soling spoke about this yesterday. Great work about predicting the likelihood of having GCA in a patient. If we look at pain as a discriminator between NAION and optic neuritis, it certainly has been reported that the vast majority of patients, 92%, have pain with optic neuritis versus only about 12% in NAION. So only 1 in 8 patients with NAION has pain. Not much difference in character. And interestingly, in another study, it was suggested that up to 1/3 of patients with NAION might have spontaneous orbital pain, which could manifest in the same way as headache. And that spontaneous orbital pain still was more common in patients with optic neuritis. Pain with eye movement is definitely much more characteristic of optic neuritis than with NAION. And in this patient, it was not clear that there was pain with eye movement. The points to take away from this, I think, are that the presence of pain certainly is characteristic of optic neuritis, but the presence of pain doesn't exclude the possibility of ischemia. The absence of pain, I think, would make us less likely to make a diagnosis of optic neuritis in a situation like this. And so any comments from anyone else about the importance or unimportance of pain in patients like presenting in this manner?
The only thing I would say, Prem, is that in general, pain on movement is extremely rare in NAION, as you point out. I don't think I've ever seen it, and certainly as you have there, pain on eye movement is something that virtually excludes NAION for me in most cases.
Yeah, absolutely agree, Neil. So are there other things we can do, ancillary testing, things in the clinic that might help us before we jump to any sort of studies that we're going to order? I'm going to be like Gordon and withhold any neuroimaging at this point. But are there things that before we go to there, I'm not going to ask for tangent image screen, but are there things that we can do that might help us? Any suggestions from the panel? I have been asked to review a little bit on the potential utility of OCT angiography. And the reason I was asked to do that is I think we have all learned that structural OCT, as I showed you, is really quite useless in the early differentiation of different types of optic disc swelling or different causes of optic disc swelling. If you have papilledema, the RNFL is thickened. If you have optic neuritis with anterior swelling, papillitis, the RNFL is thickened. If you have NAION, the RNFL is thickened. These things just simply don't help us. They don't discriminate among them. But if we're going to work from the idea that maybe some of these causes are due to decreases in blood flow, changes in circulation, or even vessel structural abnormalities that lead to the findings of the disc, then OCT angiography might help us. We have to remember it's a static imaging of the vasculature. This point was brought up in yesterday's discussion as well, that it doesn't tell you anything directly about flow, but you can look in fine detail at the peripapillary area, the macula, and the disc. And what I'm going to show you is primarily studies that we've done on the peripapillary area as well as within the macula. It is subject to artifact, and it's not as straightforward as looking at structural OCT imaging. There are shadowing artifacts that can occur when you start looking into deeper layers of the retina, and there's also a great susceptibility to motion artifact, not too surprisingly, because this is a technique that relies upon time-related changes that are occurring, and then the subsequent analysis of those time-related changes. So we've looked at OCTA in acute disc swelling, looking to see how pathology might affect vessel structure. Are there specific patterns with specific diseases? And then I'm going to show you what can or can't be done with OCTA to differentiate those hard cases where patients come to see you with an optic neuropathy, a pale disc, but a not very particular or specific history about how it happened. So we looked at a series of 29 patients with acute NAION, less than 2 weeks of vision loss and unilateral disc edema. Also had a population of optic neuritis, papillitis patients with anterior disc swelling, pain, full vision loss of less than 2 weeks duration as well. They had MRI enhancement of their optic nerve, and clinically we had to feel that no, this was not consistent with NAION. And then papilledema patients who had less than 2 weeks from the onset of symptoms to the time that they were examined and diagnosed with papilledema, and they could have anywhere from Fresenius grade 1 to 4 swelling. And then controls. And when we looked among these, this was one of the first studies that we did where we looked first with the commercial software. So just what does the machine spit out at you? And the machine spits out at you what looks to be very promising information. That is, if you compare NAION with papilledema, disc swelling from increased ICP, there's a huge difference in the optic nerve head images. This seems like a slam dunk, right? And when you compare it to NAION to optic neuritis, again, looking at certain sectors on the optic nerve head itself, it seemed as though in NAION and optic neuritis, there were these marked differences between patients who had one disease or the other. But a pitfall that you have to recognize in looking at this is that whenever you have swelling of the optic disc, it could potentially obscure some of these large vessels. And the machine in this regard is dumb. It is incapable of knowing that a decrease in what it's seeing is from a real decrease or from this swelling that obscures what it is able to image. So we used a custom technique that we developed to subtract out large vessels to then only look at the smaller, finer capillary vessels with the idea that they were less likely to be influenced by direct compression from disc swelling. And when we used this customized capillary density, guess what happened to that apparent relationship between, or differentiation between NAION and optic neuritis? It totally fell away. And that showed us that you can really fall into a trap if you rely upon the information that the instrument spits out at you without understanding what it's actually showing you. However, interestingly, even with this, we were able to make some distinction between papilledema and optic neuritis. Now, clinically, you can usually make this distinction, right? You don't necessarily need an OCTA to tell you that, but it was interesting to us that the character of disc swelling between these two disorders affects the radial peripapillary capillaries, the capillaries that are immediately around the optic disc, in different ways. Now, we had done some previous work with papilledema, disc swelling from increased ICP to see if it resulted in structural changes in the macula. And we had identified some temporal ganglion cell complex thinning in patients with papilledema compared to elevated optic discs. Here, we decided to look with macular OCTA at the superficial vessel and deep vessel densities. And it's hard to see on the RNFL there because the images are small, but both the NAION and papilledema eyes, as you might imagine, had very thickened retinal nerve fiber layer. The ganglion cell complex in all three of these individuals, though, was the same, normal, but the whole vessel densities in the superficial and deep plexi were less in patients with NAION than control subjects or in patients with papilledema. We unfortunately didn't have optic neuritis patients in this cohort. And if you look at, of course, the average RNFL thickness was very different from controls, as I already pointed out to you. Papilledema and NAION were not very different from each other. But as I mentioned to you, if we compare NAION and papilledema, we can see that there are marked differences. Again, it doesn't tell us about differentiating from optic neuritis, which was the clinical question in this particular case. Finally, can OCTA help us to differentiate a pale disc? What caused it? Can we tell, was it NAION, was it optic neuritis? So we looked at old NAION and old optic neuritis and looked at them with OCTA. And clearly in patients who already have an optic neuropathy, the retinal nerve fiber layer is thinned, although on average, that thinning was greater in patients with NAION. And at first, it seemed as though there was, again, a differentiation, that optic neuritis patients had a lesser reduction of that vessel density. And that makes sense on face value, right? You're looking at an ischemic disease versus an inflammatory disease. You might expect that there's going to be a greater loss of that peripapillary capillary structure in patients with NAION because they had an ischemic insult. And great, that would be a fantastic way to try to differentiate things and not to have to go to neuroimaging or rely on patient history. But unfortunately, when you adjust this for the amount of retinal nerve fiber layer loss, that difference falls away. And so that capillary density difference is actually a function of retinal nerve fiber layer thickness. It doesn't appear to be a function of what the mechanism was that led to that vision loss and that thinning of the retinal nerve fiber layer, the optic neuropathy itself. So I'm afraid I'm leaving you here with the idea that at this point in time, OCTA may not help us. Relying on pain may not help us. Relying on patient history and vascular risk factors may not help us. And so we have to be clinicians and be suspicious. If this patient had come in with no pain, inferior altitudinal field loss, superior disc swelling, and a static picture, we would have been satisfied this was NAION. I'm going to skip over this. So back to our case, because he presented in this somewhat unusual manner, he was sent for MRI imaging. And somewhat akin to the case that John Chen showed yesterday, you can see in the right optic nerve that there is some thickening and enhancement, and perhaps even enhancement of the optic nerve sheath, and even as well some enhancement of the fat in this intraconal space. And any comments from our radiologist or anyone else regarding this?
Veena, are you there? Could you comment?
She's left, Satya. She's not around.
Okay, no problem. And so in this instance, with these findings and a relatively normal brain MRI, we were concerned in a 61-year-old man for an atypical optic neuritis rather than a typical NAION. And he was treated with intravenous methylprednisolone actually prior to coming to us. So I hid that information from you. But he improved and then worsened again. So he was given just a 3-day course of 1 gram daily of intravenous methylprednisolone. His pain returned. And so we were concerned again that this might be neuromyelitis optica, or more likely a MOG-associated disease because of the MRI findings. And indeed, his MOG IgG titer was positive at 1 to 1,000. And he was treated with a very slow taper of oral prednisone after intravenous methylprednisolone again, oral prednisone for weeks. This was his only episode of this. He was tapered off of it, and he's been followed closely without any recurrence. So I'd like to leave you with the idea and then ask the panel for any closing comments on this atypical type of optic neuritis, a presentation in a manner similar to NAION, but the clinical features that led us to be a little bit suspicious that it could be something else. And then the fact that unfortunately there's not a lot in terms of ancillary testing in the office that might have helped us to differentiate among these. Thank you.
Yeah, thank you, Dr. Subramaniam. I would just like to ask one question. What is your experience for arthritic AION regarding OCTA? If OCTA is able to differentiate between the non-ischemic, non-arthritic and arthritic AION?
I would say that because some of the ischemia in arteritic AION is often in the choroid, and there are many challenges to using OCTA to image choroidal circulation, that I wouldn't rely on it, at least at this point, with commercial instruments.
It's still more of a clinical differentiation that you would like to rely upon.
Yes.
Yeah. Dr. Prem, I'm Vivek here. So as you have rightly, mentioned, and those very classical differentiation between, the OCTA finding in NAION and optic neuritis. I mean, what is your observation? I'm just curious to know, what is, the capillary pattern above the disc, the edematous area, in NAION versus optic neuritis. Probably if there is, the difference, then probably, OCTA probably help to pick it up amongst both of them.
Sure. So our colleague Tony Arnold is trying to use SS-OCTA right now to answer some of those questions about the circulation on the optic disc itself. There are a lot of challenges to imaging those particular vessels in the acute phase. And so, yes, you're absolutely right. That's our goal. And we were delayed a little bit by current events, but Tony and I are hoping to enroll more patients and to try to get additional data to help us to understand those differences.
Thank you.
That was wonderful presentation, Dr. Prem. I'll continue in respect to what Vivek was trying to ask. Apart from the quantitative differences that you highlighted, are there any qualitative patterns that you are seeing in OCTA in typical NAION patients?
We're interestingly seeing them more in the macula than in the peripapillary area, and that may speak to a broader dysfunction of the capillary structure or capillary perfusion in patients with NAION. So that to me is actually the more interesting part of it. So as far as a specific pattern on the disc right now, I can't point to you a distinguishing feature of that.
So I was trying to ask, because we have observed something like capillary perfusion loss, especially when it is segmental and corresponding with a visual field defect.
Sure. And we've seen that in older, or in patients who are a little farther removed from the acute onset of their disease. And, but you can see that early on, but we're unsure whether that has more to do with loss of the retinal nerve fibrillary and ganglion cells than it has to do with an actual perfusion. That's always my concern in interpreting those data, like I showed you with the late patients who have pallor already.
Thank you very much. I think it was wonderful. Any other comments from anyone?
Prem, this is John. Could I just make a quick comment? I thought it was a great case, and I think it was, you know, the pain that really kind of tipped it off. And it's interesting because MOG really can affect any age. So we are seeing these patients sometimes where it's thought to be an AON, and then, you know, we're finding MOG in these patients. I remember, I think there was a patient in the Quark study where they actually had an OCT, and based on the Brooks membrane complex, they were actually able to say this is not an AON, and they actually found it was MOG. And is that something that we think that we could use to kind of as a tip off here? Obviously, the pain really was what got the MRI here.
So maybe I can address that. And I brought that up yesterday, and Prem knows what I'm going to say. And that is the neurocanal borders are very sensitive to any type of pressure phenomenon behind them. Interesting, not so much for glaucoma. So having high pressure doesn't push the neurocanal borders back because of the lamina. But for some reason, the lamina gives way, and I haven't get the glaucoma people, they just haven't studied it, why that is, why the sclera will allow pressure behind it. So it could be from a stiffening in the optic nerve sheath from an angioma, from trapped CSF and maybe high protein from an optic neuritis, or of course, from intracranial hypertension, and that would be bilateral. So it isn't always a great diagnostic sign. You don't always see it because you don't know where the patient started, whether it's anteriorly displaced towards the vitreous or not. But if you have an asymmetry and the affected eye deviates slightly more anteriorly or less posteriorly than the fellow eye, then you know something's behind the eye, and it's not going to be an intraocular problem or ischemic optic neuropathy. We just never see that. So that's a very good, easy sign that's not perturbed by the massive swelling that you might see in an ischemic optic neuropathy or some of these other disorders.
Thank you, Mark.
Okay. I think wonderful discussion and wonderful case. Thank you very much, Dr. Prem. In the interest of time, we'll move ahead and we can have more discussion on the chat. I will next invite Dr. Padmaja, and I would invite Dr. Sumit Manga to introduce Dr. Padmaja with her case, as well as we'll go ahead with the case presentation. I'll be sharing the slide. Yeah, go ahead, Dr. Sumit. You have the slides.
Right. Thank you so much, Dr. Virendra, for the kind opportunity. Well, it's an absolute privilege to introduce Dr. Padmaja Sudhakar, who is currently working as Assistant Professor of Neurology and Ophthalmology at University of Kentucky, UK. And she did her basic training and fellowship from Chennai, India. And she went on to do her fellowship in Neuro-ophthalmology from Kellogg Eye Center, University of Michigan. She also did her residency in neurology. She's an esteemed chair for the neurology residency program at the UK and a Grand Rounds director. She has several academic publications and academic material, to her credit. And she's an avid researcher too. It's an absolute pleasure to welcome you, Dr. Padmaja. Over to you.
Thank you.
All right. Good evening, everyone. I'm Padmaja Sudhakar, and I'll be presenting an interesting case titled Nerve-Wracking Eye Puzzle. I, at the outset, want to thank all the co-authors of this presentation, and I want to thank the Neuro-ophthalmology Special International Group, and particularly Dr. Satya Karna, who was my former mentor at Shankar Nethralaya, for inviting me to present today. I have nothing to disclose. My case is an 18-year-old man who originally came to the neuromuscular clinic for evaluation of inability to walk with concern for polyneuropathy. His symptoms had started in childhood. He was experiencing low back pain. His primary care was concerned about scoliosis. He had seen orthopedics. He had seen a chiropractor. There were significant coordination issues with poor balance. He had trouble tying his shoes, buttoning his clothes, lots of falls, and trouble walking. Initially, he did not have much sensory symptoms, but slowly developed numbness, tingling, burning in his extremities. He denied symptoms such as headache, double vision, blurred vision, change in voice, trouble swallowing, or bowel or bladder incontinence. He had no significant past medical history otherwise. Now, family history was significant for the death of a twin brother around age 6, and we'll be talking later about why. And then he was doing well. He was a senior in high school, which means a 12th grader in the United States, with no smoking, alcohol use, and review of systems was otherwise negative, and he was not on any medication. So on exam, his vital signs were stable, and on the general exam, the only prominent features was that he had hammer toes and high arches. On neurology exam, he was alert and oriented with intact cognitive and language functions. And on cranial nerve exams, he was detected to have limitation of ocular movements in all directions of gaze, particularly in up gaze, and I'll be showing you a video. Other cranial nerves were within normal limits. He had motor weakness, proximal greater than distal, affecting all extremities with normal bulk and tone. And on sensory exam, there was diffuse patchy sensory loss to light touch and pain, loss of vibration at ankles and toes, and proprioception at the toes. He demonstrated agraphesthesia in the hands and feet bilaterally. Reflexes were depressed throughout. And then on coordination testing, there was ataxia on finger to nose test and breakdown of rapid alternating movements and imprecise, slow, poor amplitude finger tapping. He had a broad-based and a stiff gait. He was unable to do tandem walking. He was unable to walk on his heels and toes. And preliminary workup for like a neuropathy showed the labs were all okay. His CK was mildly elevated, and when they did the EMG nerve conduction studies, it was significant for a severe axonal and demyelinating polyneuropathy, which was predominantly sensory. They did do an MRI of his head, which was contrast enhanced, and this showed an incidental left frontal lobe deep venous anomaly. I know I sounded like a neurologist so far, but because of the limited extraocular movements, he came to the neuro-ophthalmology clinic, and his visual acuity was 20/25 in the right eye, 20/30 in the left eye, with intact color vision. External exam revealed bilateral proptosis. You will see the videos soon. And on the ocular movement testing, he had limited ocular movements in all directions, worse in the up gaze, and he was orthophoric in the primary gaze. Pupils revealed no afferent pupillary defect. Anterior segment exam was unremarkable. Intraocular pressures were normal. And on fundus exam, there was cupping of both optic discs. This is his video. You can see that he is not able to do his up gaze. And I'm hoping you guys can appreciate the limitation of movements. And there you can see a little bit of histosis. So we did do visual fields. There was nerve fiber bundle pattern defects involving the central fixation, but foveal threshold was still good. And then OCT of the retinal nerve fiber layer, it showed that there was loss of average thickness with some kind of polar thinning in the right eye and supratemporal thinning in the left eye. We did do a VEP, and on the pattern reversal, it was abnormal, showing reduced amplitude and delayed P100. And a multifocal ERG surprisingly showed a cone dysfunction. We did do an MRI of the orbits, and then in the top row, we have coronal images, and the bottom row is axial images. So the first is the STIR image, and this is the T1 weighted image, and then this is the T1 with contrast. And we have arrows here pointing that there was atrophy of all extraocular muscles. During follow-up, there was dramatic progression and worsening of symptoms. He developed significant pain in his extremities. He went on several pain medications, not atypical in America. Over the next 2 to 3 years, he started having spells where he would feel clumsy, his legs would give out. He also developed seizures, myoclonus. He had to be initiated on levetiracetam. And when we did an EEG, there was excessive slowing of the posterior background with intermittent moderate bihemispheric slowing. And the motor weakness progressed so much that he became wheelchair bound. Now we have to fit the pieces of the puzzle together. So we have this gentleman who originally came to the neuromuscular clinic for polyneuropathy, the ophthalmology exam showing a picture of chronic progressive external ophthalmoplegia, and then eventually he also developed epilepsy. So because of the CPEO-like picture, we did think about a mitochondrial disorder, but because of the polyneuropathy, which started when he was a child, we could not exclude a hereditary polyneuropathy. Now we know that things like Charcot-Marie-Tooth disease, specific types are associated with optic atrophy. So we did proceed with cardiac evaluation because of this concern for mitochondrial disorder, and that just showed a global hypokinesis. So these are the next options. So should I proceed with a muscle biopsy, consider a lumbar puncture? Should I image his entire spine? Should we consider some kind of genetic testing, or should I call another neurologist or probably another neuro-ophthalmologist for help? Any suggestions?
So, ma'am, at this point of time, considering the changes that you mentioned, so would we not consider myasthenia at all? Like a young male coming with ophthalmoparisis as such. Obviously the other symptoms, are separate, but then would we also, do some tests for myasthenia?
That is reasonable, but like all this started when he was probably like 2 or 3 years old, and it's like continued to progress, and there was no variability in his pattern, and this was just very classical. Like you don't see polyneuropathy in myasthenia. And then you saw the eye movements video. It was just very symmetrical limitation of movements.
I would agree with your concern about this being a mitochondrial disorder, because I was counting in my head how many parts of a nervous system here are involved, and it's it's the peripheral nerves, it's the muscle probably, it's the brain, and then the optic nerve as well as the retina. So you have a multifocal neurological disorder with CPO and myoclonus. I think it's probably mitochondrial, maybe like a MERV mutation or something like that. I think in the old days, people would go to a muscle biopsy first, but nowadays with the easy availability of genetic testing, I would start with that. Do a next generation, maybe a neuropathies panel as well as a full mitochondrial panel, and that would be my first test of choice.
Absolutely. So we took your advice, and then we did simultaneously, we proceeded with the muscle biopsy of the left vastus lateralis muscle, and that showed the ragged red fibers. And then when we sent him for genetic testing, it came positive for a POLG mutation, which was heterozygous on chromosome 15. And remember, I did tell you in the family history that he had a twin brother who died of a genetic disease. So a twin brother had died of a condition called Alpers syndrome, which is a mitochondrial myopathy, and our patient also got diagnosed as Alpers syndrome. So what is this Alper-Hutchin-Locher syndrome? And of course, this was only with this case I had heard about it. So this is a rare mitochondrial autosomal recessive and fatal neurogenetic disorder affecting 1 in 100,000 people. They have the POLG mutation, and it affects muscle, nerve, and brain, as you pointed out. There is a mutation in the mitochondrial DNA replicase with reduced polymerase gamma levels, and phenotypic manifestations occur when the mitochondrial DNA function reaches a critical nadir. There is early age of onset. They typically develop intractable epilepsy with regression of mental and motor abilities and will have liver involvement, but our patient never had liver involvement. Additionally, you can have ataxia, myoclonus, chorioathetosis, neuropathy, and hypotonia. The reduced levels or the deletions in the mitochondrial DNA affects the oxidative phosphorylation chain, impairs the ocular muscles, and thus produces the external ophthalmoplegia. Now, you need a clinical triad of refractory seizures, psychomotor regression, and hepatopathy for diagnosis, but if you don't have the hepatopathy or additional findings, the diagnosis can be confirmed by the polymerase gamma gene sequencing, liver biopsy, or postmortem exam. You need 2 of the 11 findings as listed below. So the cranial proton MR spectroscopy can indicate reduced N-acetyl aspartate, normal creatinine, and elevated lactate levels. You could have elevated CSF protein, cerebral volume loss, which is central more than cortical, with ventriculomegaly seen on repeat MR imaging of the brain or CT of the brain, at least 1 abnormal EEG reflecting multifocal paroxysmal activity with slow amplitude or slowing, and spikes, polyspikes. Cortical blindness or optic atrophy, he did have optic atrophy. Abnormal VEP and normal ERG. Interestingly, he had an abnormal ERG as well. Quantitative mitochondrial DNA depletion in skeletal muscle or liver. Deficiency in the polymerase gamma enzymatic activity in skeletal muscle or liver. Elevated blood or CSF lactate on at least 1 occasion in the absence of acute liver failure, and isolated complex 4 or combination of complex 1, 3, and 4 electron defects in the liver respiratory chain testing, and a sibling confirmed as manifesting Alpers syndrome. So we needed only 2, but he had several of this. So he was treated with the coenzyme Q10 complex, vitamin E, vitamin C, L-carnitine, and then for the neuropathy, he developed, he received gabapentin and pregabalin, and the seizures he received levetiracetam, but unfortunately he succumbed at age 27 after going into status epilepticus. And that is my case. And I want to thank you guys for listening and for participating. Happy to take any questions.
Any comments from Fiona or Umapati?
No, thanks. It was a very nice case. I think it's the combination of all these features point to mitochondrial disease, and of course, this is almost like a recipe book sort of thing. So you just need to think about which are the combinations. So it seems to fit into this polyp gene quite nicely. Thank you. Very nice case.
If I could make a comment, I think what's fascinating about this disease, like meningi and some of the others, is we talk about it as a mitochondrial disease, and it is, but unlike, say, labor optic neuropathy, this is a disease of nuclear genetic abnormality that secondarily affects the mitochondria and causes the mutations. So I think it's fascinating that you really have two separate disorders or types of disorders, one where there's primary mitochondrial abnormality causing a myopathy, etc., and the other is a secondary mitochondrial disorder caused by nuclear abnormalities.
So I think just one other comment is that the names sometimes, like POLG1 gene is associated with a few phenotypes. I think Alpers syndrome is one of them. The other one is the SENDO, which is sensory ataxic neuropathy and ophthalmoplegia. So I think depending on the constellation of physical findings, they have different manifestations. What's interesting here is that the twins, within the two of them, they seem to manifest slightly differently. So that is something very interesting for the geneticists to help us delineate why one twin seems to have different manifestation from the other. Any comment, Padmaja?
So they said that the phenotypic manifestations can vary from what I have read in Alpers. So that's why I thought, like, as you just said, one succumbed at 6, but this boy went on till he was 27.
So I presume they were not identical twins, I guess.
Yeah, no, they were fraternal.
Yeah. Thank you.
Dr. Padmaja.
Doctor.
I'm sorry.
Yes.
Yeah, go ahead, Dr. Sumit. Yeah.
Thank you. Just for the benefit of the audience, I was just wanting you, if you could just compile and tell us that, if we just see a patient of CPEO, with all the findings, and now, say the muscle biopsy has been done, what exactly protocol-wise ophthalmic features, and since there are many systemic syndromes there, what kind of referrals we should take, on a priority basis, so that, we know about the systemic features.
So yeah, that's a great question. So when we see someone with like a CPO, and this is not first time, because I have another patient who actually came to the oculoplasty clinic with ptosis, and actually he was the one who thoroughly examined and noticed it was beyond the ptosis. There was limited ocular movements and had actually chronic progressive external ophthalmoplegia. Now, she was a high myope and a diabetic and had seen an ophthalmologist almost from the age of 5. And we picked up on the CPO at the age of 30. So she went for 25 years without anyone noticing the eye movements. I mean, I don't think general ophthalmologists check the eye movements as much as strabismus or neuro-ophthalmology people do, and of course the neurologists do. So generally in external ophthalmoplegia, we definitely make it a point to send for cardiac evaluation, because cardiac conduction defects are, need to be ruled out, and she had a cardiac block. Similarly, although the fundus exam might look normal, just like how I was surprised in this case, cone dysfunction was detected. So I don't think it would be unreasonable to get the ERG. And then I always get my neuromuscular colleagues involved because, two neurologists examining sometimes is helpful in a complicated patient like this. And they have proceeded doing the EMG nerve conduction studies. And and then when we send for the mitochondrial workup, I think we have to send the whole sequencing instead of like, unless we're absolutely sure that, to clinch the diagnosis, I think the whole mitochondrial sequencing will help clinch the diagnosis. These are the basic things that we do. Of course, labs wise, we check for things like pyruvate, lactate, and then in rare cases, we've sent for MR spectroscopy, but not in all cases.
Just one more thing regarding the muscle biopsy. Although the standard has been, proximal muscle biopsy, but there have been reports that, some people have used the orbicularis muscle also, either while doing the ptosis surgery or, like I personally have actually sent 2 samples from extraocular muscle surgery while operating strabismus in these patients. So what is your take on that?
Yeah, I agree with that. We have done that as well. So our plastic surgeon has helped us with, but it's a little more invasive for the patient. Whereas if we have the neuromuscular specialists support us and identify a muscle, like for example, vastus is a big muscle in the quadriceps and is easier to approach, so mostly we go for something in the legs rather than the eye, but we have done in a few cases as well.
I can make a comment on that also. So generally, as principle, if there's a systemic disorder, we prefer to do a biopsy in a systemic muscle. Usually the default muscle is like what Maja said, either the vastus or the biceps. But occasionally we get a specimen from after the eye surgery, so that's also okay, but it doesn't need to be directed towards the eye just because the eye is the main manifestation, because often you will find it in other muscles. As opposed to other disorders where it's a very localized pathology, here if it's a genetic disorder, we expect things to be seen generally, so it should be okay to biopsy a standard muscle like biceps or vastus lateralis. And then regarding your earlier question, I think one useful, maybe I could just share the screen to show you. There's one very useful website, is the neurovascular website that WashU has, which is a very useful, very regularly updated website that you can, if I were to just share it now, you could see, I think you can see my screen. So you can see that this is the neuromuscular website. It says neuropathy. You go to the neuropathy side, and then mitochondrial diseases, and then everything about mitochondria is there. So it's often updated very regularly, and this is a fantastic website that most of us use to keep up to date, and because there's no way that you can keep up with all these things that are going on. So to your earlier question about what do you do when you see a patient with extraocular muscle problems, so again, you go to a neuropathy with extraocular muscles abnormality, you click on that, and all the differentials will come out. So I would highly recommend this website.
Thank you so much. Great help. Thank you so much.
Yeah, Dr. Padmaja, I just wanted to ask, one question regarding, as you presented a very rare case when we see patients with external ophthalmoplegia, particularly CPEO. So this particular syndrome, they do have, both the variants, right? Autosomal dominant as well as recessive. And in both of them, I mean, with this presentation, would you able to say that it is exclusive that, the external ophthalmoplegia is predominantly in the recessive variant versus, the autosomal dominant? Looking at history, probably that would help, the general ophthalmologist or strabismologist to define, I mean, in which direction I'm going, looking at the clinical history or pedigree.
So in this in Alpers, I think it's only described as autosomal recessive, but you're right, there are other CPEOs where it could be. So generally, ideally we try to get them to a genetic specialist, but we're willing also to offer the eye exams if we know like there is like a suspected pattern in the family. For example, this boy was brought because parents know that they lost the other child, and then he was manifesting some symptoms of the neuropathy and the weakness. So that helped us. But I would like to offer, I don't know specifically whether, based on the recessive and dominant pattern, we would be able to kind of pinpoint as far as the eye muscles are concerned.
Yeah, because I was thinking about the age also, because age may not be very synchron. I mean, looking at the dominant and recessive pattern, because recessive could happen at any age group, right? From
That's
birth to, yeah. Thank you.
I think that was wonderful discussion, and we got access to a very useful resource from Dr. Uma. So thank you very much. I think we'll move ahead with the next presentation, and I will invite Dr. Preeti to take us through the next two presentations. Dr. Preeti, over to you.
So it's my pleasure to introduce the next speaker, Dr. Bart Schwalies. Dr. Bart is a neuroimmunologist and a neurologist, neuro-ophthalmologist at the Massachusetts General Hospital. He has done his medical training from the University of Illinois in Chicago, then his residency in neurology and a clinical fellowship in advanced autoimmune neurology, and then a fellowship in neuro-ophthalmology from the Mass Eye and Ear. His key areas of interest include inflammatory and infectious autoimmune disorders. He's also the founding director for the Inflammatory Neuro-ophthalmology and Skull-Based Disorders Clinic, which is really a one-of-its-kind referral clinic that he's running. He has a keen interest in research and in teaching. So without further ado, Dr. Bart, I invite you to present your case.
Thank you for the introduction. I'm going to try to share my screen here. Is that showing up? No.
Not quite yet.
Not quite yet. All right. I apologize for that. Is it now sharing?
Yeah, we can see. You can put on the slideshow.
Okay. Very good. So thank you for this kind introduction here. So I'm going to share three short cases here from in skull-based neurology. So my first case is entitled Pushing the Limit. It's a case of a 79-year-old man with progressive right vision loss. So the story is here that 9 days prior to presentation, he developed right temple pain. 8 days prior, he developed this gray band in his vision of his right eye, and he felt like his eye was swollen and pushed forward. He did not have any pain with eye movements. He went to see two ophthalmologists sequentially. The first one told him that he can't see anything wrong. The second one was a retina expert who told me he had a stroke in the back of his eye and that he will never see again. Then he presented to Mass Eye and Ear, and at that point, he described no vision in the right eye and proptosis of the right eye, and a little bit of decreased vision in the left eye. On a review of symptoms, he had no fevers, chills, jaw claudication, scalp tenderness, myalgias, arthralgias, weakness, numbness, or speech or swallowing changes. He had a medical history of dyslipidemia and prostate cancer that was felt to be in remission, as well as cervical disc surgery. He was on aspirin and simvastatin and calcium vitamin D. He worked as a retired lab courier, was married, and a former smoker. So on exam, in the right eye, he had no light perception vision. Left eye was 20/70, but pinholing to 20/25. In the left eye, the colors were not impaired, but confrontation visual fields were constricted circumferentially. He had minimal reactivity of the right pupil with a relative afferent pupillary defect, and he also had limitations of abduction and elevation of the right eye. On Hertel exophthalmometry, he had 6 millimeters of relative proptosis of the right eye, and there was also a difference in the intraocular pressure. And he was seen to have chemosis, proptosis, and resistance to retropulsion of the right eye, and in the back, a blurred disc margin of 360 degrees with some vessel obscuration. So imaging was performed, and so what I'm showing here is an MRI that's T1 post-contrast images, fat saturated, axial on the left side of the screen here, and on the right side, a coronal image. And I think what you can appreciate here is that the right eye is pushed forward. There's proptosis. There's also congestion of the orbit. There's maybe congestion of a lacrimal gland. There's a signal change in the orbital fat. There's a signal change in the optic nerve sheath and maybe in the optic nerve itself on the right side. So just I want to briefly open this up for discussion here. What might be going on? What should this patient have next?
So at this point, I guess given the vision loss, the pain, the proptosis, so we know we're looking at an inflammatory pathology. Given his, so it's either like an orbital inflammation, like a non-specific orbital inflammation, but given his previous history, I would also be concerned about infiltrative pathology. I would like to know what everyone else thinks. The other point that I also wanted to bring up on the MRI, if we were looking at inflammatory pathology, how often do you see the nerves so intensely involved with the muscles relatively spared? And I just wanted to get everyone's thoughts on that.
Yeah, you're right. The muscles were felt to be relatively less involved, but maybe slightly congested as well. Okay, maybe I'll just move on here. There are 3 cases to discuss. So he had a number of different studies. So the blood labs were notable for relatively normal labs with no elevation of the inflammatory markers and some negative infectious studies, as you can see. A lumbar puncture was performed that was notable for an elevated protein, but no cell count and no oligoclonal bands, normal IgG index and synthesis rate. Because of a history of malignancy, a CT PET from the skull base to thighs was performed to look for active malignancy, which was negative. A temporal artery biopsy was performed, which was negative as well. And lacrimal gland biopsy was performed that showed mild diffuse ductal with scattered lymphocytes and plasma cells, a few IgG scattered cells, none with IgG4. So an additional test was performed. The MOG titer was 1/1000. So this was actually a very fulminant presentation of MOG optic neuritis with an orbital inflammatory syndrome. And he was then treated with IV steroids followed by a slow PO taper of prednisone. His visual acuity now about 6 months later is 2200 in the right eye, 2020 in the left eye, with a minimal right abduction deficits at left and minimal right proptosis that is left over. He has developed optic atrophy in that right eye. So we have seen several cases of MOG and antibody disease, but there's very few cases of it presenting as really an orbital inflammation to the point where the first consideration is really not an optic neuritis, but people are, the clinicians seeing the patient are looking at this as an orbital inflammatory picture. So there are 3 prior cases reported. We just put this one, another one in for submission. In all these cases, there's a prominent optic perineuritis and some orbital congestion, and it's a very steroid responsive condition. So I think that we have to think that, this is pushing the limit of what we know of MOG, but also because we don't normally think of MOG in the circumstances. So maybe we should check more often, but it joins these other MOG antibody disease manifestations that we have heard about, like bilateral optic neuritis, longitudinally extensive optic neuritis, cryon presentation, optic neuritis plus transverse myelitis and brainstem disease. All right. We will have time, I think, to discuss it at the end. So let me go through the other two cases here. So case number 2, something strange in the neighborhood. So this is a case of a 58-year-old man with left eye pain and blurry vision. And so the history is a little longer. So 3 years prior, he had nasal septum and sinus surgery for chronic sinus symptoms. And 2 years prior, he had surgery for left lacrimal duct stenosis. Then 4 months prior to presentation, he develops anosmia. He is again seen by his ENT doc, who notices some crusting and a possible mass of the left ethmoid, and gets a CT that shows an irregular mass extending from the left ethmoids to the left medial orbit and cribriform plate. But then as he is being worked up for this, he develops left eye pain and blurry vision acutely and presents to the eye near. On review of symptoms, he does endorse mild dry eyes and dry mouth, but otherwise nothing else. He has a past medical history of hypertension, hyperlipidemia, anxiety, depression, and esophageal reflux disease. His eye exam is as follows. So the visual acuity in the right is 20/20 and the left is 20/30. He's congenitally colorblind. He does have a left relative afferent pupillary defect. No difference on the exophthalmometry. And the anterior and posterior ophthalmic exam is relatively unrevealing. Visual fields show that there is a suggestion of an inferior arcuate pattern of the left eye. And so this is this imaging here. So again, this is an MRI T1 post-sat fat-saturated images. And we're looking at different levels here on a coronal plane. The arrows here in left upper corner are showing, you know, the involvement of the pachymeninges and the ethmoid air sinuses. But then there is an involvement of the posterior orbit, and that's probably where the optic nerve is getting caught up to cause this left optic neuropathy. So again, any thoughts of what might be going on with this gentleman and how we should proceed to work this up?
Definitely want to get a lumbar puncture done to look for CSF, including looking for cytology regarding the etiology of the primary mass itself.
To look for malignancy. Right.
Yep.
Mm-hmm. Any other thoughts? All right. So in this case, because of the high concern of a malignancy or something mimicking malignancy, we actually went straight for a biopsy with ENT of these ethmoid sinuses. And so what I'm showing here are the pathology from the biopsy. And so what you're seeing here in a left upper corner is a mix of an inflammatory and a fibrotic picture with this deep-seated storiform fibrosis. And then and higher up, you see that there's a dense lymphoplasmacytic infiltrate, and you'll occasionally see eosinophils as well. This is a high in plasma cells, and then a lot of these stain for IgG4. And the ratio that we calculated was greater than 40%. So in this case, the final diagnosis is IgG4-related disease, causing in this picture of chronic sinusitis, lacrimal duct stenosis, pachymeningitis, and an orbital apex syndrome. So the lessons here, I think, is to really systematically evaluate the adjacent compartments, both historically as well as radiologically, because there can be important clues, from the sinuses, the skull base, the orbits, the cavernous sinus, the pachymeninges, the pituitary gland. A lot of these tissues are biologically related, and some of the same processes occur. And the skull base overall is a hotbed for systemic disease. But so what's IgG4-related disease? Well, this is it's a very exciting story because this is a 21st century disease. It was really proposed in 2003 by a Japanese group who was looking at a type of autoimmune pancreatitis. And it's ultimately is always a clinical pathologic diagnosis that has this characteristic histopathology of lymphoplasmacytic infiltration with predominant IgG4 cells, as you see over here, IgG4 cell predominating. Storiform fibrosis, and the word storia is a Latin word for a woven mat. So you can see these woven strands of fibrosis in between inflammation, and obliterative phlebitis, as you see in the the right lower corner here. And so why is it important? Well, it is a unifying diagnosis for a multifocal fibroinflammatory disease in multiple different organ systems that previously was seen by specialists in different areas, like type 1 autoimmune pancreatitis, retroperitoneal fibrosis, formerly known as Ormond syndrome, renal thyroiditis, chronic dacryoadenitis, sclerosing orbital pseudotumor, Mikulicz disease, which is a combination of lacrimal and salivary gland fibroinflammation, Kuttner's tumor of a submandibular gland, hypertrophic pachymeningitis. And it enters the differential of other forms of inflammation, vasculitides, granulomatous disorders, hematopoietic disorders, but there's specific treatment that's usually effective. And so we see a lot of, 20-25% of these patients present in an orbital area, and they can have dacryoadenitis, periorbital swelling, ptosis, as you can see. You'll see on MRI, you can see, a lot of orbital congestion. Sometimes the extraocular muscles are very involved. And then often you will see adjacent compartments involved, such as you see over here in the top picture, the pituitary, the cavernous sinus. What you're seeing on the bottom picture is actually involvement of the trigeminal branches. And that's a big radiological clue. This is the infraorbital nerve. Normally, we hardly ever see it. And here, this is also the infraorbital nerve. This is V3 branch here. These nerves are massive, often with very few symptoms, but that's a very important clue. And then the bigger picture here is that, as I mentioned, the skull base is a hotbed for systemic disease. And for each one of the areas that are highlighted here, but of neuro-ophthalmic interest, the orbit, cavernous sinus, the sellar area, we deal with a lot of focal disorders that are idiopathic and inflammatory, but there's always a differential diagnosis of systemic disease, and there's a lot of overlap. Sarcoid, IgG4, ANCA, you're going to see in a lot of these areas. All right, let me show you one more case that I entitled here, Not All That Glitters is Gold. A 74-year-old man with headaches, malaise, and left eye vision loss. So 3 months prior to presentation, he developed fatigue and dyspnea on exertion and a constant non-productive cough, as well as night sweats and anorexia, and then he had a 30-pound weight loss in 2 months. A month prior to coming in, he sneezed and briefly lost vision in the left eye for a few seconds. And on the day of presentation, he woke up blind in the left eye, but the vision gradually improved over the day. He was also complaining of a generalized headache, no specifically eye pain, and hand and foot numbness, left greater than right. He had a past medical history of COPD, pulmonary fibrosis, smoking, asbestos exposure, hypertension, dyslipidemia, coronary artery disease, a myocardial infarct, osteoarthritis, and melanoma removed from the cheek, as well as multiple basal cell cancers. On exam, his vision was 20/15, very good in both eyes, but he had decreased color vision in the left eye with a relative afferent pupillary defect. And on visual fields, you see that the left eye has a more prominent defect. The right eye may not be completely normal either, but it is probably a left inferior arcuate defect that will be localizing to the optic nerve. And this is his fundus picture from that initial presentation, which we felt was relatively unrevealing, maybe a suggestion of temporal pallor of the left optic disc. The general exam is notable for non-tender but also non-palpable temporal arteries. He also had thrush. He had bibasilar inspiratory crackles of the lungs and clubbing, as well as pitting edema of the ankles. And then he had decreased sensation in the bilateral median nerve distribution on neurological exam. So again, I'm going to open it up for discussion.
So just to summarize, so this is a slightly older gentleman, vision loss, but then a whole host of systemic features, including night sweats and weight loss. And so that points more towards a systemic etiology, just to sort of broadly differentiate. So obviously we would want to get imaging and then get a detailed blood workup. I just wanted to add, for those of us in India, the first thing we would think of here was tuberculosis. I know it's probably not the commonest and not the top in your differentials in the United States, but yeah, so that's where I would begin.
Yeah, very good. Any other comments, or should I? Maybe I'll leave those comments for the end here again. So he had a number of studies performed. And so he initially he presented through a pulmonary clinic and a referral. So, but his labs were notable for an elevation of the inflammatory markers, quite high, both the C-reactive protein and the SED rate, and the platelet count was also elevated. He had a mildly elevated ANA with negative rheumatoid factor, and then he actually did have tuberculosis testing. I didn't mention here, but that was negative. I mean, we'd also thought about that. He came with pulmonary function that showed a restrictive and non-obstructive pattern, and a CT chest showing small, moderate bullet throughout upper lungs and heavy interstitial density, consistent with very, very severe chronic interstitial lung disease. So I have a picture here. And I don't think you have to be a lung doctor to realize that this is a wildly abnormal lung CT. Now, of course, he did come with his history of COPD, smoking, and asbestos exposure previously. You know, we also thought along those lines of inflammatory systemic disease. So because he had headaches, vision loss, and these high inflammatory markers, we went to for a temporal artery biopsy in this case. And so what you see here is that there is active arteritis of a main temporal artery in infiltrate lymphohistiocytic picture with focal granulomas and giant cells. But then the little branch arteries around the artery, so these are the vasa vasorum, were also inflamed and showed fibrinoid necrosis and a luminal thrombus in some of the branch arteries. That is a bit of an atypical picture for giant cell arteritis. And then there were some other pictures, things that we thought were a little bit unusual for giant cell arteritis, such as a suggestion of neuropathy that he had on exam. So an additional test was performed here, and his ANCA was positive. So the point here is, so this is in this case, it's the ANCA-associated vasculitis causing a temporal arteritis syndrome, worsening of his chronic interstitial lung disease, and a mononeuritis multiplex. And so, yes, this patient presented as a temporal arteritis, but it did not end up being the clinical pathologic diagnosis of giant cell arteritis. So I think it's important to make that distinction sometimes. We sometimes forget about that. So GCA is a clinical pathologic diagnosis, and temporal arteritis is a clinical syndrome. And any of these primary systemic necrotizing vascularities can affect any artery. So sometimes you will find them on the temporal artery biopsy. So you'll see, you can have, you know, cryo, you can have lupus vasculitis, other ones. You can have secondary vascularities associated with infection and non-vascular vascular disorders. So for instance, here's a patient I saw recently. This is a 61-year-old man who had a prior history of a heart transplant, presented with headache, temporal tenderness, and jaw claudication. And this is his temporal artery biopsy. It's non-inflamed. It stains positive Congo red. And then there's he has apple green birefringence. So this is amyloidosis of a temporal artery, causing his temporal artery syndrome. This is a patient that was reported by the Colorado group that had a ischemic optic neuropathy and had you know, inflammation of the temporal artery, but you know, it was really sort of sparing the media and was sparing the elastic sorts of areas that you normally see involved in giant cell arteritis, and was more involving the intima adventitia, and they stained it for zoster, and so this was a zoster affecting the temporal artery, causing temporal arteritis syndrome. Here's another case that I saw as a fellow, a 57-year-old woman who presented with fatigue, sweats, weight loss, headaches, and skin lesion. You can see here her temporal artery that was inflamed, and this was IgG4 related disease. So we are, you know, I think the teaching point, the big teaching point overall is that we always have to be aware of the level of certainty that we're dealing with in our diagnosis. Are we dealing with a clinical syndrome, or do we have the certainty of a clinical pathologic diagnosis? Because for each one of these, you know, clinical syndromes, you know, there's going to be a true clinical pathologic diagnosis. If you haven't reached that level of certainty, you can be misled. And, you know, the temporal artery biopsy is, I think, is always useful. Even if it doesn't show classic GCA, sometimes it shows other things, and that can change the differential too.
Thank you. I think they're extremely interesting cases, all three. If you could just expand a little bit, and I think there's some discussion on the chat box as well about the biopsy findings and how that would differentiate between classic GCA versus the other vasculitic pathologies.
Yeah, so in this case, you can have a granulomatous picture that will be caused by things that other than a giant cell arteritis. So it is a granulomatous inflammation. You can see there's a giant cell here, for instance, in the corner. But it will be very unusual to see true fibrinoid necrosis and in run-of-the-mill GCA. I'm not saying it never occurs. Also, there's a literature on if a branch arteries are involved, if a vasa vasorum involved, that is less likely to be giant cell arteritis, which is we classify usually as a large to medium vessel vasculitis. So, but typically it's a large vessel vasculitis. So if you have a more promiscuous involvement of vessels of different sizes, that also might take you away from this being a classic giant cell arteritis case. But then I think it's also important to put the whole picture clinically together. And giant cell arteritis very rarely cause peripheral neuropathy, for instance. And it can actually cause a cough. It is not uncommon for GCA patients to have a non-productive chronic cough, but it shouldn't really produce interstitial lung disease. This patient actually had a lung biopsy as well that showed a granulomatous inflammation with giant cells, and that's probably what causes functional decline.
Could I just make a statement? I mentioned this in the chat. I think this is the picture on the right is a great example of the minor inflammation around the small vasa vasorum that you can see in the upper left. That we see all the time in temporal artery biopsies, and that's just from the surgery itself. So that means nothing, but you wouldn't expect the larger vessel with the fibrinoid necrosis, which tells you that that's not typical temporal arteritis.
Thank you, Dr. Miller. So I think the overall message I wanted to send is we keep learning about new associations, but ultimately this is an area of the body where we see a lot of systemic stuff going on. I think of it as like if you take the hedge at the edge of a forest, so you have a field and a forest. You have some species of birds in the forest, some species that are in the plain, but you're going to have a highest density of species at the edge of between these two areas. So I think in the skull-base area where we have an interaction between the nervous system, the eye, and then the aerodigestive system in the skin, we see a large number of pathologies.
Yeah, very, very interesting cases, Dr. Bart. In the last case, so if we now try to correlate as a message for all of us in the audience, how does the systemic correlation, like looking at the lung picture, would you go ahead and do something more earlier in such a patient that would give us some more clues to establishing the diagnosis?
Yeah, I think that it would take a multidisciplinary approach to if a patient comes in, they're having, in nerve pain, they're having trouble breathing, all these sort of things. But I mean, the first thing is to be aware of those things, and if it's not quite right, then ask more questions, and then if you then send them to the right colleagues to identify some of these things. In this case, the treatment would be different. So for ANCA-associated vasculitis, the treatment would be an induction protocol, which would either involve cyclophosphamide or rituximab. Rituximab was chosen in this case. Those would not be the treatment of choice for giant cell arteritis, which we would treat with steroids, maybe with addition of tocilizumab, IL-6 inhibitor. So it makes it actually, in terms of treating the patient correctly, it makes a big difference.
Thank you. And as regards the first case, that was also very interesting. So I would like to ask the other panelists and speakers how often they see something like emoji presenting with a significant inflammation apart from the optic nerve? You yourself said, Dr. Bart, that you have seen 3 cases like that.
Yeah, we recently published a case where it initially presented as a trigeminal pain syndrome and actually had full workup, including MRI and various things, and the optic nerve orbital involvement was delayed by over a week.
Yeah, so I had a very similar question. Like, in fact, if I would see the kind of clinical presentation for first case, I would think on the line of, IgG related disease rather than, the MOG antibody disease. Because, the orbital fat component, extraocular muscle involvement are very classical. But, what made you think, it is the MOG as a primary differential rather than, the routine presentation of IgG disease in the first case, Dr. Bart?
Yes, I should say that the reason I was involved is because I work very closely with our IgG4 group. And John Stone, who's the head of rheumatology here at Mass General, he's a world authority in IgG4 related disease. He consulted on the case on the floor and then brought me in. And we both opined unanimously that this should be IgG4 related disease with all the lacrimal gland inflammation. And the first study we asked for was the lacrimal gland biopsy, because that would be a high yield. That's one of the most commonly involved organs. So you're absolutely right. I think IgG4 was the strong differential diagnosis, we just a large workup in terms of antibodies was sent here, and the MOG came in as a little bit of a surprise. Okay. But then, the very quick response to steroids in terms of reduction of apoptosis and all those sort of things, I think confirmed this diagnosis clinically. The question for me is, why can MOG behave like this? And I don't know that I fully understand the answer to that, but we think that it's a pathogenic antibody that affects the outer myelin sheath. And maybe the fact that it is more outer as opposed to more internal inflammation of a parenchyma of the optic nerve can sometimes lead to a more prominent inflammation around the optic nerve. So we know that, optic perineuritis is much more common in MOG optic neuritis than it is in multiple sclerosis or even aquaporin 4 related disease. And so I think in some of the very fulminant cases, that just spills over in a non-specific fashion, and maybe the whole orbit gets inflamed secondarily. I don't know that there's MOG antibodies that are actually inflaming, the lacrimal gland or the muscle itself. I think this is probably where the center of the inflammation is. It would be my hypothesis.
Can I ask you, did the inflammation go away in the repeat MRI scan after treatment?
Yes, it was. It all resolved. Yes.
Yeah, this is John. I agree with Bart. We've seen some rare cases of this as well, and I agree. I think it's just so much inflammation around the optic nerve, the perineural sheath, and that just kind of spills over. And I think what's interesting, we've seen so many MOG cases, and they're all kind of acting differently. I think the spectrum of what we know as MOG-associated disorder is going to expand now that we've got a biomarker for it. Just like with aquaporin 4 NMO, our understanding of NMO spectrum disorder has greatly expanded. Now we know 10 to 20% of patients have Ehlers-Danlos syndrome. For MOGAD, we're going to continue to have new phenotypes, and we're just going to have to rely on a fairly specific biomarker. But I agree. This is, I think, 1 to 1,000 is about as high of a titer as you get with MOG, and we've had similar scenarios, and the response to steroids, it all matches.
John, can I ask you the specificity? So if you had a lot of inflammation in the nerve sheath or the nerve, do you ever see disorders that are not MOG that have MOG positive antibodies?
That's a good question, Mark. So the question is, if you have enough inflammation, can you just get MOG antibodies non-specifically? We'll get, MOG antibodies in our cases of sarcoid and, some of these other ones, and we don't see any higher percentage of MOG antibodies, just secondary to inflammation. And then just general inflammation in the brain with our patients with NMO spectrum disorder with tons of inflammation in the brain. Sometimes we don't see MOG antibodies. So I don't think it's secondary to the amount of inflammation. The drawback, though, is the MOG antibodies are still not quite as specific as OCP4. And we're talking about 98% versus 99.8%. But that 2% difference can still make a big difference if you're just checking all comers. So we do have to be cautious about that. But the titers matter too. If you've got a 1 to 20, which is the lowest MOG positive titer, you're going to have more false positives. You've got a 1 to 1,000, it's going to be much more specific. And again, I think Bart's class cases, it's going to be a pretty good MOG case.
There's a question there. In case number 2, was the IgG4 serum positive before the biopsy?
So that's a very good question here. So it's the role of the IgG4 titers, when you're suspecting IgG4 related disease. This patient did not actually have an elevation of the IgG4. I didn't show it, but and that is not terribly unusual, especially in head and neck presentation of IgG4 related disease. It is a clinical pathologic diagnosis unit tissue. The sensitivity and the specificity of the IgG4 in the serum are not high enough to rule in or rule out IgG4 related disease. And so there is a test that has been proposed here out of Mass General, which is to do a flow cytometry of a serum for the plasmablast. And that seems to have better sensitivity, but ultimately, I think you need a tissue diagnosis because it's so treatable. In most cases, the inflammation responds very, very nicely to steroids, or if it's refractory to rituximab. But you then have to treat people for years with rituximab to subject somebody to that. I think you need to have a tissue confirmation. I will say that if the titers were positive, then you can follow them over time. They're a good marker of whether the disease is active. But if they're not negative, that should not discourage you.
I think that was very interesting discussion. Very, very interesting cases, Dr. Bart. Thank you very much. And I think we'll have some more questions coming in the chat. We'll keep on posing there. Thank you very much. Dr. Preeti, we will move ahead and we'll invite Dr. Patel.
Yeah, I'm just trying to share my screen here. So the next speaker this evening will be Dr. Vivek Patel. He's the Director of Neuro-ophthalmology and the Adult Strabismus Service at USC, that's University of South California. He has done part of his education in Canada and then his residency at McGill University and in Neuro-ophthalmology fellowship also at USC. He's extremely fond of teaching and very active in research as well. His areas of interest are the structural and functional changes in the visual pathway after retinal and optic nerve injury. And he's part of an NIH-funded study on this. So Dr. Patel, if you could please go ahead.
Thank you very much. I'll just get onto my screen here. Real pleasure to be here. Thank you for this invitation and be among so many distinguished speakers. Can everyone see my presentation there?
Yes.
Okay, good. Great. So I was asked to speak about a topic where obviously involves intracranial pressure, but slightly different than what we're used to seeing in our neuro-ophthalmology clinics, but of course important when there are ophthalmic features. So case one is going to be 2 cases, and I'll come back to the discussion. So please interrupt me at any point if there's any questions you'd like to ask. But the first one was a 43-year-old woman in 2016 first presented with headaches, gait instability, and a little bit of falling to her right, oscillopsia, as well as dizziness. So this provoked a MRI scan, and you can see that on the left image there's a large cerebellopontine angle with extension into the internal auditory meatus, as well as compression of the ipsilateral brainstem. And you can see a couple of cuts upward. You can see the compression of the brainstem here, specifically at the pontomesencephalic junction, probably interrupting nerves as they cross around. So she had a surgery, and again, you would expect a very large tumor. This was known as an acoustic schwannoma, and it was a Coues grade 4, WHO grade 1 on histopathology. For those that aren't familiar with it, Coues 4 is essentially a acoustic schwannoma that is coming from the auditory meatus, but extending and compressing upon the brainstem. So when it compresses the brainstem, then you know it calls the Coues 4. So it's obviously very large, and she underwent a translabyrinthine and transcochlear approach for resection. She did have a subsequent CSF leak, which required repair, but there was fairly good debulking of the tumor, and you can see much smaller tumor postoperatively. And you can imagine, because the fourth nerve would come through this area, although very good debulking in that region, she did have a cranial nerve 4 palsy on the right side, ipsilateral trigeminal dysfunction, as well as facial nerve palsy, partial, but it was symptomatic. She had Bruns as well as torsional nystagmus, and it's not surprising she would have a Bruns nystagmus given the ipsilateral pressure on the gaze holding network on the right aspect of the brainstem. So if you can't hold gaze there, looking ipsilateral to it is going to cause a problem with holding gaze, but you'll be able to push the eyes back out, but there'll be a high amplitude, low frequency nystagmus ipsilateral to that lesion. But contralaterally, because of the vestibular imbalance, you'll have a high frequency, low amplitude nystagmus, which we can talk about later. But this was her orthoptic measurements, and what we measured was a reduction in the RSO as well as an overaction of the LIR because of its yoked muscles. And you can see that there was a fairly small but symptomatic right hypertrophy in primary position, much larger in down gaze because of the incompetence here. And as expected, there was a small amount of excycler torsion of the right fundus as well, given the weakness of the right superior oblique muscle. So how would we approach this? This is one of the first things I was going to mention, is that for incomitant vertical strabismus, it can be difficult to try to get somebody seeing single in all of their symptomatic fields of gaze. So what we did here was a resection of the inferior rectus muscle by 5 millimeters, actually took a part of it out and recessed the same muscle 7 millimeters, and essentially creating then a net recession of 2 millimeters, addressing the very small primary position deviation. If you just did a simple inferior rectus recession, you would overcompensate or overtreat and create a contralateral hypertropia, i.e. a left hypertropia. But here what we're able to do is create a small net recession, but a large total recession, therefore affecting the muscle in its maximal field of torque, which is in down gaze. And this was something initially described by Dr. Alan Scott in 1994. And I've used it many times, and it works quite well. And you can see that postoperatively, she had excellent orthophoria in primary position and a small residual deviation in down gaze, but much more binocular vision in all fields of gaze. But unfortunately, she did well for a couple of years, but she ended up having a recurrence with headaches, gait instability, and dizziness recurring. And of course, you would imagine that there probably was significant tumor enlargement. And I put them side by side. This is how it looked postoperatively in 2017. And you can see growth again, further impingement on the brainstem, and perhaps some widening within the internal auditory meatus as well. So she underwent image-guided radiotherapy, 50 fractions split over, so 50 gray split over 25 fractions. She tolerated this quite well, balance improved for the next few months, but she had significant radiological progression. It just continues to grow. Headaches actually felt better. She felt better in that regard. And from the neuro-ophthalmic examination perspective, oscillopsia was stable. She still had some features related to her Bruns and torsional nystagmus. No double vision that was particularly symptomatic, and no afferent visual changes. But obviously in July of 2020, you can see that the significant growth of the tumor, even some trapping perhaps of the fourth ventricle here, become considerably bigger than it was in September of 19. Let me just take you to how her nystagmus evolved a little bit here. This is a video showing that when I take her to the left gaze, she has a left beating nystagmus, relatively small amplitude, not that high frequency at this point, but on right gaze, you can see that there's a slightly higher amplitude, a little bit more vigorous in that field of gaze. And what was new for her is that when she looked up, she also had upbeating nystagmus, but you can see there's a little bit of left beating as well. And therefore it tends to beat to the better ear when there's a bit of a vestibular bias. So she has a gaze evoked type nystagmus at this point. with the vestibular bias because you can see how much pressure there is on the brainstem affecting the ventral tegmental tract, which goes from the superior vestibular nucleus to the inferior oblique and the superior rectus, which are your primary elevators of the eye. If that's not working and interrupted, then the eyes drift downwards and then have a fast phase upward. So essentially, she has this mixed picture of gaze evoked as well as the vestibular bias based on the directional pressure of her tumor. So as part of a complete examination, we do a dilated fundus examination, and although she was relatively asymptomatic, you can see that she's developed new disc edema. And in particular on the left side, it would be probably a freezing grade 2 on the left and a freezing grade 1 on the right side. But her visual fields are fairly good. Didn't seem much really that was of concern at this point. But of course, the new disc edema was important to recognize in this situation. And if you look back at the scans, I saw her in August. That's the visual field and the disc edema is from August. But if I look back at the July 2020 scan, you can see that there's enlargement of the lateral ventricle here. In particular, the anterior horns look wider than they did in September. And the occipital horns are also wider than they were in September. And you can see here at the level of the lower part of the third ventricle, just superior to the optic recess, you can see in between the two hypothalami, you can see widening of that recess compared to before as well. So you can see elements of lateral as well as third ventricular hydrocephalus that are developing at this point. And perhaps better seen on the sagittal section, you can see in September of 2019, the cerebral aqueduct looked fairly open. You can see a little sliver of hypointensity that allows for fluid passage through. But in July of 2020, perhaps because of the edema within the brainstem, you can see that it's relatively flattening there. With bowing anteriorly of the lamina terminalis here, not seen previously, as well as thinning out somewhat of the corpus callosum and enlargement of the lateral ventricle as well. So fairly convincing that we have a situation here where we're trapping CSF in this situation. So I followed her very closely at this point. Perhaps her blind spot enlarged a little bit on the left eye. This, I think, was mostly due to the corneal defects. She's a school teacher and back on Zoom for her kids. And I think her cornea was more irritated on that side than before, but not looking like an optic neuropathy at this point. But on OCT, you can see that in between those 3 weeks, of course, she was thickened bilaterally 158 microns initially, 173. So supportive of the fact that the blind spot was getting a little bit larger, but relatively mild but new papilledema. So what do we have? Her current status is, tumor growth, obviously, stable cranial nerve and vestibular deficits. She has new papilledema, what we think is due to obstructive hydrocephalus, but fortunately no signs of optic neuropathy at this point. So I come back to this, but our primary management discussion is, do you address the growing tumor if you can? There's medical, surgical, and radiation approaches. Or do we address the ICP elevation? Of course, both. If you can achieve ICP regulation via tumor reduction, then of course we go in that direction. But we have medical and surgical options as well for ICP lowering if needed. So that's the part of this sort of discussion that I'd like to get into. Case 2 is a little faster, but also very important, shows a different aspect of hydrocephalus. He's a 56-year-old man, right-handed professional writer. In January of 2020, he first starts noticing pinwheeling sensations or scintillations in the left temporal visual field of his left eye. But his primary complaint really was what he called horizontal double vision, which was worse when he moved his eyes. And you can see here on the MRI that he gets pretty much within a week of these symptoms because they were new and troublesome. You can see right here, there is a rim-enhancing, centrally necrotic hypointense lesion, very large, abutting the posterior aspect of the right splenium and sitting really at the intersection of the parietal, occipital, and temporal lobes. It's a very large area, very large lesion in the sort of the association visual cortices. So of course, the suspicion was of a GBM in this situation, given the imaging characteristics. And a few days later had a gross total resection. And that unfortunately portends a few more worrisome prognostic features. Is IDH wild type mutation is essentially this isocitrate dehydrogenase enzyme that's looked for on the biopsy specimen. And the mutated forms of IDH tend to have a better prognosis, whereas the wild type tend to have worse. And if the MGMT, which is methylguanine methyltransferase gene promoter on the lesion, is unmethylated, this tends to also be a poorer prognostic sign because they tend to respond worse to alkylating agents such as temozolomide. So if you're going to have a GBM, you want to have an IDH mutated type, as well as methylated MGMT gene promoter region a little bit better prognosis, but he had the worst prognostic features in this situation. So then he has intensity modulated radiotherapy, 30 fractions delivering between 50 and 60 gray, and immediately started in temozolomide and Optune. For those of you who may not be familiar with Optune, Optune is a device that's worn on the head, which delivers tumor treating elective fields, which are thought to work synergistically with the temozolomide to help control the tumor. So by the time he saw me for the first time in March of 2020, he had completed the first of 3 cycles of temozolomide. So at my examination, his VA was 6.6 in both eyes, normal pupils, extraocular motility is full, orthophoric in all fields of gaze. So not a real clear explanation from the motility exam for his double vision, but anterior and posterior segments were normal. And you can see, of course, not unexpected, given the location of that lesion, you see a partial left inferior homonymous quadrantinopia that is beginning at this point. So what to make of his double vision? As I mentioned, no cerebellar, brainstem, or orbital abnormalities that I could see. He did have saccadic pursuit in all direction. Perhaps I could be convinced that it was a little bit greater to the right, but it may be just based on some preparation bias. But he clearly did have a monocular and binocular diplopia that was worse when he tracked, and it did not improve with pinhole. So in the context of this cortical lesion, really seemed most consistent with a visual perseveration disorder, i.e. cerebral polyopia or palinoptic polyopia, which you can think of as the perseverated and the real imaging coexisting in space and time as he's tracking along. Be interested to get people's thoughts on that, but that's kind of the thing I thought, is he registering the image just seen, and then when he's moving along, he's not allowing the old image to extinguish and then seeing the new one at the same time, creating this spatial perseveration, which is sort of in the context of cerebral polyopia. So by June of 2020, he had completed 2 rounds of temozolomide, maintains his double vision, and of course, shows some mild progression of his visual field loss in the same territory, but overall stable. And this is a postoperative image in June. You can see that fluffy, hyper-intense mass extending superiorly or anteriorly, extending into the splenium as well. And you can see here that there is some infiltration of the tumor within the splenium along the corpus callosum as well as the fornicel columns. Really no suggestion of hydrocephalus or so forth at this point. So 6 weeks later in July, presents at the ED with acute confusion, blank staring spells, and memory lapses. His wife took him in right away. He feels much better after an intravenous infusion of dexamethasone 10 milligrams. Feels kind of back to normal and is then discharged on oral tapering dexamethasone. And then he continues with his 3rd cycle of temozolomide. He sees me a couple of weeks later in the neuro-ophthalmology clinic, recounting to me what had happened. And he continues to feel well following the mission. He thinks I'm going to tell him things are better, although he does feel that because the double vision has got better, maybe it's because his visual field has gotten a little worse. He wasn't too surprised with that, recognizing that he understands this disease to some degree, but no headaches, no nausea. So as you can see, there is progression of the visual field from June to August in that same territory of left homonymous hemianopia, now extending superiorly as well. But of course, when you do the dilated examination, here's what you see. You see hemorrhagic papilledema bilaterally. And the optos was done despite asking for the fundus photo, but serendipitously it showed the venous congestion nicely, as well as the retinal venous congestion, as well as the hemorrhages and the whole thing. But you really can tell that there is significant disc edema in this situation, which is quite new onset, really happened within the course of a few weeks. And then if you look at the images that were done just a few days prior to that visit in mid-August with me, you can see, of course, extension of this tumor along the splenium, now expansion of this occipital horn compared to June, as well as expansion of the lateral ventricles compared to June, okay? And then when we look at the sagittal section, you can see greater infiltration of the splenium, extension more prominently into the corpus callosum and the fornicel columns on the new image as well. But still looks like the cerebral aqueduct is open. 4th ventricle looks pretty much the same as it did previously. And you can see extension, of course, here into the posterior parietal lobe, more vasogenic edema. And I would say that the lateral ventricle looks larger on the sagittal cut than it did in June as well. So you can start to see expansion of the ventricular spaces here. And the 3rd ventricle as well shows the same thing, larger and wider 3rd ventricle, larger occipital horn compared to previously. So painting the picture here, not unexpected, a couple of weeks later, he has worsening of that left-sided homonymous hemianopia because of that right occipital lesion. And then in September, in that same visit with that worsening, you can see the hemorrhages are resolving, so perhaps in a less acute phase, but still very active. As you can see, the hemorrhages and the venous congestion there. And on OCT, you can see that he continues to thicken. His RNFL continues to thicken. This is in August and this is in September. So in 3 weeks, he's continuing to move down a more severe papilledema route. So again, coming back to that same thing, the discussion of somebody who in a neuro-oncologic setting develops new onset hydrocephalus and visual manifestations, or at least ophthalmic manifestations secondary to this, how do we approach this? Of course, GBMs are easier said than done with respect to treatment, but what options do we have there? How do we address the ICP elevation if not? So this is what I'd like to sort of bring up. I took both cases to a tumor board, but perhaps this is our de facto tumor board. What would people do in terms of the audience as well as other speakers and panelists? Let me just reiterate, the first case we think is obstructive non-communicating hydrocephalus, perhaps a little bit more slowly paced and a little more chronic in terms of its development, but still worrisome in this situation. And you can see, just to reiterate that, there was pressure on the tectum, between the tectum and the tegmentum, occluding or at least blocking the cerebral aqueduct and causing expansion of the third as well as lateral ventricles. Any thoughts that anyone would have about options that we could exercise at this point?
So in the first case, you have a benign tumor that hopefully hasn't degenerated to become a sarcoma, but it's involving the brainstem now. So you have to take that tumor out and sacrifice her hearing, if she's still got hearing, and whatever else needs to sacrifice to unblock her and see what happens. She doesn't have symptomatic papilledema. Otherwise, if she had an unresectable tumor, you could do a third ventriculostomy. Of course, that would be but you probably don't need to do that. But you should, the tumor has to come out. And some of these schwannomas secrete a high amount of protein into the CSF. Sometimes the protein could be very high. So it could be a combination of things causing this besides the obstructive hydrocephalus. But I don't think, I'd be surprised if your tumor board said anything else.
Were you there, Mark? You might have been there. Yeah. So that's any other comment? I can go to where we're going. And yeah, so that was the whole point, is that what can we do for the tumor? Obviously, we can do temporizing measures like acetazolamide and so forth. I'd like to get people's thoughts on that. I have a fairly slow growing, papilledema here. Of course, there's choroid plexus in the third ventricle and the lateral ventricle, and that's where I see most of my problems. So perhaps buying a little time. There's a few reports out there where acetazolamide, if somebody responds, it could show that there may be a better response to a shunt in the future. But I really did that as a measure just to get us going and not as a definitive thing. And so the neuro-oncology team thought that perhaps considering a Avastin IV could shrink the tumor to some degree. They've had some success with aggressive tumors like this for that reason. But as you said, Mark, our main neurosurgeon who's been working and the person who does most of these acoustic schwannomas had felt that we had to discuss surgical debulking with her. She, of course, was not so excited about surgery because she's had 4 of them, right? So there was an initial event, as I mentioned, the translabyrinthine, transcochlear, that was in our institution. But prior to that, there was sort of a peek and freak kind of situation where somebody took a little nibble and came out. And then the surgeon that had to take the whole thing out left her with cranial nerve deficits and then a CSF leak. So, necessarily, but that's the next step. And as you mentioned, considering an endoscopic third ventriculostomy makes a lot of sense in this situation. If you think about the ventricular anatomy, this would be the body of the lateral ventricle, occipital horns, and the temporal horns here. And here's your third ventricle, cerebral aqueduct, and coming through here. And if you think that, okay, if we're blocked the level of the cerebral aqueduct, pressure is obviously going to build up within the third ventricle and the lateral ventricle. And basically an ETV makes a hole here in the floor of the third ventricle in between the mammillary body and the infundibular recess in that region. So that can help her. And that may be where she needs to go after we discuss the tumor options in detail. So that's kind of the hole that's been made in the base of the third ventricle. So case 2, let's discuss that. Now, this seems more of a communicating hydrocephalus situation, even though the fourth didn't look to be too enlarged. The most common form of hydrocephalus, although all forms are possible in GBM, the most common is communicating hydrocephalus. And you can imagine, as Mark alluded to, there's a lot of fibrosis of the arachnoid granulations, perhaps after the radiotherapy. There's tons of protein running around in the CSF. There could be leptomeningeal infiltration. And there's some data suggesting that if at the time of surgery there was a ventricular opening, that could lead to a higher incidence of communicating hydrocephalus as well. And I think none of us would disagree that there's a more aggressive course here, not only given the tumor subtype, but also the degree of papilledema. And just to show you there again, you can see the larger larger lateral ventricle, larger third, but the aqueduct looks open, fourth looks okay, but it may be a matter of time until that expands as well. So again, well, let me just any other thoughts with this one in the context of communicating hydrocephalus, more aggressive course, worse prognosis. There's data suggesting shunting does help these patients, even though you're not going to prolong life. Obviously, we're trying to think about how to make him least uncomfortable. Any thoughts? So again, we brought it up to tumor board, and the temozolomide clearly isn't working in this situation very well, and it wasn't that unpredictable given its unmethylated status. And so neuro-oncologists suggested another alkylating agent known as CCNU. Perhaps they may have a little bit more benefit in this situation. There's a clinical trial going on where they're looking at a vaccination protocol. This ATLDC vaccination perhaps boosts his immune system attack on the tumor itself. And you may be aware of pembrolizumab, which is a immune checkpoint inhibitor, which could help perhaps have his immune response recognize the tumor by inhibiting the PD-1 ligand. So that's an approach that's being taken here, hopefully to try to do more in that regard. And just on Friday morning here, the VP shunt was inserted. Obviously, this needs to be regulated as well, given the pace of things. So this is kind of where we're at. So I wanted to just sort of bring back home a couple of interesting parts of the neuro-ophthalmic presentation, our eventual presentation being hydrocephalus, but what got these patients in the door were some interesting neuro-ophthalmic things. We discussed that the Brunn's nystagmus is a high amplitude, low frequency ipsilateral to the lesion, high frequency, low amplitude contralateral to the lesion because of the vestibular imbalance. Incompetence strabismus can be addressed with a resection and recession of the same muscle. You could think of it as an adjustable Faden type procedure, which gives us that range, and that can be very important in terms of really making a difference for some patients. If you just address the primary position, you're really not going to help them going downstairs and so forth, and vice versa, you'll overcompensate in primary position. And I think another interesting point is that not all monocular diplopia is cringeworthy or refractive or macular in origin, although most of us will see that. And it could be due to a cortical process. And I find these fascinating. Obviously, I don't understand them that well, but there's a lot of theories as to what portends to palinopsia versus cerebral polyopia versus expansory illusory phenomenon, all of these spatial and temporal perseveration entities when these things occur in the extrastriate visual cortex. Any thoughts of that would be good. My closing comment was just to us as all ophthalmologists and perhaps neurologists as well, we play several important roles in the context of neuro-oncology. We can help identify, characterize, and manage a variety of the clinical manifestations. Here it's the visual fields, the efferent manifestations, and we're continuing to monitor for the expected and the unexpected. Not that hydrocephalus would be unexpected here, but it wasn't really consistent with her clinical course, as well as his clinical course, my second case. And we have the opportunity to communicate with a diverse team of physicians to guide our management and guide the patient's management. And we always learn a ton. As Bart mentioned, with these systemic diseases, I've learned more in trying to manage these cases than I have when we deal with our more run-of-the-mill stuff. So any comments, and thanks for the opportunity to speak to you.
Thank you, Dr. Patel. They're both very interesting cases. I just wanted to bring up in terms of also the temporal relationship. So the first one, like we said, was more slow. There was no optic neuropathy when you saw her. So how aggressive would you be in treatment as versus the second one? So again, that's I think a point that we didn't really address in terms of the time frame, considering that the second one was more aggressive.
Sure. Yeah, I think as you said, the histological subtype of the tumor is obviously more worrisome in the second one, and the overall morbidity and mortality is much greater. But for the first one, you could argue that, you know, she's likely going to have a long life. You know, it really isn't a lot of histological transformation as far as we can tell. But I feel like the papilledema, although not hitting us in the face and not causing an optic neuropathy at this point, this is only going in a bad direction. You know, I mean, obviously the tumor has gotten a lot larger. She's had a lot of surgical intervention, but I think the papilledema is just more an indicator that she's on the cusp of there being more neurological dysfunction here. And I don't think her vision is imminently threatened here. So I don't think there's a rush from the context of vision, but I think it's telling us about a bigger picture that the growth is having neurological consequences. And I think it has to be addressed, and maybe we're not as much of a rush in terms of shunting and so forth. I think an ETV would make sense if I see, you know, her in a couple of weeks and it's noticed that her papilledema is now causing, you know, arcuate field defects and so forth. But I think we have to address the tumor. And then for the second one, the real problem is that the tumor itself is relentless. And we're trying to really manage this in a more palliative sense, I think, and trying to be as respectful of his quality of life as we can, unless a miracle was to occur. But open to thoughts. I mean, I'm not in a rush to treat her papilledema, and therefore the Diamox was sort of just kind of like a make me feel better maybe situation, but I didn't think it would hurt her either.
Have you seen improvement with Diamox in these cases, or just an opportunity to buy more time?
You know, I haven't treated anybody with Diamox in hydrocephalus. I mean, I just haven't done it. And so I was just thinking that it made conceptual sense, and I did a little literature search after it, but it's an N of 1 at this point, but others may have had some experience. I know it's not conventional. He's already on Decadron. Mark, do you have any thoughts?
Case one or case two? Or
both?
Both. Oh. Yeah, I don't have any experience where it's been particularly successful. I'm sort of like, I think it's sort of like spitting into the wind when you have obstruction, you know, particularly with case one. About case one, I would say that the decision about what to do with this is sort of out of, you could, if this patient develops visual loss, of course, you become important, but otherwise, you're just telling them what they already know, and that this patient has obstructive hydrocephalus. The big thing as a neurologist is this patient's brainstem is really compromised with edema, as opposed to meningiomas, where you might push the slow growth and the tumors on the other, the pons is on the other side of the head, and the patients have no symptoms and no findings. You know, this one really over the course of several years, I guess, regrew, and it regrew into the brainstem. So, I think that needs to be attended to, because this patient, when the patient goes bad, is really going to go bad.
Right, and that's exactly what Dr. Giannatta, our neurosurgeon, thought, is that we have to discuss with her options for removal of the tumor, as reticent as she might be, because they're also worried that with the KOOS-4 classification, it's really indenting that that brainstem. Yeah. But I thought it was interesting to try to bring up another form of papilledema that we don't consider as often as we do with the other things that we see. And I don't think these were secondary to the tumor itself. Obviously, the tumor is causing a secondary problem, but the hydro itself is what's leading to the subarachnoid pressure from the ventricular system, then to the subarachnoid system, and then manifesting in the eye.
I just want to bring up one other point, just as a very important point for people to remember, that a lot of people don't remember. That is, when you do surgery in the CP angle area, any type of surgery there, you might end up with hydrocephalus or papilledema if that is the side of the dominant transverse sigmoid sinus, and that gets occluded. So if you have a hypoplastic sinus on the other side, people scratch their head, oh, I don't see much. I don't understand why the pressure's gone up. But because if you take out that dominant venous sinus, you're likely to get intracranial hypertension. So it's an important thing that unfortunately not every neurologist or neurosurgeon is cognizant of. And we've been, well, the only reason I know about it is because we were on the short end of that, 30 years ago. So you always learn from your mistakes.
Thank you. It's a great point.
Thanks, Dr. Patel and Dr. Cooper-Smith. I think this was a wonderful discussion. I think I would take as message the last slide that you kept, that we have to be cognizant of all those points and keep on monitoring that would be going for all ophthalmologists and neuro-ophthalmologists in taking care of these patients. Thank you very much once again for wonderful cases. We'll now move ahead to the last presentation, and we have Dr. Mark Cooper-Smith with us. I will begin with a very brief introduction for him. He actually, he really doesn't need a great introduction, but to do the honors, it's a privilege for me to introduce him. He is a professor of neurology, ophthalmology, neurosurgery at Mount Sinai Hospital and New York University. I'm sorry, I think the slides are there. Yeah. So he did his MD from Northwestern University, Illinois, and he did his residency in neurology and ophthalmology from NYU. He's a pioneer in the field of neuro-ophthalmology. He has over 228 peer-reviewed publications, and he has done a lot of pioneering clinical work as well as research in the field of IAH. We know about IAH treatment trial, NAION, ocular myasthenia, and imaging in the optic nerve diseases. He is also the chair of Neuro-ophthalmology Research Disease Investigator Group, the Nordic. I think it's a privilege for all of us to listen to him. And over to you, Dr. Cooper-Smith.
Okay, so someone has to allow me to share the screen. Oh, now you have. Okay, great. Okay. And okay. So now you can see my slides, right?
Yes.
As you can see from my picture, I was cooking you up a few cases there, these cases, and some of them are old. And thank you, Vivek, for at least for moving us into the field of less rare problems. And none of these issues, I'm going to discuss 3 cases, and there are about 3 cases of case management for people with ocular myasthenia gravis. Okay, so this is a completely different approach than we've heard over the last couple of days. And you know, I'm always, for those who know me, I've always been out of step with everyone else. So I apologize for that, but maybe this is just a different approach. Anyway, this case is what I call my signature case. This formed my thinking about how I approach people with ocular myasthenia 30 plus years ago. So I have this 50-year-old Asian woman, actually from mainland China. She was diagnosed by a good neurologist of having ocular myasthenia gravis when they were still doing tensilon tests, and that it reversed her ptosis and double vision with the test, and done in a conventional way. And she was given pyridostigmine and mestinon and improved her ptosis, but not her diplopia, and she had some discomfort in her abdomen. So when I saw her, she had ptosis to the top of her pupil, no fatiguing, but she was on mestinon. And she had, I should have drawn these out. It'd be nice to draw that out as patterns, because I realized I had the strabismus people on. I didn't realize there was going to be so many of the eye muscle people on. But she had underaction of inferior rectus and right lateral rectus, and underaction on the other side as well, medial rectus and up gaze. So, and she was otherwise neurologically normal. So I will toss it, and I'm going to stop on each one of these slides and say, well, what would you do? So what would someone do with the case like this who is not responding well to pyridostigmine and maybe having trouble with the higher doses? Anybody?
She needed a corticosteroid.
Okay. And remember, this case is, I said 30 years, this is 35 years ago. So that's, at that time, neurologists were pretty much treating people with ocular myasthenia just with pyridostigmine, with mestinon. And honestly, telling themselves they were getting good results. So I did, so here's again, what I did at the time, since I knew she didn't have generalized disease, and I didn't know what I didn't know at the time, I quickly induced her to 40 milligrams a day and tapered her over 5 weeks. So when I saw her back, she had no ptosis. Her ocular motility was full. She had an intermittent XT in primary gaze, but no diplopia. And I further reduced her from where she was probably on 5 milligrams a day to 5 milligrams every other day. And she went home thinking she was great, and maybe there was a communication error, but she came back 2 months later and stopped her steroids, and she had marked underaction of her medial rectus and a large exotropia and a right hypertropia. So I restarted her steroids back to 40 milligrams with again, a rapid taper to over 3 weeks. And 1 month later, on 10 milligrams a day, she had no diplopia, and her motility exam was essentially normal, but no ptosis. So I said, go to 10 every other day and come back and see me, you know, in a few months. And she showed up 2 years later. So this patient was lost to follow-up, and then she represented. She had actually very good motility off of steroids, but she had weakness in the lower face, neck, and proximal upper extremities and left proximal lower extremities. So she had generalized off of the steroids. So the case points here were, even at low dose prednisone seemed to be effective. This is what it told me then, could be effective, could control the ocular myasthenia. It raised that question in my mind whether low dose prednisone could delay or prevent myasthenia, a generalized disease. And fortunately, I was actually lucky to have not run into a problem with such a rapid induction and a rapid reduction without a recurrence. And so this set me on my pathway for the next number of years where, you know, I began to, you know, we never got a treatment trial going this, but we prospectively looked at patients and started to use a more uniform protocol, and then showing that it looked like oral prednisone in people who needed prednisone to control their ocular movements seemed to reduce the incidence of developing generalized disease from the usual 40 to 50% to about 9% after 2 years. And that hadn't been noted quite like that before, although steroids had been certainly used before. So now I have this. So I don't know if anybody wants to comment on this, but maybe we're going to talk a little bit about ocular myasthenia as a group. But now I have a 35-year-old man who's a type 1 diabetic for several years, and he presents with painless left upper lid ptosis. Didn't have it when he got up from sleep, but he developed soon after he got up, no diplopia and no common neurological problems. And when I saw him, he had left upper lid ptosis that was fatigable. It got better after rest. And after an ICE test, it also got better, back to normal. And he had normal ocular motility and no systemic neuromuscular signs on exam. As I mentioned, he was a diabetic, pretty well controlled with 2 drugs. And he was acetylcholine receptor binding antibody negative, by the way, as was the other patient. And neither had any chest abnormality seen on the chest CAT scans. So we treated him with pyridostigmine, helped his ptosis in part, but then he developed double vision within 2 weeks of my seeing him. And he now is back complaining vehemently about his problem with his double vision. Ocular motility actually had full versions, but he had a significant right hypertropia in primary and down gaze. So how do you treat this diabetic how would you guys treat him again from the panel? And someone want to suggest what to do?
Mark, if it was a long time ago, our neurologists would have treated him with Imuran. Now they probably treat him with Celcept.
Okay.
But they wouldn't use steroids.
Okay. All right. And Neil, why do you think why would they prefer Celcept to Imuran at this time?
It works a bit faster than Imuran.
Yeah. Okay. Well, we'll talk about that a little bit, but I would say this was a while ago. This case started about 10 years ago. So here's foolishness here, and we'll talk about this. I conferred with the patient and his endocrinologist, and he was going to be inpatient for use of CellCept or azathioprine. He wanted to get his double vision under control, big businessman, finance guy. And his endocrinologist says, I can control his diabetes. So we gave him prednisone. So we gave him prednisone, and of course he got normal pretty rapidly. So in a different way that I induce the cases now, I now induce them with a small dose of prednisone for over a course of at least 4 days before we go to a higher dose. And then when I saw him back, he was on 30 milligrams of prednisone and was normal oculomotor exam and no systemic problems. But he refused to take less than 20 milligrams a day, because every time he went below that, his diabetes would get out of control. I mean, his double vision would return, and his diabetes was fluctuating wildly. And he was thin, by the way, so he did a good job with his diabetes. So now what would you do? I guess CellCept, Imuran? Everyone's petered out after all of these tough cases. These are easy.
CellCept, Mark.
Okay. So again, it was a while ago, but I still like azathioprine as my primary drug for ocular myasthenia. As it turns out that there's no credible data that prospective data, except the data from Germany, from JNNP in 1996. That article, and there's no credible data on CellCept about using CellCept by itself or as an early treatment, and that's a problem for us. But we gave him CellCept, and he did quite well, and he was fine for a number of years. And here's the teaching points here for me is, patients are not customers, despite the fact what our healthcare institutions tell us these days. And there's a reason why we sit in our chairs and they sit in their chairs. And we should not provide therapies that we know have risk to them if there are alternatives. And whether I'd given them CellCept or azathioprine, that would have been the proper decision initially. Thought that he actually had quite a rapid response to the azathioprine, because within 3 months he was not symptomatic. And then here's the footnote. So here, more than 7 years after I started this, he had stopped the therapy himself for about 1.5 years, hadn't come back. But he just called, and he's having double vision for the last several months, but we haven't seen him because he's moved. So we'll probably refer him to, we'll give him to our colleagues in Boston to take care of. So interesting about 2 points about this. I don't know if anyone wants to talk about this, how we learn, how we go along here.
So Dr. Cooper-Smith, in this second patient, would you have tried something like starting steroids and starting azathioprine quite early, both concomitantly, and allowing just adequate time for azathioprine to work?
It's an interesting point. But the problem, maybe that would have avoided long-term steroid complications, but he had the short-term steroid complications of sending his type 1 diabetes out of control. And I would say, if I was faced with this again, I'd say CellCept or Imuran, I probably wouldn't give him steroids because he's a type 1 diabetic, as opposed to maybe a type 2 diabetic that had pretty good control.
Thank you. Should we go ahead and take the next piece?
Okay.
And then we open for the discussion for everyone.
Sure. So I have a 37-year-old orthopedic surgeon who presented with painless fourth nerve palsy. Saw the patient at typical findings, underaction of right superior oblique, positive head tilt tests, and blood tests, including acetylcholine receptor binding antibody, were negative. He did not improve spontaneously, and 12 days later he worsened, having ptosis of both upper lids, and he had developed right medial rectus weakness and underaction of upgaze in the left eye, as well as abduction. So, and diagnosed by Dean Sestari at Mass Eye and Ear. So, fortunately, he came back to see me, and despite my misdiagnosis, and we treated him with low dose of prednisone after an induction period, and he was controlled with no generalized disease for 5 years. And then he developed recurrent double vision that, despite my increasing his prednisone to like half starting dose to like 25 milligrams a day, he would get under control. But as soon as he got to less than 15 milligrams a day, he would have double vision that would interfere with his ability to operate as a surgeon. So here's a patient 5 years out. Now, what would you do for treatment? Okay, well, here, we went right to this. So we decided to give him some IVIG, and he tried it twice with no effect. So I'm asking for the panel's response. What is we know IVIG has been given as a rescue therapy for people with generalized disease with some success, although I don't know the numbers. How many of the panel have used IVIG to temporize or to control ocular myasthenia gravis?
Done it. It's rare, but we have done it.
But did you get a response?
Yes, in the case, 2 cases where we've used it, yes.
Yeah, I did it too. It's been
with
helpful.
Success.
Yes, not too many cases, but as Prem said, at times when there's not much else, and contraindication of steroids or lack of response, it can make a difference.
Yeah, yeah. I mean, of course, we all have a small experience because it's usually we have some recourse, but I have 4 cases and none of them have had a response. So maybe we're using the wrong stuff in New York. Could be. We're not getting the real stuff. So what would
the other problem? The other problem, Mark, is that if these patients improve with IVIG, they don't come back to us. So we only see the ones that fail and they still have double vision.
Yeah. I mean, that's true. But even if there are neurologists who say, I want to give this patient IVIG on a regular basis as their therapy. And there are some people out there that are not necessarily myasthenia experts, but they do that and say they have results. But there's no results for ocular disease. So next therapy, so he did not want azathioprine. He was nervous about the potential neoplastic side effects of long-term Imuran. But despite the fact that I think that there's some good data in MS and other studies now that show that it's probably no increased incidence of lymphoma and other disorders in patients who take azathioprine. So he was giving Celsep or mycophenolate, and interesting, he required, usually we think about 1,000 milligrams twice a day, but he required 2,500 milligrams a day. And we know that the people who use this for transplants or autoimmune responses to transplanted material, they go up to 3,000 a day. So I wasn't really afraid of the 2,500 milligrams, but it is an outlier. And so he's remained on the 2,500 milligrams and it's 4 milligrams of prednisone daily. And 5 years later, he's doing fine, and he has no important side effects. So the teaching point for this case, first, superior oblique palsy is rare, but it does occur. It's less than 1% of the cases. I look back and I have 3 cases in over 400 cases, so it's less than 1%. It's interesting that this initial case had a negative antibody, and so that didn't certainly help me point towards myasthenia gravis. And one thing that's interesting that was presented in a poster at Nanos the last time when people met with one another in place, and that is that almost 40% of the patients who have ocular myasthenia require some immunomodulatory therapy beyond low-dose prednisone for long-term control of their ocular myasthenia. So it's not a totally benign disease. So I could leave it there to have a little discussion. Then I want to show you some other materials, but talk about how people treat. This is my approach now, how I've evolved to this. I do prefer azathioprine, and I've had very good results with azathioprine following prednisone failure. That's how I use it. I have, like I said, I've had in my practice very few type 1 diabetics that I've put on this, that I put on prednisone at all. I've had some type 2 diabetics. I've had some people develop diabetes, and I've had lots of people who refuse to go off of steroids and get it elsewhere and keep taking it at higher doses. So let's like to hear from our colleagues anywhere.
Mark, I'd just sort of say that I think what I've noted over the years is that previously, a lot of the ocular myasthenics, if prednisone worked, that was fine, but if they didn't want to take it, they were willing to live with the condition. And I think now, because there are drugs like Cellcept and even rituximab, that they're more likely to sort of, when you say require immunomodulatory therapy, it's more that, well, we have this to offer, the side effects are very low, so why not go ahead, as opposed to prednisone. So I think there's a selection bias now because we have the drugs that can help them with minimal side effects.
I think that's true, and also the other thing is that maybe by introducing them to the idea that they don't have to see double, or they don't have to have an eye blocked by a ptosis, and they're getting used to functioning better on prednisone. When they fail, they said, "Oh, what's this? I don't want to live this way," because they remember that they don't have to live this way from prednisone. Maybe I were doing a disservice. There was years ago, Bob Daroff would say, and he and I would be on the other side of debating this. He says, "You don't have to treat ocular myasthenia." He says, I said, "Well, maybe that works well in Cleveland for people who walk around with one eye with a patch. It doesn't work well in New York." That was our discussion, that went back and forth.
That's exactly what we went through at that time. It was sort of like, hey, it's only ocular. They should be thankful that it's not systemic. And so, wear a patch, use a ptosis crutch, whatever.
I think this is a very interesting point, Dr. Mark and Dr. Miller. It's everywhere we face the same dilemma, but at the same time, I think I wonder, should we investigate all the patients at the presentation with only ocular and subclassify they are purely ocular, or they have already a generalized thing which is not manifesting? So how would you approach that workup? Will only a serological workup be enough? You would also do a electromyography, and majority of us everywhere are treating majority of the patients initially at the presentation with steroids to begin with, and tied over to Imuran in majority of the centers. This is what I think is the practice currently. So I think that helps a lot. But how long do you keep on Imuran is possibly a question for all of us.
Okay, so you asked several questions. So the first is the workup. So you can do eye test, of course, the blood test. And by the way, for the audience, the only diagnostic blood test is the acetylcholine receptor binding antibody. Modulating and blocking are not tests for diagnosis of myasthenia. So just, if you want to keep your costs down and you want a diagnostic test, go for the binding. Unfortunately, we know it's not a good biomarker for following progression nor treatment effect. Now, what about EMGs? There's repetitive nerve stimulation. Well, first of all, there's the neurological history and exam, which are very good. And of course, the neuromuscular experts who know more than us will ask a very detailed question. But I do think just some key questions, like the questions like we ask for giant cell arteritis. We know the right questions to ask. We ask the right questions about. So we ask about chewing, we ask about swallowing, we ask about, some of these people are older, shortness of breath. We ask about fatigue and muscles and time of day. But when you're looking at this tends to affect big muscles. So you can do a 2-minute neurological examination that tells you that you have no weakness below the orbicularis oculi, with testing the cheek muscles and neck extension and flexion, and shoulder and biceps and tricep strength and proximal lower extremity. And you pretty much got it covered with this door. So, okay, so if you send the patients for EMGs, probably 50% of them will have repetitive nerve stimulation EMGs that'll be abnormal, and a higher percent with single fiber EMGs. But single fiber EMGs are not done by every neuromuscular expert. That's a whole level of expertise above that. And there are false positives. But even if you have a positive EMG, repetitive nerve stimulation or single fiber does not tell you that you're going to develop progressive or generalized disease. And so we artificially separate ocular myasthenia into, it's only ocular versus generalized, but it's part of the same continuum. So patients are always monitored when they come back to us and ask them the systemic neurological questions and do at least a cursory neurological exam on them. And I advocate for this for the people who do strabismus and measures. You guys can handle this disease better than a general neurologist who cannot determine how much double vision they have and to what extent they have ocular misalignments that cause problems. So I encourage this to be done by either neuro-ophthalmologists, of course, when the places are not neuro-ophthalmologists, by ophthalmologists that are strabismus people or ophthalmologists who are interested in strabismus. So that's my long-winded question about that. I could leave the azathioprine. Once someone crosses over and they are failing steroids multiple times, I tend to put people on azathioprine and I tend not to take them off. But they always try to continually monitor them and try to monitor them to get to the lowest dose possible that keeps them from developing symptoms. So this fellow, this case 2, he's a little bit difficult, as you can tell, to manage as a person. So he went off it himself, and so a year and a half later, he's going to be back with double vision. So I find that remissions in myasthenia can occur, probably a little less than 5%. But a durable remission is much less common in someone who's had protracted disease. So I don't know, Neil or Vivek or others or Prem, you guys, or other people from India want to chime in and tell me. That's my experience.
Hi, Dr. Cooper Smith. I think I would treat in a very similar fashion, what you had considered, but looking at, the cost-effective way of treating, I would treat this group of patients with Azuran over a period of 6 months. And as we know, after 6 months, probably it gives a kicks off, right? So it gives a kick off to get really its actual effect. And then I would, in fact, further lower down, the steroid doses, even from 10 milligram per day to 2.5 to 5 milligram every alternate day, whether it is diabetic or non-diabetic. Even if it is diabetic, it would help you, to further low down the steroid doses to 2.5 milligram per alternate day if we put on Azuran. I think the Azuran in my own practice has shown very good results.
Yes, Umapati.
Okay, I just want to make, I agree with everything that Dr. Cooper-Smith said about using steroids, and then I just want to make a comment about the associated conditions. I think most people are familiar that if the antibody is positive, we tend to, even if it's just ocular, if the antibody is positive, we thymectomize the patient. In antibody negative, we only thymectomize when there is obvious swelling, and we can't rule out thymoma. I think everyone is familiar with thyroid abnormalities, but I think one of the things that is not well appreciated, which I'm appreciating more and more nowadays, is sleep apnea. So screen for sleep apnea, because this is one of the things that makes myasthenia worse, and they're evil cousins. You know, myasthenia makes sleep apnea worse, sleep apnea makes myasthenia worse, and then after a while, it goes off in a circle, or vicious cycle. So, and sometimes it's difficult to diagnose unless we screen for it. So nowadays, I tend to screen for patients who are refractory for sleep apnea, besides the other things that I mentioned. Over.
So I'd like, in our couple minutes that remain, I want to introduce a new concept. So we just heard reference that in patients who have antibody positive ocular myasthenia might consider thymectomy. So I want to just talk for a minute about, for the ophthalmologists in the audience, the results that was published in New England Journal from our colleagues in the United States, but it was an international study funded by NIH for open chest, so sternum splitting thymectomy for generalized disease, and they finally proved that the QMG is the myasthenia score that's accepted score for clinical trials, that the thymectomy score, which that the QMG score, which is this is like golf, the higher the score you are, the worse you are, but it showed that thymectomy plus prednisone in people with generalized disease starts to significantly separate from prednisone alone by about 9 months, and persists out to 36 months. So this showed proof conclusively that thymectomy can be used for generalized disease in the group from 18 to 65 years of age. And another way to look at this was, and this is one of the outcomes that I worked with this group on, actually, when for initially when they came back for a second round for the grant, and that is they looked at prednisone doses alone, and you see that the dose of prednisone is significantly less, and there were statistics on this in the thymectomy group. So it's both the QMG score and the surrogate steroid score. Now, here's the interesting thing. Here is antibody positive, antibody negative. Well, guess what? And my myasthenia friends have heard me say this multiple times. They said, you guys are stuck in the mud, because all the studies with new drugs and thymectomy are only done in antibody positive patients. And so none of the results that have been published are transferable to antibody negative patients, because they've never included them in the studies because they're always afraid of contaminating their cohorts. So that's a big problem, because almost 50% of people with ocular myasthenia are antibody negative, at least by the commercial lab. And maybe it'll be augmented by cluster analysis, and we can talk about that some other time. And in generalized, it's probably 30%. So that's a significant number of people who are not being considered in the new therapies, whether it be thymectomy or not. In the thymectomy trial, they also showed here that looking at microRNA that has to do with immunomodulatory factors, this particular one, that Dr. Punga, I think she's from Sweden, has shown that there was also a significant, in the sub-study, a significant reduction by thymectomy. And then from the UK, Dr. Punga again analyzed people with ocular myasthenia who had not gotten immunomodulatory drugs, and found that this miRNA, which also has role in the number of immunomodulatory factors, although we don't know exactly why myasthenia, but it was predictive. Having a lower amount was predictive of developing generalized disease, or higher amount, excuse me, generalized disease. So there are biomarkers now that might be helpful to, and these are not necessarily the two, but it's just suggesting. So what we're proposing in the US with the NeuroNext, trial group is to look at both people with groups with antibody positive and antibody negative and do video assisted or robotic intervention and compare the results with tapering off prednisone in 6 months and looking at a surrogate as a phase 2 study, prednisone dosage to control ocular myasthenia, as well as this exploration for mRNA and some of the other newer ways to look at immunomodulatory effects of drugs that haven't been done in myasthenia and untreated patients. So we're going to try to extend that, but we realize we have to include the antibody negatives, or else again we'll be ignoring 40-50% of our myasthenics. So I could leave this open for discussion. This is something that we're working on now to try to get the consensus for people to do. I'm working with the people who ran the thymectomy study, fortunately, so they know a lot more about it than I do. So I welcome comments, suggestions. Everyone's tired, right? 2 days.
Dr. Cooper-Smith, I think it's a very interesting study, but expertise over here in India is not very attuned to doing it quite early. Though we have recommended patients to our CTVS colleagues, we do not get the required expertise to agreeing to do it quite early. That's the main problem.
Yeah, well, this would be research. This would be research. We're looking to change the course of the disease by trying to alter the immune system or restore the immune system back to normal by getting rid of the supposed abnormal antigens and B cell and T cells clones that are in the thymus.
Yes, that's remarkable.
Dr. Mark, did you advise thymectomy for these patients only when they are enlarged or irrespectively?
It will be irrespective of it, and that's why we're not going above 65, because they found that there's so much involution of the thymus by that time.
I think we look forward to the results.
Well, we'll let you know when we have the money in our pocket to start. Always.
Yeah. So any other quick comments from anyone on these two aspects, biomarkers and minimally invasive thymectomy study? If not, I think for summarizing for everyone, I think we are looking at a very relatively common disease that we all face, and we all agree that all these patients need a dedicated workup, early steroids or immunosuppressive as the first line therapy, and majority of the patients need it for a long time. And as neuro-ophthalmologist and pediatric ophthalmologist working in tandem with these patients, we have a lot of monitoring to do for them and help them. I think that is possibly a message that we can give to all the audience. And we look forward to the results from the biomarkers and the minimally invasive thymectomy studies. Thank you very much once again, Dr. Cooper-Smith. I think I would like to thank everybody for a wonderful evening and the last 2 days that we had of very interesting cases, starting from some of the more common situations to uncommon. I would hand over back to Dr. Satyakarna for his final comments.
Thank you, Virender. I would like to give a vote of thanks. My family has been binge watching the popular TV show Grey's Anatomy for the last couple of months. And I took a break to binge watch neuro-ophthalmology instead. I am really humbled by the fabulous support from all faculty, and a special mention for Dr. Miller for mentoring us all through the 2 days. And the overwhelming response from viewers worldwide, around 1,000 plus each day. The NOSIG members would like to express our gratitude to all the speakers, panelists, and moderators for making the discussion quite lively. And a big thanks goes to Sunilji, who monitored the technical aspects very professionally, and Ramanji for facilitating the entire event. Thank you all and have a good day and good night.
Thank you.
Thank you, everyone.
Bye-bye.
Thank you.